I hear David, but it was a talk between you two, I think.
Oh yeah, okay.
Can he try? Can he try again? Now I put my volume to maximum.
Okay, I will just cut my microphone, then you are sure that it's not mine.
Good afternoon, ladies and gentlemen, and thank you for joining this special COVID-19 marathon webinar, which we are able to deliver today, thanks to the willingness of many intensive care specialists across the world who are ready to speak to us despite their heavy work schedules and also due to the generous support of our industry partners, which has helped us to bring this live broadcast and learning opportunity to so many. Since the initial outbreak of the novel coronavirus in Wuhan, China, late last year, and the WHO declaration of this situation as a public health emergency, the lives of ordinary citizens, the responsibilities and priorities of governments, and the work of healthcare professionals across the world have all been transformed by this deadly virus. We know that people are scared as they watch the extraordinary and upsetting images on their screens and see the daily numbers of those affected and sadly dying rising steeply. We can appreciate their feeling of helplessness. Our ICUs are facing the greatest challenge of recent decades, and sadly, many health workers in the front line have also contracted the disease while trying to save the lives of others. We are, however, in this together, and we'll face this battle together. Saving lives is, as it always was, our #1 priority. We must, however, also look after our own health and well-being, and this is why it is so important that the support and the resources are in place. For this reason, the European Society of Intensive Care Medicine has been actively publishing guidelines and scientific articles, increasing public awareness and supporting its network of intensive care professionals. One way to connect everyone is through online forums like this, and the next 7 hours will be filled with back-to-back presentations and live interviews with leading international experts from China, the US, Latin America, South Africa, and Europe. They will be sharing with us latest clinical evidence, data, and best practice, and answering questions from the audience. Before we begin, I will briefly introduce myself. I am Joseph Kesicioğlu, Head of Intensive Care Medicine at the Department of Intensive Care Medicine, University Medical Center, Utrecht, and also President of the European Society of Intensive Care Medicine. It was the end of February when our President-elect and my friend Maurizio Cecconi called me on a Friday afternoon telling that something important was happening in Lombardy, Italy, with regards to COVID-19 patients. On the 5th of March, we decided to send the warning to everyone in the world, sharing the experience from Milan.
Dear friends, at this moment in time, we believe it is important to share our first impressions and what we have learned in the first 10 days of the COVID-19 outbreak. We have seen a very high number of ICU admissions, almost entirely due to severe hypoxic respiratory failure requiring mechanical ventilation. The surge can be important during an outbreak, and cluster containment has to be in place to slow down virus transmission. We are seeing a high percentage of positive cases being admitted to our intensive care units, in the range of 10% of all positive patients. We wish to convey a strong message. Get ready. We also want to share with you some key points from our experience. Get ready now, with your ICU networks, to define your contingency plan in the event of an outbreak in your community. Don't work in silo. Coordinate with your hospital management and other healthcare professionals to prepare your response. Make sure your hospital management and procurement office have a protocol in place about which personal protection equipment to stock and restock, Make sure your staff is trained in donning and doffing procedures. Use education, training, and simulation as much as possible. Identify early hospitals that can manage the initial surge in a safe way. Increase your total ICU capacity. Get ready to prepare ICU areas where to cohort COVID-19 positive patients, in every hospital if necessary. Put in place a triage protocol to identify suspected cases, test them, and direct them to the right cohort. Make sure you set clear goals for care with patients and their families early on. With our best regards.
I would now like to introduce Professor Maurizio Cecconi, who will be acting as a moderator for the sessions throughout the day. Maurizio is a full professor of anesthesia and intensive care at Humanitas Research Hospital and University in Milan, Italy, and president-elect of the European Society of Intensive Care Medicine. He will begin his mandate as president in October 2020. As the first Western country to face the COVID-19 outbreak outside of China, the world's attention and media focus has been on Italy. And Maurizio has given several interviews to the international press. He is part of the COVID-19 Lombardy ICU network, an emergency, a task force set up by the Lombardy government and local health authorities to lead the response to the outbreak. He is also co-author of the critical care utilization for the COVID-19 outbreak in Lombardy, Italy, early experience and forecast during an emergency response. Good afternoon, Maurizio. Welcome. How are you doing now?
Good afternoon, Joseph. Well, it is still tough here, but we are good, Joseph. Thank you. How are you?
Okay, well, we have started actually 1.5 weeks ago, and our patients are also indeed increasing, and we have more than doubled our ICU beds as of now.
Yeah, I think that's what we're seeing now. We do hope, and I'm sure that some of the speakers will tell more about the Italian situations later. But we do hope that we are seeing the peak coming, and finally we can start to breathe a bit, because it has been quite difficult. But anyway, since you give me the words, I would like really to thank you also as a friend, as a president, because you listened to me, to us very carefully, and we decided as ESICM to take the lead in trying to spread information and knowledge and listen to our members worldwide. So thank you for that. And I think the affection that we get from everyone and the support that we got from everyone when we started to do our first pages, blogs, and the live webinars has been so overwhelming that it's been great to see that we could prepare this live event today. And I just would like to thank our office and to thank also everyone, the technical people, everyone that has been working on this, because the world has changed. In a month, everyone is trying not to meet in person. We are trying to bring people together in a new way. The amount of work that we put together on this has been enormous. We hope it's going to work. I would like to thank the sponsors that have supported us. I would like to thank also the speakers, because everyone is really busy on the front line, and to take some time really to be able to be here, it means that every one of our teams in our hospitals today is working a little bit harder. So I would like to thank everyone on that. And also we need to remember really that if we have any technical issues, we do have a backup. So we have worked around the clock to be able to record some of the talks this morning. And so don't worry if by any chance there is a problem with any of the videos or any of the connections, you will be able to follow some material that we've prepared in the last few hours. So we want to make this interactive. Our social media team is online, ready to get questions, and Joseph, myself, and other moderators, we will be able to do that. However, before I give you the word back, Joseph, to introduce the first session, as we were discussing before this morning, I think it's important to remember that at the moment, roughly 28,000 people across the world, both young and old, have lost their lives to the virus. And also some extraordinary healthcare professionals who've been caring for patients with the virus, working on the front lines, unfortunately have not been spared. So I think we would like to ask everyone just to stop for a few seconds to remember all that have died in this struggle, the many victims, and in this moment, I would say, especially our dear colleagues and friends. We think really of those left behind, many of whom have been our patients, our healthcare professionals, our colleagues in the hospitals, our patients in our intensive care unit. So I would just like to stop for a few seconds. Okay, I think Joseph probably is now time to start with our first speaker.
Yes, thank you. Our first guest today is Dr. Janet Diaz of the World Health Organization, who is the clinical management lead for COVID-19, and she was involved in supporting various aspects of the WHO response to Ebola. She will be talking to us about the scale of the COVID-19 pandemic and the role of the WHO, and has kindly offered to take questions from the floor afterwards. Please.
Good afternoon, good morning, good evening. Many thanks. I hope you can hear me okay. It is a privilege for me to be here, and I want to thank the organizers of the conference for giving us the opportunity to present at this very important Congress. As well, I want to say thank you to all of you for the hard work that you're doing on the front line. You know, my background is as an intensivist, and so I know the difficulties and the challenges you are facing, and we are together. I want to cover 3 points in this discussion: give you a global surveillance update, discuss about the concept of operations and our approach to the COVID-19 pandemic, and discuss a bit of work about accelerating innovation. Between the 31st of December to March 26th, there was a total of 465,915 cases reported to WHO, affecting 209 countries, with a total of 21,031 deaths from 99 countries. And the top 10 countries with the highest number of cumulative cases are listed here, including China, Italy, USA, Spain, Germany, Iran, France, Switzerland, the UK, and the Republic of Korea. On a daily basis, we get the information of new confirmed cases around the world, and as of the 26th of March, you can see here, there was 40,486 new cases from 193 countries, 5 of which were just reporting their first time. Those include Belize, Dominica, Turks and Caicos Islands, Myanmar, and the Lao Democratic Republic. That day, we also saw 1,710 new deaths from 48 countries. And the countries with the highest number of new cases, similar to the list I described before, include United States, Italy, Spain, Germany, France, Iran, Switzerland, the UK, Austria, and Brazil. You see on the left is a map, a global map of the daily new confirmed cases, highlighting in the darkest colors which countries are seeing the highest numbers. This slide shows the number of confirmed cases that the IHR, so that's the International Health Regulations, that's how information WHO gets its information from member states. And here showing the epi curve over time. The highlight of this curve is that it is separated by regions of the world that the WHO uses. So at the beginning, the predominance of cases in the WIPRO region, predominantly in China. As you come to see here, you could start to see the blip of increased cases in this more orange-red area, and that represents the European region where we are today. All along, you see a small number of cases in purple. This is in the EMRO region. The yellow region starts when we start to see cases in the PAHO region, so the Americas. And you see the increase in cases over time in the yellow. And I want to highlight this green here, and you can barely see it on this graph, but these green is really the cases in Afro, so the big continent of Africa, very little reported cases over time. On the right, I want to show you a graph from the colleagues in Spain. The reason I present this graph is just to show you the rise in number of cases, because this is what many of you have been seeing in your countries, specifically in Italy, in Spain, in France, and in US, and was seen in China. So a rapid escalation of new cases every day, and at the same time reflected a rapid escalation of deaths every day. And we know in the middle between the number of cases and the deaths is a lot of intensive care bed use, a lot of patients, a lot of doctors caring for those patients, and a lot of resource use and perhaps exhaustion of resources. These two graphs give you a cumulative number of reported COVID cases per population. Again, on the left, showing you in the denser colors, the more COVID cases per population, highlighting the differences across the globe. And to the right is just a little snapshot of total tests performed per million people, again, looking at the differences in testing per population or per number of persons and the variability around the world. So of course, that raises questions as to why in Africa or sub-Saharan Africa, there is few number of cases, perhaps because the ability to test is not as robust as it can be, as it has been in other countries, for example, such as here in the Republic of Korea. So what is our concept of operations? So I think number one is the public health interventions. And I'm going to try to rapidly go through a concept of operations that focuses more on the clinical operations because of the audience that we're in. But I think from what we know of the experiences around the globe, that public health interventions are by far very important and effective to flatten the curve. And I don't have a picture of the flattened curve, but but the main points from this slide are, obviously here is introduction of the virus. Here is early detection and local transmission. And this amplification phase can take different curve designs, in the meaning that it can be very accelerated with a doubling time between 2 and 3 days, which some countries have seen, or a more delayed doubling time between 4 days, 5 days, up to 7 days, which countries have also reported when they implement public health interventions. So the containment is important, and I think everyone would agree it's the only way to delay the upsurge of patients that require acute care, hospitalization, and intensive care. So what are these public health interventions? They are to do active case finding. So for those countries that are just at the beginning, it is important to find your cases. It is important to isolate your cases. And we'll talk more what this means operationally in the next slides. It is important to test your suspect cases. And of course, this is all with the caveats that we know that there's not enough diagnostic testing to test all patients, all suspected patients everywhere at all times. But for the public health interventions to work, this is still, the best approach. And then contact tracing. And again, understanding the caveats that in certain situations, such as when there's widespread community transmission, contact tracing can be nearly impossible to do. But the public health intervention to stop transmission, as in all other outbreaks of highly infectious diseases, is to contact trace, to monitor, and in this case has the recommendation to quarantine of contacts. As public health interventions get put into place, unfortunately, the speed of the epidemic has passed from different scenarios. It passed from scenarios to countries where there's only a few countries now that have no cases. It passed to scenarios where we have one case, sporadic cases, or low number of cases and maybe small clusters. Progressed to large clusters, which rapidly progressed into widespread community transmission in certain provinces, as you've seen in northern Italy, in France, in Spain, in Iran, and US. So what does this mean for now What does it mean for the countries that are still getting ready or preparing or are in the middle of the surge? The concepts are relatively simple. We know the severity of disease by best estimates, again, and this is best estimates from the largest cohort studies from China, that the predominant majority of patients have mild disease, so 40% with mild disease, so very little needs for any acute care hospitalization. The next portion with moderate disease, meaning they probably have some radiographic infiltrates, but not severe pneumonia, so pneumonia that can likely be managed on an outpatient setting. Severe patients, which have physiological changes that require acute care intervention, such as oxygen therapy. And then the critical patients that require intensive care, commonly mechanical ventilation. So the severity of disease looks like this, but the resource requirements, which is what we're seeing in the situations when countries are in full surge, is a wide impact on the need for intensive care beds, for ventilation, for acute care with oxygen therapy. And of course, these proportions are estimates that we learned from China, but they will depend on testing. In China, where they tried to test almost everyone that had some symptoms and were suspected, although they didn't do that for the entire outbreak, but they did it for most of the outbreak. These are the proportions. If you're in a country right now where you're not able to do that testing, the denominator will be different and the proportions may look different based on the subset of patients that you are testing. So what does getting ready mean? And we've tried to kind of keep this to the basics. Some countries have more experience with outbreaks of infectious disease, and some parts of Africa actually have built up these systems robustly, even some of the most resource limited settings, because they are used to having outbreaks of infectious diseases, where our other countries, some of our countries perhaps less used to having the outbreaks of infectious disease. But what is important is screening and triage at all access points of the healthcare system. That means everyone has to be educated and know how to screen for a COVID suspect patient, and a triage system has to be in place that uses some standardized scoring system to evaluate severity of disease. That's point number one. Point number two, I think what's been most useful in this outbreak, and many countries have done this in different ways, is the COVID-19 informational line. That is important in order to direct the public, because the community needs to be educated and the community needs to know what to do, and the community needs to know that they're safe. So where should they go? Should they go based on the type of symptoms they have? Where should they go for testing, if the testing strategy is to go get tested? Or where should they go for treatment if they actually have signs of severe disease? So this information line and referral pathways have to be put into place and ready to go, including the inclusion of transfer vehicles or ambulances to transfer patients to the designated testing or treatment areas. There has to be a plan as to what are your designated COVID centers for isolation and care for mild or moderate cases that are not at high risk. Will you choose to put them at home if home is a safe place for them to be and they can be in self-isolation? Or will you choose to put them in a community facility where patients can be held together, cohorted with people with the same diagnosis, and get their 14 days there, their care there, not requiring acute inpatient hospitalization? These decisions need to be made at the national, regional, local level to decide what is the right strategic approach, but the concept needs to be put into place. Designated COVID treatment areas. Many of you, I think, work in these areas right now that are caring for the patients with severe or critical disease in intensive care or on medical wards or infectious disease wards. And part of the readiness, the last one, is make your surge plan. And I think this is where we have seen that countries taking action at the right time to surge. I bring this graph again just to show the highlight how fast the rapidity of cases can grow exponentially when public health measures are not put into place or are put into place in a slow fashion, and how many deaths can increase with that. So meaning the load of patients you'll have to manage in hospital, in intensive care, and the patients that may die. So taking actions at the right time means that the surge plans have to think about the 4 S's or the 5 S's. Structure, so that means structure and beds. And so we go back to the basics. What beds can you repurpose from your hospital wards? What hospitals can you repurpose for COVID? Do you need to build new hospitals? What kind of hospitals? Military hospitals, tent hospitals? Who's going to build this? Staff needs to be kept safe. And I think this is something that's hitting home to everyone, acknowledging the Maurizio's moment of silence for the healthcare workers that have passed. So we must focus on, if we're going to, as we're going to surge, that we must keep our healthcare workers safe, and some may be better prepared than others because they've had more training in infectious disease or infection prevention and control than others. But it is our priority to keep them safe and focus on IPC measures and workflow. And so this becomes very important, as how health workers work in the COVID unit, where they don, where they doff, put on the PPE, take off the PPE, how they wash their hands, how they come into the facility and how they leave the facility. These are all important workflow interventions that need to be done very carefully and taught to the staff. You'll have expanded staff model systems, which I know many of you are doing, which means that you'll bring in people that have little, perhaps, or no intensive care expertise to come be physician, intensive care extension providers. So we have to focus on making sure that they stay safe and that we have the optimal use of evidence-based protocols in our units. And then, as has seen in some of the countries, the use of regional extra workforces, national extra workforces, including the military, global surge workforces, such as emergency medical teams or teams from China that may now be able to have some bandwidth to come and help another country set up, augment workforce, or set up a treatment unit, or set up a hospital. NGOs, and I know many of your humanitarian organizations, such as Médecins Sans Frontières, MSF, and Delima are already helping and working here in Europe, in fact, to help surge the workforce, and WHO and its GORN partners that are also participating. Supply is a big ticket item here. So key items that need to search for care, such as PPE, oxygen in certain settings, and ventilators. And again, what is your regional, national, and global surge plans for this? And finally, I add here a word about global solidarity, the word that our Director General, Dr. Tedros, likes to use. The need to open up humanitarian corridors for the most vulnerable countries that need supplies, equipment, and human resources. And as we know, the borders closed, that means borders closed to many other things. And the importance of getting the correct supplies and staff, especially to countries that are in conflict, to refugee communities, and low-income countries scattered around sub-Saharan Africa. What about clinical care? What's our operational plan for clinical care? So going to the patient now. So we started with the operations and setting up the system. Now we're back at the patient. So how can we provide patient-centered care and evidence-based care? And evidence-based care during times of uncertainty. And why uncertainty? Because there remains many things we do not know about the disease, although many things we have learned over time. I want to thank our colleagues at this point in China and all over the world that have spent not only time taking care of patients, but also doing clinical research and trying to answer some of these unknowns and publishing excellent studies, clinical studies, observational studies, starting to publish some randomized studies in order for us to improve our knowledge base so we can improve our practice. What we do know is that older persons and those with comorbid disease, such as hypertension, diabetes, and cardiac disease, are reported to have higher risk of death, but death has also been reported in younger patients, and we need to understand that better. We know that higher levels of D-dimer and SOFA scores have been associated with higher mortality, but we need to do more analysis and investigation to see what else predicts severity and death. We seem to have reports that children and pregnant women, their disease seems to be more mild, but critical cases have been reported. And as for complications, this has been consistent, perhaps because the case definition required pneumonia at the beginning, severe pneumonia being the common case complication, sepsis, and specifically acute respiratory distress syndrome, but also reported is cardiac injury, acute kidney injury, and again, the profiles of hospitalized patients and intensive care patients needs to be better described. What is missing? We need a better understanding of pathophysiology of disease progression. What is the inflammatory pathways that are activated, the coagulation pathways that are activated? This is important work in order for us to better develop our therapeutic plans, validation of predictors of disease severity that can maybe help us with early classification of disease, how to manage patients, where to manage patients, prognosis, family discussions, end-of-life discussions. What do we know about clinical management? There are evidence-based interventions that save lives from patients with ARDS, and these should be implemented. And I know I'm speaking to the people that know this the best, but I think as a standardized approach to management of COVID patients that are in hospital with pneumonia and ARDS, the basics, and do the basics well, and do that in all countries where there are resources and where there are limited resources. So this means early triage and recognition of severe cases and close monitoring, early initiation and escalation of oxygen therapy when indicated, and close monitoring. For those that get intubated, implementation of lung protective ventilation strategies for ARDS coupled with the best practices for sedation, prevention of complication and liberation from ventilation, prone position for moderate severe ARDS patients, and fluid conservative regimens. What we don't know, efficacy and safety of high flow oxygen and non-invasive ventilation. Specifically, the concern here has been about the extent of aerosolization of virus. So of course, if used, should be used with airborne precautions, and patients monitored closely to delay and not to delay intubation when indicated. And most recently, I'm sure you've seen the videos of using ventilators for multiple persons. And is that really safe? Is that a good idea? How to do it safely, how to optimize it? You know, what are the indications to do this? These are things that we must still answer. In regards to therapeutics, again, and this I think has challenged the community more than anything, is the evidence-based during times of uncertainty. There is no known effective antiviral or adjunctive therapy as of March 26, 2020. So the WHO recommends these repurposed therapeutics that are being used to be used under ethically approved randomized controlled trials that are the best way to assess efficacy and safety. And thankfully, to many colleagues around the world and many investigators around the world, there are multiple clinical trials ongoing and multiple randomized clinical trials, which is wonderful. And we encourage those be used to test these repurposed drugs, off-label drugs, in order to get an answer. What's concerning right now is really the widespread use of off-label therapeutics globally. And this is including a tremendous amount of polypharmacy between different drugs, whose risks are unknown when given together and potentially could be harmful, and also impact supply chain for other diseases for which they are on the market for. So this is an important consideration that we ask member states to look at as states start to develop national therapeutic protocols that are not based on evidence-based medicine. If you are using these off-label therapeutics and you are unable to use it in a clinical trial, the WHO has some guidelines about the monitored emergency use of unregistered interventions that describes that these may be used, but only when RCTs cannot be quickly implemented and patients should be enrolled with informed consent, with National Ethical Review Board approval, and data be collected and analyzed on a regular basis. Accelerating innovation and research. Again, I applaud many of you probably as well that are ongoing, doing clinical trials, randomized trials for therapeutics or observational studies, collecting prospective data in order to inform our understanding of this disease and interventions that may save lives. In early January, the WHO held a global COVID research summit, which brought together many researchers to move forward on key topics. Out of that was a lot of work that has been done over time on a global COVID-19 clinical platform, which the WHO supports as a global registry for COVID-19 hospitalized patients to inform public health response. And when possible, that means when you're not so busy in the hospital, please try to contribute to this data platform. The other major push from the research group here at the WHO has been the Solidarity Trial, which is meant to be a multi-center, multi-country randomized clinical trial that launched just yesterday, I think, with its first enrollment. It is a global trial that is has multiple arms to test various therapeutics that have been prioritized by a global expert panel group. The WHO is also working on many streams of research, not to do research ourselves, but to help prioritize the research questions with the global community and then facilitate that this research gets done and published quickly and shared to inform us. And the research is not just on clinical care, which I've been discussing, but on community engagement, social sciences, ethics, data sharing, infection prevention and control, and transmission and epidemiology. Accelerating innovation is not just about research. Actually, we need to figure out how to expand our innovation in equipment, which means diagnostics and biomedical equipment. How can we use innovation to improve the supply chain models, the production, from the production side to global dissemination in an equitable fashion to countries and frontline users. So the WHO has brought together UN agencies, public and private stakeholders, humanitarian partners, and academicians to deal with the global supply chain and how to accelerate innovation and distribution. The key focuses here, as you know already, are the personal protective equipment, the oxygen, which may not be limited in some of the countries here in Europe, but for low-income countries and many of sub-Saharan countries where local production is limited, this is a major, major, major problem. Biomedical equipment, I think the ones that seem to be, that are the most obvious being ventilators and consumables related to ventilators. And then of course, diagnostics. And again, as we work to improve the supply chain and the production of these key items, knowing that all of this, if it's meant to be used in the field, has to be used with appropriate training and standard operating procedures. So with that, I highlight some of the work that WHO has done on training. And these two, I think I relate the best to the audience that we're talking of now. This will be the clinical care of severe acute respiratory infection, talking about some of the basic principles of clinical management, and the severe acute respiratory infection treatment facility design. So how to repurpose your hospital, your ward, your unit, how to build a new treatment center according to IPC, infection prevention and control, principles and appropriate ventilation principles. And here a module on infection prevention and control, again with the focus on keeping healthcare workers safe. So in conclusion, I want to thank you all for giving me this opportunity to talk with you. I want to thank you all for all your hard work on the front line. I know it's not easy. But as Dr. Tedros has repeatedly said, only together in solidarity will we as a global community save the most lives, at the same time advance the science of public health and clinical care. And our common aim is to protect our community's health and happiness all over the world. And with that, I want to thank you for your attention, and I'm happy to take any questions.
Thank you very much, Janet. Indeed, there are quite a lot of questions. I will choose some of them. One of the questions was, you mentioned the standardization, but we also know that there are lots of variation in practice with regards to isolation and quarantine. Can you comment on that, and what's the role of WHO in this?
So I think it's a very good question, and I think a lot of this is in the the meaning behind the message. So isolation, you know, the recommendation to stop transmission is if you have COVID-19 that you isolate, you do not go close to other persons. Now the mechanism that you're going to do that depends on your setting. Initially, some of our guidance said, you know, hospitalize everyone. And the reason it was like that, and I have to, you know, give a disclaimer to that, and it is true in essence, because the idea was to put people in an isolation room so that they can not infect any other. But the truth is, we know that none of our many health systems, most health systems, even the most robust health system, cannot manage to hospitalize all these patients because of the extent of numbers of patients. So then the idea becomes the isolation still has to happen, but it has to happen either at home, where you have where you instruct persons, infected persons, to self-isolate at home, and if that's possible, then that's fine, and that they're monitored, and that they have access to rapid medical advice if they, you know, have a symptom or a complication. The other option is to use a community facility, and this is like a repurposed gymnasium or a stadium or a school. And this may be better options in some communities where home isolation, because of the way communities may live, maybe too close together, too many people in one small home, then home isolation becomes impractical. So the community may, so the public health system may decide, let's make a community facility, and patients can go there and remain there. That's a similar thing to the quarantine. So the context for quarantine, you know, is this possible? But the idea there is that contacts must be monitored closely. It could be a phone monitor, it could be a WhatsApp monitor. You know, we can use technology to monitor them. And if they develop any symptoms, then test and refer to the right place. So again, so these concepts are the key concepts, and then the way you implement them or operationalize them, which is kind of why I presented this as an operational discussion. Then we need to look at the details. Where is your situation, and where is the best place to do this for your communities? Over.
Okay, I think Mauricio has a question. Mauricio?
Yeah, Janet, first of all, thank you so much. And also thank you to WHO for everything that you've been doing, because all the advice that you've been giving, I would say worldwide, has been instrumental for us, especially, I would say in Italy. For us, it became so clear from day one of the outbreak, you cannot win just in hospitals, you really have to contain the virus. So, you know, it's really an important message you give and that we followed. My question is, as an intensive care society, we are trying to support also low and middle income countries. And that's, of course, it's a big challenge there, because if we work now with limited resources in rich countries with ventilation and intensive care units, the question that I have is, what can we do for countries like Africa, continents like Africa or other countries with low resources? And I'm sure that your public health measurements are going to be very important there. What can we do as a society or as a scientists or clinicians to help you with it?
Thank you, Mauricio. I think that the challenges in the low-income countries that have much less resources, you know, maybe 2 ventilators in a hospital rather than, you know, 70, is a challenge. And from our side, what we would like is I think it's a couple of fold, Maurizio, and this is something perhaps we can, you know, further discuss, you know, with time. One thing is, I think, immediate type of peer-to-peer knowledge exchange platforms, I think, are very useful. So I think what the society is doing with its webinars, you know, speaking basic messages about, you know, good practices for oxygen, for ventilation. You know, maybe there won't be that many ventilators available, but those patients that do get them, that they get that quality ventilator management possible. So I think there's a role there for peer-to-peer knowledge exchange, information sharing from the society to those that are working in lower resource settings. The surge is a very important also operational way to share information, how you surged it. And of course the systems look different, but what your decisions were to surge, to repurpose the ward, to how you brought in new staff, how you trained the new staff. These are things that are operational issues, but may be helpful to share that experience with the doctors or the clinicians or the administrators, I guess, also in these countries. And then finally, we don't know what will happen in Africa, and we're watching the epidemiological curves there. We'll have a shortage of staff, and how we can provide more for something that WHO is looking at. And at a certain time, we hope that the pandemic subsides in Europe for teams to countries. So have been in countries that we were country into some countries in Africa that resources and additional workforce that's on a significant. So those are just, I'm open to these for collaboration with, you know, the bigger societies.
Okay, very much, especially that you have time of view. I think we'll go to the next.
And got together to share everything. So we'll be giving the medical ICU college since 2000. Postgrad president is Professor
Thanks, Maurizio, and thanks everyone for being here. In this presentation, I will give you some updates on the epidemiological situation here in Italy. That's a curiosity that I want to share with you. This is the epidemic curve of seasonal flu. And as you can see, this year, the curve is strange here in Lombardy, because after the peak, the curve doesn't follow the typical decrease, but at this point here, some weeks ago, it started not to decrease. And if you look at here, you can see that this less of decrease in the curve is due to the increase in the cases of coronavirus. This means that during at least 4 or 5 weeks before the first case was diagnosed, we had some cases of upper respiratory tract infection or atypical pneumonia that were misdiagnosed as flu, and that were probably due to the start of the spread of the coronavirus infection. So this is the situation in Italy, updated yesterday. So we are now, I think, above 80,000 cases, and with a good proportion of healthcare workers infected, and that number of associated deaths. You can see here on the left corner the distribution of age. The median age is 62, and here on the right you can see the epidemic curve with the surge in the number of cases, which is very similar to what has been shown by Professor Bindu before for Wuhan. This is the map of Italy on March 9, and this is how it looks like now. So you can see that the disease is spreading. It's spreading all over the country. Clearly, the highest number of cases, it's here in Lombardy, and Lombardy is a little bit like the Wuhan of Italy. On the right-hand side, you can see the case fatality rate and the distribution of mortality in different age classes, and you can see clearly that mortality increases sharply after the age of 70. So this is very important because you all know that everyone is saying that in Italy we have a high number of deaths. And this has been analyzed by this paper by the people of our Istituto Superiore di Sanità, which is our National Institute of Health. And they basically, when they compared the case fatality rate in Italy and in China for different age classes, they found that the case fatality rate was almost the same up to the age of 70, while it's much higher in Italy after the age of 70. So there are several things. We could discuss this for a long time, but first of all, clearly the Italian population is older than the Chinese population. So our median age is 62, while the median age in China was 46-year-old. Second, there might be issues regarding the definition of COVID-19 related deaths, but probably the most important thing, which was told also by the WHO expert, is the problem of the denominator. Because now in Italy, and especially in Lombardy, we are testing only symptomatic patients. So clearly the denominator, the population on which we calculate mortality is probably much larger than that of positive cases, because again, only symptomatic patients are now tested here. Let's come to Lombardy, which is our region, and as you know, it's been the center of the epidemic here. The first case was diagnosed on February 20. It was a previously healthy young man with an atypical pneumonia. He was admitted to the emergency department and then to the ICU of the hospital in Codogno, which is a small town south of Milan. And the day after, 36 new cases unlinked to the first patient were diagnosed. So what is very important is that our regional ICU capacity, bed capacity before the crisis was around 750 beds. It's about 2.9% of the total hospital beds. Then after the first case was diagnosed, we immediately constituted this emergency task force here in the government of the region. And we created a network of dedicated COVID-19 ICUs. We started with 15 cohorts, 15 COVID-19 ICUs in 15 hub hospitals, and we are now at something like more than 90 dedicated ICU in 70 hospitals. The ICU bed capacity has been more than doubled here in Lombardy. We have a central coordination for the allocation of the cases. The hospital network has been completely reorganized because we thought that the government of the region thought that it would be useful to centralize specific diseases like trauma, neurological emergencies, cardiological emergencies or cardiac surgery to a limited number of hubs in order to, again, centralize these diseases and to free space for new units to be converted in COVID-19 units. All surgical elective procedures have been stopped. And as you know, severe containment measures until the complete lockdown of the country have been put in place by the government of the region first and of the nation then. This is the situation here in Lombardy. In the last 5 weeks, we have treated a total of 2,600 patients, of whom 500 have been discharged, almost 700 died, and now we currently have in ICU 1,425 patients. And you can see here the incredible surge in the number of ICU beds occupied by COVID-19 patients during the days. So this is my final slide, and these are my take-home messages that are summarized, that have been also presented in a letter that together with Maurizio and Antonio Pesenti we published on the ESICM website. Clearly, when you experience an outbreak of COVID-19, you can see that there is a significant mismatch between the number of patients requiring ICU admission and the number of available ICU beds. Again, what you can do is to try to increase your ICU capacity, and what we did was to create a network of cohorted ICU to optimize patient allocation and isolation. The problem of protection of healthcare workers is extremely important because healthcare workers must have enough PPEs and they must be trained on the proper use of PPEs, and also defining protocols for triage and treatment of the patient is clearly useful. What is probably the most important message, though, is that opening new ICU beds and buying new ventilators is not the solution of the problem. I mean, this is a good solution for people who already are sick, but clearly what we all have to do is to teach the population that the most important thing is that people change their behavior, and that only with behavioral intervention, like social distancing, for example, we can stop the spread of the disease. Thank you very much.
Well, thank you, Giacomo. And actually, I see from the camera that one of the grandfather of intensive care in Italy is just getting ready for the next presentation. First of all, let me just thank you again, Giacomo, you and Antonio, because you have been tasked with an enormous effort to organize our response in Lombardy. And actually, I would like to ask you just to make a comment or maybe to specify one thing, because what I believe has been extraordinarily difficult for us was actually to wake up one day with a very specific thing, which was a cluster of secondary transmissions. I don't know if that's clear for everyone. Do you want maybe to comment on how we discovered case number 1 and why we were so nervous about it when we discovered it?
Yes, this is very interesting to know. I mean, the case number 1 was diagnosed because the anesthesiologist at the hospital in Codogno, basically not following the protocols, decided to test the patient because the patient has an history of dining with some people coming from China 3 weeks before. And so she decided to test him for coronavirus, and this is how this first case was diagnosed. What was scary is that basically the people this guy had dinner with were negative, tested negative for coronavirus, also the antibodies, also serology. So what was scary was that we were not able to detect the patient 0, but we only detected patient 1. And also, the 24 hours after the first diagnosis, we had 36 new cases who were basically not linked to the first patient. So what was clear to us was that a huge number of patients were probably infected without us to know. And this is what shows the epidemic curve of flu that I showed you. And we were scared because we knew from China that young people should be in some way protected. But this guy was very young. So we immediately realized that a huge number of infected people, also asymptomatic carriers, was probably around. So that was really scary for us. And that's why we tried to respond so quickly by creating the emergency task force.
Yeah, and I remember you were calling me. I was in Switzerland at the time giving a talk, and I remember you were calling everyone to say, we have a problem, we discovered a patient yesterday, we need to meet very quickly. I think that was very useful. If I can ask you, there are some questions. They want you to comment again on why you think the death rate between China and Italy is so different. Do you want to, you already mentioned that in your slides, but the question is coming back again. Do you want to explain it again or to give some possible explanations for it?
Yes, there are several possible explanations. The first one is certainly the age of the population. I mean, Italian population is older than Chinese population. And as we have seen, both in Italy and China, mortality, case fatality rate better, increases sharply after the age of 70. But we have more patients after the age of 70 compared to China. Indeed, case fatality rate in the other age groups is basically the same in China and Italy. Second point is that if you compute absolute mortality as a percentage of the positive cases, you have to take into account the fact that the denominator is completely different, because we are now not testing asymptomatic patients, for example, asymptomatic contacts of cases. So what I expect is that the population of infected patients is much larger than what we find. To give you an idea, the percentage of positive tests here in Lombardy now is around 50%. And in some areas, for example, in Bergamo and Brescia, is 72%, while in other regions, it doesn't reach 10% of the total number of swabs performed. And then the third point is that the definition of COVID-19 related deaths, because especially at the beginning of the epidemic, some people were dying for other causes, but they came from the red zones, so they were tested even post-mortem for COVID-19. They tested positive, and those deaths were attributed to COVID-19. I mean, someone says that some people didn't die for COVID-19, but they died with COVID-19. But to be honest, there is also the case of now, for example, in the region of Bergamo, of people who die at home who are not tested. So the issue of mortality is quite is a little bit difficult to but I'm pretty sure that the denominator is an issue, and the age of the population is an issue too.
So Giacomo, I think you mentioned we treated something like 2,500 intubated patients, but probably we've treated also an equal amount of non-invasive ventilated patients. I suspect we've increased our respiratory support probably 4 or 5 times compared to our baseline. What has worked well, do you think, in Lombardy, and what do you think maybe has not worked so well? What would you do differently if you can go back to 6 weeks ago?
What worked well was that we started the response very quickly, thanks, for example, to Professor Pesenti, who was very active on that. I think that we had a very good collaboration between the centers. So everyone was contributing and is making a huge effort to fight the disease and to control the spread of the disease. And also, I have to say that working here at the government of the region, I have to say that all the bureaucracy that we are used to face every day, like immediately disappeared. So I have to say that the economical and administrative bureaucratic constraints are now much lower than in the usual situation. So this, I think, worked quite well, and also the idea of having a central coordination, especially at the beginning, worked well, because we knew for every critical patient his conditions, and so we tried to allocate every patient to the centers with experience or centers where free beds were available. One of the main problems we had, I think, was the diagnostic capacity. At the beginning, maybe because we started to do an aggressive contact tracing at the beginning, a huge number of swabs was performed, and so many patients had to wait for a long period of time to have the results of the swab. And those patients are a problem because you don't know where to put them. You cannot put them into the COVID-19 units because if they are negative, they could get the disease, but you cannot even put them in the clean ICUs.
Yeah, because that was we were always working on two principles, Giacomo, that you mentioned very well, and I think the WHO message was there. You must increase capacity, but you need to work on containment. You cannot afford your hospital to become a cluster. So I think your point about the labs is very important. I think Professor Bindu may be online on the phone. Professor Bindu, are you there? It seems we're still having some connection, so I still would like you to maybe to mention one very last thing. We've been trying to work on some papers together. It's not been easy because we're overwhelmed by this. We see a lot of the community, not just in Italy, but everywhere, trying to share data and trying to do some science on it. What do you think? What do you think about this, and how do you think we can progress together, not just in Italy, but maybe linking with other scientific networks and so on?
Well, I think that despite the incredible amount of patients people have to take care of, which I would say overwhelming amount of patients, I think that doing every effort to collect the data and to share them with the scientific community is extremely important, not only from the scientific point of view, clearly, but also for the preparedness of the different health systems in different countries. And I'm sure that the papers that we have published and we are publishing will help other people to, again, to prepare themselves to contain the outbreak as soon as it reaches the other countries. So publishing data and doing research is extremely important. Despite, I mean, it's very tough in these days and this situation to find the time to do it. But again, if you, thanks to the collaboration of everyone and thanks to the help of many people around, we have been able to collect, I think, some good data, and I will show some of them in the next presentation.
Okay, I don't think we've been able to connect to China. I had a call actually with some doctors from Wuhan, So even if I'm not talking by first hand, I'm just reporting some information, but just to say there is some hope, because after the surge and after the the outbreak and the peak in Wuhan, now they are not reporting any more new cases. And when we talk with the doctors there in the hospitals, they are finally able to start back to go back and restart the economy, to restart a kind of a normal life in the hospital. So I think we need to learn from China. We learn a lot from them, but I would also like to say we need to also to bring a message of hope from everyone, because our Chinese colleagues are also telling us that you can control, you can slow down the virus. Of course, they are very worried now to see what's going to happen when they reopen a bit, but I think we see some positives also from their experience too. Okay. I think there is one question that I get, and then probably we should try to move on to the next session. What would you prefer, since in Italy we're using a lot of this, between non-invasive ventilation and CPAP or high-flow nasal cannulas? Your audio is going, I think, Giacomo?
Sorry. Yeah, sorry. I just turned off the microphone by mistake. So I'm saying that in Italy, as you know, we are all passionate of the helmet. So even in peace times, we would answer this question with, we prefer free flow CPAP, especially for hypoxemic patients. So, and in this case, I think that the helmet, since you can also put proper antiviral filters, can help you to assist the patient, because it provides a known FiO2, which can be even 100%. It provides a certain amount of PEEP, quite stable, and it also helps to contain the disease, because I know you know that with face mask or with high flow nasal cannula, probably the risk of the spread of the virus around is certainly higher than the helmet. So our first choice is the helmet, and I can tell you that we did, like, we are now doing a research on that, but trying to quantify the number of patients on CPAP around. But what I know is that we did the first very rough estimate that when we had 1,200 patients in the ICU, there were about 2,000, 2,200 patients on CPAP in the wards in the hospitals in Lombardy.
Yes, yeah, I do remember. Anyway, I think it's probably time to move to the next session. So I would like to thank you, Giacomo, also Antonio, again for your leadership in this. And I'm sure that we have some time to ask you questions, because you are staying for the next session. So if there are some more questions coming through, you will be able to answer them during your next presentation. Okay. In the next half an hour. So thank you, everyone.
Thanks, Maurizio. Thanks.
Bye, Maurizio.
We move to the other room. Rest of this.
Hello,
Good
everybody.
afternoon, everybody. Welcome to this part dedicated to the clinical picture and the outcome data. Today we have two distinguished speakers. The first speakers that will dedicate to the clinical picture cases will be Antonio Pesenti. Antonio Pesenti is at present the coordinator, the national coordinator and the Lombardy coordinator for the emergencies. And he is gonna just describe the clinical picture of the numerous cases that have been presented in Lombardy. And together with him, there is also Giacomo Grasselli, who will co-work with him in presenting the data.
Hello,
Antonio?
everybody. I am Antonio Pesenti, and I welcome you all to this discussion. I think the clinical picture of COVID is more complex than we thought it was. And I'd like to thank European Society of Intensive Care Medicine giving us this opportunity to discuss this important topic. It's important to remember that COVID is not just a kind of viral pneumonia. It's much more than that. It might become, in quite a few subjects, a very severe disease involving different organs and systems. And unfortunately, I will have to leave this session practically now, but I give the virtual podium to Giacomo Grasselli that will present you the essentials of this disease. Please, Giacomo.
Thank you. Thanks, Antonio. Thanks, Massimo. So basically, we've seen this already. The first case here in Lombardy was diagnosed on February 20, and on March 11, the WHO declared the outbreak as a pandemic. And now Italy is the second. Now probably, yeah, it remains the second, but the first one has become the US. Anyway, Italy, US, and China account for the vast majority of the cases in the world. Again, we still need a lot of information on the clinical characteristics of critically ill patients. Even the proportion of patients requiring ICU is not very well known, since in China it ranges between 5 to 32% in different series. But clearly, knowing the baseline characteristics and the outcomes of critically ill patients is extremely important, not only from a scientific and a clinical point of view, but also for our preparedness and for the plan that we have to do to address the local outbreaks. So very, very quickly, the clinical basics on the clinical presentation, I'm sure you all know, the disease typically presents with systemic and respiratory manifestations, and common clinical symptoms are fever, up to 90% of the patients, cough, fatigue, and shortness of breath in about 1/5 of the patients. Then there are less common manifestations like myalgia, headache, sore throat, and some rare manifestations, especially gastrointestinal ones. And also what we know is that some individuals, probably a large number of individuals, are asymptomatic carriers. And as far as we know, some cases of transmission of the disease from asymptomatic carriers has been described, though we know that probably viral shedding is higher during the first days and in the 2 days before the symptoms become evident. As Professor Bindu explained, the disease can present as again asymptomatic or with very little symptoms. The majority of the patients have mild disease, which is defined according to the Chinese CDC as patients without pneumonia or with only mild pneumonia. Around 20% of the patients develop severe disease, which is defined as dyspnea, tachypnea, desaturation, PF ratio below 300, and the lung infiltrates. And around 5% of the patient in the Chinese population develop critical disease, respiratory failure, septic shock, or multiple organ failures. And you can see that basically the percentages are more or less the same also here. This is taken from our national database health system. The radiologic presentation is quite common. You can see here a typical chest X-ray and also a typical CT scan with these are the demographic data of our patients. So I'm going to present you the clinical characteristics, baseline characteristics of the patients of the first more than 1,500 patients treated here in the ICUs in Lombardy. And these data are going to be published, probably almost accepted. So I show you them for the first time. So again, the number of patients is 1,591 critically ill patients admitted to the 72 ICUs of our network. And you can see there's a huge prevalence of males, 82% versus 18%. And here on the right-hand side, you can see the age distribution in age classes. And you can see that the vast majority of the patient is in between the age of 40 and 80, but we have some patients, some younger patients. And the median age in our population here is 63. About comorbidities, almost 70% of the patients had at least one comorbidity, especially older patients, as expected. Hypertension is the most common comorbidity, as already described in China. About half of the patient has hypertension, and the other most common comorbidities are cardiovascular disease, hypercholesterolemia, and obesity. And only a very small percentage of patients had a previous history of chronic obstructive pulmonary disease. With regards to the respiratory support in our patients, among these first 1,500 patients, 99% had some form of respiratory support. Almost 90% are on intubated and on invasive mechanical ventilation, and only 10% are treated in the ICU with some forms of non-invasive ventilation, which is mostly CPAP or non-invasive positive pressure ventilation. At admission, around 1/3 of the patients are treated with prone position, but I can say that this number is probably underestimated, because as you can see, we do not have all the data for all the patients, and at least as a gut feeling, the number of patients who undergo prone positioning is higher. The number of patients treated with ECMO is very low, and what I do not have the numbers, I do not have the numbers yet. But what we know is that most of the patients have relatively conserved compliance of the respiratory system. So when we apply protective low tidal volume, they usually have low plateau pressure and low driving pressure, but they all have a high ventilation requirement. These are the value that we collected on the first day, and you can see that the median value of PEEP is 14 centimeters of water. The median value of FiO2 during the first 24 hours is 70%, and this was higher in older patients. And the median PF ratio was 160, higher in younger patients. With regard to the outcome, then Marco Ranieri will show you better data. In this population, at the end of the study period, I mean, those patients were admitted in the first 14 days of the epidemic. So from February 20 to March 8. So at the end of the study period, 60% of them were still in the ICU, 16% had been discharged, and 26% had died. So this is an ICU mortality, but it's a very rough and imprecise data because the follow-up period is too short. So what we know now is that ICU mortality will be certainly higher than 26%. This is all what I can tell you about ICU mortality, and we have no idea now about hospital mortality. And as you can see here, again, the death rate in the ICU increases linearly with age, and is extremely high after the age of 80, but even of 70. This is just a curiosity. Patients with hypertension were older and needed higher PEEP levels and had a lower PF ratio compared to patients without hypertension. And again, the incidence of hypertension was higher in patients who died in the ICU. So this is a retrospective study, so we cannot draw any conclusion on, it might look that hypertension is also a risk factor for death. This study has limitations. First of all, it's a retrospective study. We have a lot of missing data because I'm sure you understand that in this situation of an overwhelming number of patients, precisely collecting all the data is very difficult. So we did our best, but again, we have missing data. And then with regards to the outcome, the follow-up period is too short compared to the course of the disease. We know from Chinese study that the median time on the ventilator is around 16 days. So the follow-up is too short to draw any conclusion on the mortality of the disease. And so in conclusion, we can say that in this very large case series of critically ill patients admitted to our ICUs, the majority of patients were older males. A large proportion of them required invasive mechanical ventilation and relatively high levels of PEEP, and this rough first sight ICU mortality was about 25%, but it's certainly destined to increase with longer follow-up. Thank you very much.
Giacomo, in the end, we'll have the questions and we can answer them. Now, there will be the following speaker. And the following speaker is Marco Ranieri. Marco Ranieri is one of our past presidents and currently is the head of the Department of Intensive Care Medicine Anesthesia in Bologna University, and at the same time is also the regional coordinator for the emergencies in Emilia-Romagna. And Marco, who is also a good friend of mine, is going to speak about the outcome data. Marco, please.
Thank you very much. Do you hear me? I guess so. Let me, first of all, try to give some definition that are necessary to be given because it's very difficult to answer the question, what is the outcome of COVID-19? Now, we define outcome in two major ways. We estimate the overall mortality. That means how many patients are dead at the end of the study period. And the second way to estimate outcome is using the Kaplan-Meier curve analysis is to assess the probability of death that you observed throughout the study period. Now, all the time that we test the efficacy of a device, of a pharmacological agent, we use the definition of outcome based on Kaplan-Meier curve to give a difference of the strength between the two methodologies that are used to assess outcome. So unfortunately, most of the data we have available nowadays on COVID is in terms of overall mortality. This is the list of available data. In black, you see data obtained in China. And in red, you see data that are the only data that are available in the Western world. Now, as you can see, there is a huge variability that is caused by the denominator and the definition of outcomes. First of all, the New England Journal of Medicine published a mortality rate of 1.5% out of almost 1,000 patients that were positive for the virus. When the subset of patients was restricted to 173 patients that had severe pneumonia, mortality, which is actually something that needs to be better defined, was 25%. This 25% actually includes death, but includes also needs of ICU and needs of mechanical ventilation. So it's a very overestimate of mortality. Lancet published a mortality rate of 11% out of 99 patients with pneumonia. Again, Lancet, the same issue, 15% out of 41 patients hospitalized for COVID. JAMA in 2020, a few weeks later, 4.3% of 138 hospitalized patients for COVID. So we have a mortality that has been estimated essentially looking at either patients, subjects positive for COVID, or patients admitted to the hospital. The two reports that we have available in the Western world report a mortality rate of 15%. Giacomo already presented these data, and probably the largest patient population available nowadays. And these are the data coming from the US, a single cluster in the Seattle area, 6.67% out of 21 patients admitted to the ICU. Regarding the estimated risk of death, we have a single piece of information coming from China, and this article published on Lancet Respiratory Medicine. Now, the surviving curve was obtained at 28 days for 52 critically ill patients. And these 52 critically ill patients in a single center study represent the 7.3% of patients admitted into the hospital. ICU mortality at 28 days was 61%. And the median duration from ICU admission to death was 7 days, with an interval of 3 to 11 days. This is a Kaplan-Meier that shows a nice asymptotic behavior after 14 days. Now, I am presenting some preliminary data that soon will be submitted for publication. We collected the data on the first 2 weeks of the outbreak in the 3 regions of the north of Italy where they were initially hit by the virus, so Lombardy, Veneto, and Emilia-Romagna. And we collected as much as more than 3,000 patients that were hospitalized for COVID-19. And we assessed ICU mortality, estimated to be 13%, consistent with what Giacomo presented. But we also provided a Kaplan-Meier analysis of the first 14 days of time. And here you can see that the rate using this assessment was around 30%. And this is the Kaplan-Meier curve that differently from the Kaplan-Meier curve was obtained in 28 days doesn't show the stabilization because probably it's taking the picture of the very initial phase of the disease. Of note, if you take the mortality of 14 days, you see that while this subset of patients from China, mortality rate was 50%. The mortality rate was observed in the first 14 days, and the largest Western world patient population is 30%.
Now, why is this? I think it's a matter of discussion, it's a matter of standard of care, it's a matter of organization. But I can say that 30% mortality rate in the context of this analysis is probably the most robust piece of data we have. And let me conclude thanking all the nurses, the doctors, the residents that are risking their life now up to date every hour to take care of our patients and our staff. Thank you very much.
I guess that we do have a number of interesting questions for the two speakers, and maybe I should start from the end. And some colleagues were asking that given the variation in practice or in measuring the outcomes, what is the suggestion for having the way for comparing the these different measurements? Marco, can you answer this question?
I think that we need to have a good estimate of outcome, because we have to set up based on this estimate the level of care, the level of organization, and I think that the single evaluation at the single day, that is the data that are available, is not enough in terms of quality of the signal to estimate the level of investment that are needed in order to take care of these patients. I mean, a less than 30% mortality is not describing the clinical complexity of these patients. So that's why I believe that the Kaplan-Meier estimate of outcome in these data is providing the best picture, describing how complex these patients are and how difficult it is to manage them, and of how many resources they need in order to take care of them.
Thank you, Marco, and I share your vision that these patients are indeed very complicated. I do have now a question that could be for Giacomo, because people are insistently asking about the different medications that are being widely discussed and their benefit. Do you have any report concerning the various therapies that have been applied to these different conditions? Giacomo, can you tell us? Oh, I see. Giacomo is not there, so I kindly ask Marco to answer this question. Which are the therapies that usually you use, and which are the differences between the various therapies?
Well, Massimo, as you know better than I do, we currently have a substantial number of trials that are going on in Italy trying to assess the appropriate therapy for these patients. We know we have information regarding the antivirus therapy. Some they work, some they don't. We don't have information regarding steroids, and this, I think, is a major question. There are scientific societies that are suggesting actually the use of steroids. We have previous data showing that use of steroids in virus pneumonia-induced ARDS are actually dangerous. As a matter of fact, we don't know. As a matter of fact, I can tell you that in the clinical practice, more than 30% of the patients are receiving steroids. I don't know if this is right or wrong. And in general, we are trying to assess the possibility to treat these patients with anti-inflammatory therapy, aiming to attenuate the pro-inflammatory, huge pro-inflammatory signal that characterize the stay in the ICU of these patients. And this is, I mean, the complexity of treatment in the ICU. But honestly, I believe that the war in terms of pharmacological therapy will be when with appropriate pharmacological therapy outside the ICU, before the virus is able to activate the severe pneumonia or the severe inflammatory reaction we see in the ICU. That is where the focus should pay attention. When the patients arrive in the ICU, the power, this is my belief, the power of pharmacological intervention is relatively limited.
Indeed, as you know, there are some proposals of delivering some of the anti-cytokine storm very early and much earlier than before the ICU admission, and not only to the most severe cases. This could be the policy that you were suggesting then.
I agree absolutely.
Okay, Giacomo, there was a sort of technical question that maybe pertains patients that can be treated also outside the ICU. And people were worried about the exhalation valve and the pollution of the environment in the when there is the expiration on a mechanical ventilator. Can you comment on that, or do you have any suggestion to give to the various audience?
So yes, so this is certainly an issue. As you all know, the WHO recommends a certain number of air changes, and whenever possible, negative pressure in the room. But as you know, it's very difficult to have enough number of boxes with negative pressure. That's why we decided to cohort the patients. So clearly the air which is exhaled by the ventilator contains the virus. What we do is to put an antiviral filter, an HEPA filter, on the exit of the expiratory port of the ventilator. Others use the central aspiration system that we use, for example, in the operative rooms, that you can use for halogenates. So if you have in your ICU the possibility to connect the expiratory port of the ventilator to the central vacuum system, that's another possibility. But the easiest way would be to put an HEPA filter on the expiratory port. Clearly, when you substitute it, like every 24 hours, you need to make, for example, an expiratory hold and to take some precautions to avoid an aerosol of the exhaled air from the ventilator when you remove the filter.
Okay, thank you for this contribution. There is another interesting question that concern, and that can be for the both of you, concern the incidence of acute renal failure as well as the incidence of multiple organ failure. And one of the questions that the audience poses is if the patient die because of the acute respiratory failure or the presence of multiple organ failure in general. Giacomo?
We are still trying to understand and to answer all these questions. Certainly the incidence of acute renal failure is not low, and there is also a survey ongoing on this. And with regards to multiple organ failure and cause of death, it's not so easy. Some patients die for example, pulmonary embolism. Some patients die for cardiac complications and cardiomyopathy. Some patients die for intractable respiratory failure, even on ECMO, or at least this is our experience. We have connected to ECMO a very limited number of very young patients, and with high mortality. And so this is what I can tell you. It's what we know is that the idea is that it's not, as Antonio was saying, and also as also Marco was saying, it's not a like usual viral pneumonia. It's the disease and the reaction of the virus in the lungs triggers in some patients a huge inflammatory response, which in some way resembles macrophage activation syndrome, because they have, for example, very high ferritin levels, and that's the basis for cytokine treatment. So certainly the action of the virus on the epithelium on the lung is probably the primum movens, but it's not the direct cause of death.
Marco, do you have any comment on that?
Yeah, I would just like to add some data regarding this issue that we obtained in this 14-day snapshot. Actually, at the end of the first 2 weeks, the incidence of need of vasopressors is about 50%. So about 50% of these patients are on catecholamines. Renal replacement therapy is needed in the 7% of the patients, and we have coagulation problem in about 10 to 15%. An interesting piece of information is that the biological signal of bacteria infection, that is procalcitonin value higher than 0.5, was observed in the 37% of patients. Now, these are the data that we obtained the first 2 weeks, and these are the data that we saw the first 2 weeks. But, I mean, take it as my personal clinical impression. I think that after the first 3 to 4 weeks, we changed the phenotype of these patients. At the beginning, we saw older people, mostly that entered with a single organ failure and comorbidities. The one who made it were the one who remained within a single organ failure. It took a while, it took a very long time before they could get off the ventilator, but if they remained with a single organ failure, they made it. The one who didn't make it were old people with comorbidities who started to get bacteria infection, renal failure, need of cardiovascular support, and multiple organ failure. The phenotype now is changing. They are much younger. They enter with a more severe acute hypoxemic respiratory failure that is less responsive to prone positioning, and they are exposed to multiple organ failure earlier on that the previous wave was used to. But I have no data on this. It's just my clinical impression. Take it as it is.
You cannot imagine how many questions were arriving, but unfortunately our time expired, and I sincerely thank you both for the tremendous contribution you have given. Thank you very much indeed. Bye.
Thank you.
Thank you,
Thanks,
Massimo.
Marco.
Ciao.
Ciao.
Ciao, Giacomo.
Ciao, Marco.
Ciao.
So welcome back again, and it's very important that we carry on to learn from previous experience as well and from experiences worldwide. So we have another session on these two great speakers. I would like to introduce the first contribution from Professor Yassin Arabi. Professor Yassin Arabi will share some experience from SARS and MERS. Yassin is the chairman of the Intensive Care Department, medical director of the Respiratory Service, and professor of the College of Medicine, King Saud bin Abdulaziz University of Health Sciences, King Abdullah International Medical Research Center, Abdulaziz Medical City Riyadh, Kingdom of Saudi Arabia. Dr. Arabi obtained his internal medicine training at Wayne State University, Detroit, US, and his pulmonary and critical care training at the University of Wisconsin, Madison, US. He is currently the principal investigator or co-investigator of several multi-center randomized controlled trials and has received several international awards for his involvement in clinical trials. He was the presenter of the much-watched ESIC COVID-19 webinar earlier this month when he spoke about the ongoing trials, supportive therapies, and future direction. Hi, Yassin, and welcome.
Thank you very much.
That Yassin has been instrumental in helping us to look at guidelines, to look at how we can face this coronavirus, because he had some frontline experience of previous epidemics on coronavirus. So I would like to invite you to start with your contribution.
Thank you very much. I really appreciate the invitation and the opportunity to be here. So this is the third outbreak with the coronavirus in the last 2 decades. SARS created a large outbreak in 2003 and 2004. Then MERS started in 2012, and cases still exist till now. And now we are facing the COVID-19 outbreak that started a few months ago. The family of coronaviruses has 7 viruses that infect humans. The first 4 listed in this slide are known for a long time to cause upper respiratory tract infection and sometimes lower respiratory tract infection. But the outbreaks that occurred in the last 2 decades are related to SARS-CoV, MERS-CoV, and SARS-CoV-2. And the current virus has a high similarity to SARS-CoV, 75 to 80% genomic similarity, 50% similarity to MERS-CoV, and has a 96% similarity to a bad coronavirus. This current virus share the same receptor as SARS-CoV, which is ACE2, but it's different from what's used by MERS-CoV, which is a DTP4. This slide gives kind of high-level differences between the 3 coronavirus infections. The 3 of them started in a country in Asia, so SARS and COVID-19 in China and MERS in the Arabian Peninsula. The 3 coronaviruses are related to animals. They are zoonotic infections. SARS is linked to civet cats and bats. MERS related to camels, and COVID-19 probably related to bats. All these coronaviruses are transmitted from human to human, although to variable degrees. With MERS has a relatively low transmission in the community, while COVID-19 has very high transmission from human to human. Very relevant to our presentation today is the nosocomial transmission, which happens in all the 3 coronaviruses infection, and also, unfortunately, the risk to healthcare workers that happen with the 3 infections. And we really need to be careful when we are managing these patients to avoid the nosocomial transmission and to avoid the risk to ourselves and to other healthcare workers. The magnitude of the COVID-19 is certainly far higher than the other 2 infections. MERS and SARS affected a few thousand people. However, COVID-19 has affected close to 600,000 patients so far. The case fatality rate of COVID-19 has been cited to be lower than the other 2 infections. The case fatality rate, for example, for MERS is 34%, and for SARS is 10%, and for COVID-19 is 4%. But one need to be careful when looking at this number for two reasons. One is the total number of patients is huge. So 4% out of 600,000 still massive number. And the other issue is that you need to know what's the denominator. So on the left here, in China, 80% of the cases are non-severe. So when we talk about mortality of 2 to 3%, this is because you have a large number of non-severe cases. However, when you focus on the 5% critically ill patients, the mortality actually is quite high, 40 to 62%. On the right, the distribution of severity in Italy as per what's reported in a JAMA short paper, where there's some difference from what's observed in China. More severe patient hospitalized, 25% versus 15%, and you have 5% critical, and the overall case fatality rate is higher, is about 7%. For us working in ICUs, the three infections have similarities. They affect people at a median age of 60. Of course, there is variation, but the median age of around 58 to 60. Often the patients have comorbid conditions, much more in MERS than COVID-19, but clearly it's a major contributing factor to morbidity and mortality. These patients in the three infections present with ARDS and pneumonia. Often they have shock and multi-organ failure. They require to be intubated on vasopressors and renal replacement therapy. These percentages differ from one infection to the other. Probably the most severe with MERS, most common. However, the mortality in COVID-19 and in MERS for ICU patients are both high. Histopathologically, from the limited data we have, this is from a case report from COVID-19 on the left. This is from a case report we reported of post-mortem biopsies. There are several similarities. The lung has diffuse alveolar damage, and the liver multilobular, mild lobular and portal hepatitis. In the two cases, there were no histologic changes in the heart, but that doesn't exclude really heart myocardial problems because this is only one case. In the COVID-19, another study using endoscopic biopsies showed evidence of the virus in the GI mucosa. What we learned from MERS and SARS has helped in putting together guidelines for management of COVID-19. Of course, as you'd expect, the knowledge about data, the knowledge about COVID-19 management is evolving at present. But I'm gonna take only a few points. Non-invasive ventilation, this is one study we did on MERS, where non-invasive ventilation using face mask was used commonly, 35%. But we observed very high failure rate, 92% of patients required to be intubated. And those who were intubated were more likely to become hypoxic than those who were intubated from the beginning. Although at the end, the mortality wasn't different. The surviving sepsis guidelines, based on this study and other studies, recommended that maybe high flow nasal cannula should be used before non-invasive ventilation. If it's not available, non-invasive ventilation can be used, but should be used only for a short period of time and have a low threshold for intubation. Our colleagues in Italy, they are using a lot of helmet non-invasive positive pressure ventilation, and the reports have been encouraging. We're really eager to see data on the effectiveness. This could be could have different level of evidence than the existing face mask non-invasive ventilation. ECMO, most of us are familiar with the EOLIA trial, which didn't show statistically significant difference in mortality, although a post hoc Bayesian analysis suggested benefit in some patients. This is a case control study from MERS patients where we compared patients who were treated with ECMO to a matched control group of patients who were not treated with ECMO, and there was a difference in mortality favoring ECMO over non-ECMO. The corticosteroid debate is very heated at this time. This is a review of different studies from MERS, SARS, influenza, and RSV. This review suggested that steroids probably should not be used for coronavirus. The surviving sepsis guidelines suggested that generally you should not be using this if the patient doesn't have ARDS. However, based on ARDS trials, which showed benefit of using steroids, the guidelines suggested gave a weak recommendation of using steroids, although this particular recommendation was discussed extensively and there wasn't full agreement about it. I think we are waiting for some of the clinical trials that are being conducted now about corticosteroids to inform the guideline regarding steroids. Also, I think some antivirals used in previous corona infections, lopinavir, ritonavir, has been used in SARS, and pre-post studies suggested significant benefit, although this observation, and it has many problems with confounding. In vitro studies in MERS showed that the lopinavir, ritonavir has significant inhibitory effect against the virus. You probably have seen the clinical trial of lopinavir, ritonavir in COVID-19 published less than 2 weeks ago. And this trial showed that the treatment with lopinavir, ritonavir in severe COVID-19 did not improve the time to clinical improvement, and it did not affect mortality or even viral shedding. One limitation, or a major limitation actually for the study, is that the median time from symptom onset to enrollment was 13 days. So one would think that the treatment was very late, and perhaps the study does not really exclude possible benefit if this treatment was given earlier. At present, we are conducting the Miracle trial, which is a combination of lopinavir, ritonavir with interferon beta 1b for MERS, for hospitalized MERS patients. At present, we recruited the 95th patient, and our target is 114. This is, of course, the cases of MERS are now becoming very few, so it's taking a little time. The ribavirin interferon were also used during MERS extensively, and we reported the results in CID showing no benefit, no apparent benefit based on observation study of using ribavirin and interferon alpha and beta 1a in MERS patients. It is possibly that the different interferons have different effects, and this may be also applicable to COVID-19. So in MERS-CoV, among all different interferons that were tested in vitro, interferon beta, and especially interferon beta 1b, had the most inhibitory effect against the virus. Co-infections also, we learned from MERS that almost 18% of patients with MERS have bacterial co-infection, and 5% have viral co-infection. In non-peer-reviewed studies on COVID-19, they reported similarly high frequency of co-infections. And this really reminds me of the ATS-IDSA guidelines for influenza, which recommended that community-acquired influenza patients with community-acquired pneumonia should be treated with the empiric therapy for community-acquired pneumonia and then de-escalated later. I want to take this opportunity in the last few slides to talk about our experience with MERS. In 2015, our hospital, unfortunately, suffered from a major outbreak of MERS. And this has started with a patient coming to the emergency room here in June 14. But however, this case was not suspected initially and went on for several days until people suspected that he might have MERS, and then he was put on isolation. By that time, the infection was spread to many other patients and to healthcare workers. And over the next few weeks, there was a huge peak of cases of MERS in the dark blue among patients and the light blue among healthcare workers, leading to major outbreak in the hospital. Total of 130 patients in the hospital had nosocomial transmission. 33% were healthcare workers, and 96 were hospitalized, with 63 were admitted to the ICU, and almost 50% of the hospitalized patient died. It had made major impact on the hospital. The hospital, for to control the outbreak, we have to close the ER, OR, clinic, all elective surgeries. This is the load on the ICUs. We admitted our patients in first unit and then was filled, and we have to move to another 21-bed other ICU. Then we utilized the third ICU to manage patients with MERS. It was major experience, and these patients were very sick, intubated 89, almost 90%. At that time, we used high frequency oscillation, about 9%, ECMO around 7%, proning 10%, high dose of pressors, and renal replacement therapy. What is important that these patients in the ICU have high viral load, and they shed the virus for a long time. And we don't know, probably the same for COVID, how long they are infected. And these patients, frequently, they need procedures or care at the bedside and for a long time. So what's the message from this? The message from this is that early suspicion of cases and putting patients in proper infection control precautions will avoid nosocomial transmission. This should be a major target for us when we take care of MERS or COVID-19 patients. As a result of this outbreak, the hospital has devised different approach to management of these patients. So now we have a respiratory triage. Patients from the entry to the ER, before the entry of the ER, actually from the entry to the outside hospital, they are triaged to two parts of the ER. One is called flu clinic or respiratory emergency room, and the other is the regular ER. And patients who have respiratory problem are placed in isolation in the ER, and they are, if admitted to special ward and special ICU. The last slide is to show the status in Saudi Arabia. This is the report from Ministry of Health today. There's Saudi Arabia took major preventive measures to control the infection. And with this, actually, the number of cases, given what's happening around the world, is actually very controlled. Hopefully it will decline, and it actually start to show some decline. The total number of 1,200 cases. There are few patients who are critically ill in ICUs, but so far the COVID situation, I think probably because I think it's a big part of this because of what we learned from MERS, to take it seriously from the beginning. So it is important to be prepared to do the proper triage and disposition of patients from the point of entry in the emergency room, to be very strict with infection control practices. We are, as physicians and nurses, we really need to be familiar with the case definition and to have a low threshold to suspect COVID, especially at this time where the pre-test probability is very high. Missing the diagnosis or delayed diagnosis can lead to significant serious consequences. It is important to strictly comply with the infection control precautions. It is our responsibility to our patients and to ourselves and to our families to fully comply with infection control practices. We need to be aware of the diagnostic testing and that the test can be negative sometimes. You have to repeat it if the suspicion is high. At present, the care is supportive, similar to MERS and SARS. And at present, we don't have strong evidence for antiviral therapy, there are some observation or small studies. Hopefully, we will learn more in the coming few weeks. With this, thank you very much, and thanks to the European Society for Intensive Care Medicine for inviting me and giving me this opportunity to talk to you.
Thank you, Yasin. We have a lot of questions that are coming from the internet, and you and I, we were speaking during the last few weeks and exchanging emails also now to tackle this. From your experience, how different is the management strategy, if it is any different in terms of principles from MERS and COVID-19?
I think for all practical purposes, the general principles are very much similar. It is supportive care of severe ARDS and multi-system failure. What we observed in the MERS that the degree of severity of hypoxemia appears to be maybe more severe. The frequency of acute kidney injury is common, but this may be related to the high prevalence of diabetes in Saudi Arabia, or it could be related to the behavior of infection itself. But acute kidney injury is very common with MERS. But I think the general management principles of patients are almost the same.
I really would like to stress one point, and maybe you can tell me how you've done it in your hospital, because even at Humanitas Research Hospital here in Milan, where I worked, we were lucky not to have the first case. So we could work very quickly, like in 12, 24 hours, to basically separate our hospital in two hospitals. So waiting for the surge of patients, containing infections within your hospitals is so important, because otherwise you run the risk that your hospital becomes a little cluster for other patients and healthcare professionals. And it was unfortunately very sad to see this happening in the first hospitals in the south of the region, where they didn't know that they had patient until the very first patient was positive. And indeed, we noticed a very high rate also of healthcare workers there. I think at the beginning we were in the range of 11% of all positive cases were healthcare workers. So can you tell us your experience if these separating the triage and creating two different paths protects not only patients, but you have evidence that you have a much lower infection rate in your healthcare workers?
I think it is essential. I think it is essential that we, after the COVID pandemic resolve, I think this pandemic gonna lead to significant transformation of how we manage patient flow. Patients with respiratory problems should be triaged separately from the point of entry in the emergency room throughout their hospital journey. So patients should have separate ER section, separate wards, and maybe separate ICUs as well. So this will help focusing the resources, focusing the attention. These viral infections are after we had in the last 2 decades, we have 3 coronavirus outbreaks. We had the H1N1, and there are in between smaller outbreaks of avian influenza here and there. And these viral infections will be happening even around the year. So it is very important that we relook at the patient flow in our hospitals. Now, in our response plan in our hospital, we already designated certain wards to be managed for surge capacity for respiratory patients, and others for the clean, if you wish, for the non-respiratory infections. Already designated different wards, different ICUs, different parts of the ER.
Yasin, that's exactly the experience that we are seeing. We basically transformed our hospital also because we found that there is a significant rate of false negative PCR at the beginning with the swabs that you have. So I think what you were saying about designing triage based on symptoms that could be for a transmittable disease is definitely been our experience. So the important thing, you can rule in with a positive test, but if you have a suspicion, you shouldn't rule out immediately with a negative test. I don't know if you want to comment on this.
Fully agree. So one single test does not exclude the infection for multiple reasons. We don't know exactly the sensitivity of the test. There are several issues related to the sample quality. Many patients present to the emergency room. They're initially non-intubated, so they obtain nasopharyngeal swabs, and maybe the virus is not there, it is there, we don't know the sample quality. So these samples very often are negative. So in MERS, among the ICU patients, only 1/3 of them were diagnosed with upper respiratory sample. The rest were from lower respiratory samples, and even this, it has to be repeated in the diagnosis was established from second or third sample in around 25% of patients.
That's exactly our experience here in my hospital. So we've separated flows exactly because of that. One difficult question that we had from the audience is it seems that there is about 10% of patients that could have some preceding specific gastrointestinal symptoms before they get some respiratory symptoms. And of course, it becomes a little bit difficult to triage everyone. Do you also take into account these symptoms in your experience, or actually have you found that, at least what we found is that these symptoms may be preceding the other symptoms, but they don't necessarily bring these patients to your attention in A&E. So sometimes these patients are at home, so we don't see so many. But if they do come, what do you do, or how do you take this in consideration?
In our screening tool, we ask if there are flu-like symptoms, including GI symptoms. So some of these will be picked up in the screening tool at the entry emergency room. But I agree, these sometimes pass through screening, and the GI tract has been shown to be involved in COVID histopathologically, and virus been documented in stool, etc. So it is an important question. I think we need to come up with the correct screening tool for COVID, but maybe we should include in acute GI symptoms in that.
Yes, as always, a fantastic contribution, and thank you for all your share of knowledge that you've done in the last years, and especially also in the last few weeks with us. It's been very helpful to prepare better. So thank you. We are moving to our next contribution, and our next contribution is hello, Maricruz. Is Professor Maricruz Martin Delgado. It's a pleasure to introduce Maricruz. Maricruz and I were friends. We know each other for some years. I actually remember her calling me a few weeks ago saying that she had the first ICU patient in Spain in her unit, and maybe she can share some of this experience later. Just let me introduce her a bit better. Professor Delgado is the head of Department of Intensive Care at the Hospital Universitario de Torrejón, an associate professor of the Universidad Francisco de Vitoria in Madrid. Her other responsibilities include head of the Health Division of the Higher Institute of Law and Economics in Madrid, president of the Foundation for Patient Safety Research, Teaching and Innovation, and member of the Humanization in ICU project. She was president of the Spanish Society of Intensive Care and Coronary Care Units between 2017 and 2019. She's also a member of the Pan American Council and Iberican Critical Care Medicine and Intensive Therapy, and she's the president-elect for this community for 2021-2023. Maricruz, due to some technical issues, we are going to stream a recording that she's done just a couple of hours ago of her presentation, and then we are going to take a few questions that are coming from the internet. So please, let's start with Maricruz's contribution.
Good afternoon. I would like to express my gratitude for the opportunity to participate in this marathon and share some key points for the experience of the Pan American and Iberian community on the COVID-19 pandemic. Many thanks to ESICM for this initiative. The current dates on the situation in the American countries and the Iberian Peninsula show the spread of the disease, which also has become a general problem, affects some countries more than others. On the 26th of March 2020 at 1 p.m., the most affected countries were the United States with more than 63,000 cases, Canada with 3,555 cases, followed by Brazil with 2,433 cases, Chile and Ecuador. Over the past few days, the cases reported are progressively increasing in the other countries. It has not been possible to have updated figures of patients admitted to the intensive care unit at the Latin American level. We are aware of a relatively low number of cases in Chile and Brazil. The main problems transmitted from these communities are the shortage of personal protection equipment, of mechanical ventilators if the number of the cases increase, the existence of very vulnerable population with few resources, and the possibility that a significant number of professionals may be affected. FEPINTI has launched different actions such as direct collaboration with the Pan American Health Organization, the creation of a registry, as well as the development of protocols that can be shared. The experience of the countries most affected by the pandemic led us to some key learning points worth considering, such as, first, the need for real contingency plans adapted to the worst scenarios and the need for timely information on available resources and the evolution of the pandemic. The necessity to adapt proactively to changing situations since the conditions vary very rapidly. It is essential to have an effective leadership with a single centralized command. The need to apply the principle of crisis resource management both at macro and micro level. Teamwork and shared accountability is essential at all levels. The need of innovative, out-of-the-box thinking, looking for ways of acting differently than usual, even at the team level. The need of information and training of professionals. It's time we consider medicine in the context of uncertainty versus evidence-based medicine we are all used to. Sharing information is critical. Transparency is able resource and application of triage criteria. At take-home message, I would like to underline a few important aspects on how to better prepare yourself. First, learn from what has happened in other countries and identify best practice based on results. Prepare yourself for the worst scenarios and optimize your resources by adapting them to situations of shared scarcity. Consider an equitable distribution of resources and what resources can be mobilized at any time. Accept the fact that in some countries we are experiencing the reality of disaster medicine and work based on these circumstances. In any case, ensure humanitarian care at times such as these, when needs are many and so are the barriers to carry it out. Learning from the experience of the frontline healthcare workers, I would like to make a few recommendations on how to better protect yourself and your teams. Prioritize the safety of healthcare professionals. A decrease in their number will impact patient outcomes. Reduce the spread of the disease by performing PCR and early isolation of healthcare professionals so that they can return to work as soon as possible. Consider work shifts tailored to emergency loads, avoiding 24 hours duty. Ensure effective and permanent communication with the entire team under strong leadership. Celebrate success with the team establish homogeneous judge criteria and mechanisms that reduce the difficulty of decision-making and the moral stress of healthcare professionals. And finally, facilitate psychological and emotional support to professionals providing bedside care both at present and in the future, since there will be another day after this health crisis come to an end. Thank you very much for your attention. My best greetings to everyone. Good afternoon.
Thank you for your contribution, and also coming probably from two of the worst affected cities in Europe after the outbreaks in China. I also wanted to ask you how you are, and how is it been for you?
I don't listen, Mauricio.
I'm saying, how has it been for you? ¿Cómo ha sido para ti?
Okay, on February 26, after changing the diagnostic criteria of the disease, patients with pneumonia without a microbiological diagnosis, we had our first COVID-19 diagnosis in an intubated patient with 10 days of admission of the intensive care unit. Since then, we have not been able to stop. First, we had isolate the unit to verify that the rest of the patients were not infected. Then we started receiving every day positive COVID-19 patients that occupied our 16 ICU beds. In the following week, we extended ourselves to the post-anesthetic unit with 12 new beds. We ended making use of operation room beds and even ambulatory surgery beds for negative patients. We established a work plan from the beginning, led by the ICU with the help of the hospital and the support of the management. Find resources, personal protection equipment, new spaces, reinforced templates, circuits, work protocols. Every day, we have continued looking for resources to be able to attend to other patients, studying, making protocols, trying to make time for our families, supporting the team, and including other specialties such as anesthesiology and otorhinolaryngology that are helping us a lot. We alerted other units in Madrid and in the country to prepare themselves. We have tried to manage the resources in the best possible way, support and advise the administration to give an organized response.
Maricruz, it seems from what you're saying that you had a very similar situation to what we had. When the surge of patients is so high, you need to stop and think, but you really need to try to get all the resources that you have there. What I was asking was also, I know that the situation in Madrid is very difficult now. My brother is a cardiologist in Madrid, and he's telling me he's also attending some of these wards now. How has it been for you and your team? Were you able to protect yourself? Were you able to to be able to basically to isolate yourself? I know that you also had some trouble and you've been in quarantine now. Do you want to tell us a bit more about that?
I'm fine now, practically asymptomatic. I am tired, but I think it is more due to the sport to these weeks than to the disease. Also concerned for not being able to be in the hospital with the team, trying to support them as much as I can from home, but it's not the same. I hope to remain asymptomatic and test negative so that I can return to the battlefield. Meanwhile, taking the opportunity to rest so that I can go back in full force.
Okay, Mary Cruz, thank you so much for your contribution and for telling us everything that is happening there, also about all the community that you represent, not just Spain, but all the Pan-American community. We will hear more about Spain with Ricardo Ferrer later. I'd just like to say that we are close to you. This is very difficult. It's been very difficult for our two countries and our cities, but we are together on this. Thank you for everything that you guys have shared, and good luck. I'm sure that it will get better soon as well.
Thank you, Mauricio. Good afternoon.
From the National University of Ireland in Galway, and I'm delighted to moderate this session. The first speaker is Dr. Lenny Derde, and she will be discussing containment and mitigation strategies. Dr. Lenny Derde is a consultant in ICU and infectious diseases in the Intensive Care Centre, University Medical Centre Utrecht in the Netherlands. She is the European co-lead of REMAP-CAP, a trial designed to adapt to an acute pandemic need, which now includes COVID-19 patients. Dr. Derde is the chair of the Dutch Intensivist Task Force for Infectious Disease Threats and co-author of the ESICM, SCCM, SCC guidelines on COVID-19. She is a member of the ESICM, ESCMID, ERS Severe CAP Guideline Committee, and also the Dutch multidisciplinary committees developing national sepsis guidelines and influenza guidelines. Welcome, Lenny. We look forward to your talk.
Thank you very much, and thank you very much for that kind introduction. So I'll be speaking to you today about containment and mitigation strategies. And what I'll tell you is, I'll tell you what containment and mitigation is, I'll tell you why we want to contain and mitigate infectious diseases, and also tell you a little bit about how we can do that. So containment essentially is the action of keeping something harmful under control or within limits, while mitigation is the action of reducing the seriousness, the severity, or the painfulness of something harmful. And you can see that these two are interrelated. If you contain a virus, you also mitigate its adverse effects. And if you want to mitigate an infectious disease, you at least in part have to contain the virus in this case. So what I want to start with is why are we talking about infectious diseases? What makes infectious diseases different from everything else? The thing that sets infectious diseases apart is that they are contagious, that they spread. And that's why I chose this picture to bring across the message that my cholesterol doesn't affect your chance of getting a heart attack if we are in the same room together. But if I have SARS-CoV-2, that definitely affects your chance of getting COVID-19 if we would still be in that same room. And I want to start by saying a couple of things about this pandemic and how it started. So in retrospect, the first case was identified on the 8th of December, 2019. And a cluster of unknown pneumonia cases, weird pneumonia cases, was first identified, amongst others, by ProMedMail, a very good email service that continuously searches the internet for information on new or continuing information on already known infectious disease outbreaks. So it's a very good resource. And they picked up on a cluster of cases on the 30th of December 2019, as you can see here. A day later, this was also reported to the WHO. And one of the doctors involved in the very beginning of this outbreak was Dr. Wen Liang. And I'm mentioning him here because, as you may know, he eventually also died from this disease that he contracted from the first patients in Wuhan, China. And there may be more colleagues than Dr. Wen Liang, but he's one of the names that have become known in the media because he really tried to tell the world about how dangerous this virus is already at the very beginning of this pandemic. And I just wanted to mention him and say that, you know, in my opinion, he's really a hero for aiming to do that. And we should all be very grateful to what our colleagues in China did, amongst them Dr. Wen Liang. So this cluster, this outbreak of pneumonias, was very quickly related to a local, it was called a seafood market. What you see here is a picture of a similar market. It's not a picture of that specific market, but this is what markets like this look like. So what you can see is that it's not just seafood. What you can see is that there are many live animals in close proximity. And then in this market, these animals are slaughtered at the scene and the raw meat is then sold. And what they did in the beginning of this outbreak is classic epidemiology. People ask them a lot of questions on their relatives if they were too ill. And then what you do is you try to find a common theme. And the common theme here was this market. 2/3 of the 41 patients admitted by the 2nd of January 2020 had a link to this market. And behavior like that, searching like a detective for where the disease comes from, that's not new. We've been doing that ever since we've started to understand something about infectious disease. And what you see here is you see a map of London in 1854. And what you can see is little black squares towards the center of this map. These are the houses of people with cholera that John Snow indicated on this map. And seeing the pattern of spread on this map, he thought that a water pump in the center of this area could be the source of the cholera outbreak. He thought there was contaminated water that made these people ill. And he actually convinced the authorities of that, even though he couldn't prove it. And they eventually shut down the pump by taking off the crank. And then the outbreak died down. That's not the whole story. The true story is that the outbreak was actually already declining when they took the crank off the pump. That was because people were fleeing the area because there was just so much disease and death going on. But it does show you a principle that was true then and that's still true now. You find the source, you take it down, and then you hope that an epidemic or a pandemic dies out. That's what was also done in the beginning of this outbreak. The market in Wuhan was shut down very, very early. And the hope was that this would stop or at least highly reduce the number of infections coming from that. So unfortunately, that was not the case. It very quickly became evident that there was human-to-human spread. So the thought was that this virus originated in a bat and then it probably has a mammalian intermediate host, and then it had spread around the change of the year to humans. And then we saw quite quickly during this outbreak that there is human-to-human spread. And that immediately brings us to the why of containment and mitigation strategies. So there are two reasons for wanting to contain or wanting to mitigate this viral infection when you know that there's human-to-human spread. And the first reason is an individual one. So if this is a new disease, then every single human on the face of the earth is susceptible to this disease. So that means that if on average a person spreads the disease to at least 2 others, you will see exponential growth of the number of cases, and it will very quickly spread through your complete population because everybody is sensitive. That means a lot of people, well, all people will get ill eventually, and dependent on the case fatality ratio, a large number of people will die. And that brings us to the second reason you want to contain and mitigate such a disease. And that's a more societal perspective. Because if all these people get ill and if a lot of people die, then the complete societal structures come to a standstill. So this may not be the most important, but I've just said it as an example. So if everybody gets ill, there's nobody to pick your coffee beans. There's nobody to transport the coffee beans to your local coffee shop. There's no barista anymore to make you your special coffee. And moreover, there's also nobody to drive the train that takes you to work. There's nobody to make sure that your salary gets paid. There's nobody to maintain IT structures that are necessary to, for instance, have webinars like this. So the reason to want to contain this virus is to protect individuals, but also to protect society. And if we focus within that societal perspective on hospitals, we get to the main reason we're implementing very harsh measures in many countries in Europe and globally now. So in this graph, and this graph is just a sketch, it doesn't have numbers, it's just to bring across the idea of what we're trying to do. If you look at the light blue curve, you can see a typical epidemic curve with exponential growth in the beginning, and then at a certain point, the number of people left that are susceptible to the disease decreases, and then the epidemic stops growing and eventually dies out. That's typically what an epidemic of an infectious disease looks like. What you can also see is that, and this it's a random point, but let's say the maximum healthcare system capacity is where the blue dotted line is. What you can see is that in a typical epidemic, if the whole world is susceptible, we will very quickly reach the maximum capacity of an upskilled healthcare system. That means that there will be no hospital beds, no personnel to care for people anymore, and your whole healthcare system essentially collapses. And that is something we need to prevent at all costs if we can. So the aim is not to kind of decrease the area under the curve, but the aim of all these measures is to flatten the curve, as we say, and there's also a Twitter handle for that. So even if the area under the curve of the light blue curve and the darker blue curve are the same, that's not exactly true in this graph, it's just bad drawing, I'm sorry for that. But what you want to do is you want to delay it. You want to smear it out over a longer period of time so that you can stay under the maximum capacity of your healthcare system. That's the idea of flattening the curve. So then that brings us to the third question, which is how do you do that? And the very simple answer to that is you just make sure humans don't have contact. In the media, this is sometimes called social distancing. I prefer physical distancing because even though we have to be physically apart, I think we should aim to stay socially connected, however hard that is. So that's a very simple thing to say, but it can be very hard to implement. So how can we implement physical distancing strategies? So the most effective strategy depends on many, many factors. What you could think of is measures like you are seeing now, school closures, advising people to work from home, stopping social gatherings, stopping sports, games, closing musea, even closing restaurants, bars, and shops. All these things are measures to keep people physically distant. Which one works is dependent on many, many factors. You can imagine that for a country like New Zealand, which is an island, it may be relatively easy to stop infected people coming in by shutting down travel. For a country like the Netherlands, where I live, this is much more difficult. We're also much more densely populated, so you can imagine that different things work for different countries just by the geographic structure that it has and also the cultural structure that a country has. And essentially, again, this is not very different from what was done in the past. If you look at newspapers from the 1918 influenza pandemic, so the Spanish flu, you can see newspapers talking about school closures and closures of shows and theaters. You can see in the picture on the right that also for this pandemic, it was advised to do cough hygiene and sneeze in your handkerchief. It was said that this was spread by droplets, just like now. So in this respect, not much has changed in the last 102 years. So back to how we can prevent this epidemic from growing, how we can contain and mitigate this pandemic. So a variable that's spoken often about in the media is the R0 or R0. You can see that in the bottom of the screen. In this picture, the R0 is 3. That means that on average, each person infects 3 other people. And you can see very clearly here, this is what causes exponential growth of an epidemic. But this is not a figure that will tell you everything, because typically an epidemic doesn't spread like this. It spreads maybe through super spreading events, like in this pandemic we saw in South Korea with the large number of infections in a religious community. And also containment and mitigation measures have an effect on how the epidemic spreads. We then call that the effective reproduction number, or the RE. I'm just saying that to tell you the R0 will not tell you everything. It's just an average. It won't tell you everything about the epidemic or the pandemic. What we do know is to stop an epidemic, you have to get the R0, so the average reproduction number. So that's what we're trying to do by containment and mitigation efforts. And there are 3 rules for how you can do containment and mitigation. The first rule is you have to be really, really quick. And to explain a little bit more about that, I want to show you a 1.5-minute video of Mike Ryan from the WHO, who can explain much clearer than I can how to do this in a pandemic, how to be quick. And we'll have to switch to a video right now. So I'll stop talking and see if we can do that.
I think what we've learned in Ebola outbreaks is you need to react quickly. You need to go after the virus. You need to stop the chains of transmission. You need to engage with communities very deeply. Community acceptance is hugely important. You need to be coordinated. You need to be coherent. You need to look at the other sectoral impacts, the schools and security and economic. So it's essentially many of those same lessons, but the lessons I've learned after so many Ebola outbreaks in my career are: be fast, have no regrets. You must be the first mover. The virus will always get you if you don't move quickly, and you need to be prepared. And I say this, one of the great things in emergency response, and anyone who's involved in emergency response will know this, if you need to be right before you move, you will never win. Perfection is the enemy of the good when it comes to emergency management. Speed trumps perfection. And the problem in society we have at the moment is everyone is afraid of making a mistake. Everyone is afraid of the consequence of error. But the greatest error is not to move. The greatest error is to be paralyzed by the fear of failure. And I think that's the single biggest lesson I've learned in Ebola responses in the past.
Thank you. Am I back? So as I said before the video, the first rule of containment and mitigation strategies is you have to move fast. The second rule is not everything is clear right from the beginning. In the beginning of an epidemic, it's always as if you can see only half of what's going on. You're kind of looking through half-closed blinds and you don't see the whole picture. And that immediately leads to the third rule, which is mistakes will be made. Because you have to make 100% of the decisions with 50% of the information, as our Prime Minister recently said rightly, There will be things that in retrospect could or should have been done differently. But the problem is you have to make those decisions at that point. And so you will make mistakes, I will make mistakes, everybody will make mistakes. I think as long as the people deciding on containment and mitigation efforts can do their work based on the best available evidence, considering the situation as it is at that point, and acting in good faith, that's about all we can expect. And as ICU doctors, we're very used to doing this. We're very used to making decisions based on half the evidence. So we, of all people, should kind of try and understand that principle. So as an ICU community, I think we have a large task in this epidemic. Many people will end up in the ICU. And even though we all have our own worries, maybe personally or for our families or people that we know, even though we're working under extremely stressful circumstances, even if we feel overwhelmed, I think we have a responsibility to do something good for our patients. And that means, and I know that many people who may be listening, who are already in the midst of this outbreak, already completely overwhelmed with clinical work, it will be hard for them to hear this, but I think the only way we can help is by at least trying to contribute to research. Because if we don't investigate things in this outbreak, we will not learn anything. And that's a disservice to our patients. And we can look at the modelers, the virologists, the epidemiologists, who've shown us that an amazing amount of work can be done in an amazingly short time frame. So I just want to say that I think we should try and do that. And I respect that we can't always do all of that, but we should try and contribute to research, because we will not learn from this epidemic, and that would be devastating for future patients. So then, now that we know what containment and mitigation is, we've covered why we want to, and we've also talked about how we can do that. I just want to prepare you for what comes at the end, because even if you've instigated containment and mitigation measures, it's not over, especially not in the ICU. And to explain this, I'm going to use a couple of pictures that I've borrowed from Professor Birch from his Twitter handle, is on the left side of the slide. And this, I think, really shows you what you can expect, even if containment and mitigation efforts work. So if you consider patients to be water, and water comes out of the tap, and then it flows through a hose as pre-symptomatic infected individuals. And then when they become infected and become more ill, these patients have to go into the hospital. And you can see there at the lower left where hospitalized infected individuals run out of the hose. And then at the end of the picture in the bottom, there are the recovered individuals. So at the point where your containment and mitigation efforts work, you have no new infections, what you have to realize is that there's still a huge number of patients of water in the hose. And these people will develop from being asymptomatic to becoming symptomatic and maybe needing hospital or ICU care. So your ICU can still be overflown. It can still cross a critical threshold for what you can do. And in the end, your hospital and your ICU can still become beyond capacity, even if containment and mitigation measures work. We need a bit of time to see what the effect of these measures is, but it doesn't mean the flow of patients will stop immediately. So in summary, we've talked about what containment and mitigation is, that the reason that we do it is as a benefit for individuals, but especially for society and the healthcare system, to prevent the healthcare system from collapsing. We call that flatten the curve. And to be successful, we need to move fast, we need to accept unknowns, and we also need to accept that we will make mistakes because information is continually changing. Thank you for your attention, and I'd be happy to take any questions at the end of this session. Thank you.
Thank you very much, Dr. Derde, for that very interesting talk. I would now like to introduce Professor Armand Gerbes. Professor Gerbes will speak on ICU contingency planning. He's full professor in intensive care medicine and chairman of the Department of Intensive Care at the University Hospital VU Medical Center, Amsterdam. He is also a practicing intensivist, internist, and clinical pharmacologist. Armand is the current chair of the ESICM Division of Scientific Affairs and actively involved in the education program for the University VU Amsterdam for intensive care and emergency medicine. He is a member of the editorial boards of Hospital ICU Management and Intensive Care Medicine. Thank you, Armand.
Thank you very much. Thank you all very much for attending this webinar. I will talk about the ICU contingency planning. And contingency means that you talk about eventuality and unforeseen, and that seems to be quite opposed to planning. So in fact, the title I was given is an oxymoron. Nevertheless, we face with the COVID-19 disease, a pandemic, with a large worldwide upscaling of ICU resources that are necessary. And this means upscaling of hardware, which means the ventilator, the monitor, renal replacement therapy, perfusers, and in some cases also ECMO in some institutions. Upscaling of the infrastructure in terms of making places available for intensive care, the operation room, the coronary care units, medium care, post-anesthetic care units, change the supply, disposables that needs to be well arranged, and pharmacy logistics, and also personal protection and measures and equipment that needs to be upscaled. And that also means that you have to change some routings. And finally, of course, the staff and nurses and physicians that need to be upscaled. Now, if we look at this picture, we can see there is a difference in starting position for different countries. For instance, in the United States, there are almost 35 ICU beds per 100,000 inhabitants, whereas this is much lower in India, 2.3. And my country, the Netherlands, is at 7 ICU beds per 100,000 inhabitants. Now, most hospitals and most ICUs, they have their plans for the disaster, and most of these plans are designs for earthquake, terror attack, airplane crash, submersion, fire, whatever, and mostly they take into account that it is very temporarily. And most Western hospitals with the ICUs, they start with well-organized ICUs, with intensivist, closed format system with ICU nurses, etc. There are in the coronavirus disease some debilitating factors that make things more difficult. It is, first of all, it's a pandemic at this time, and it also means that you can have a lot of cases where you have dropout of staff and nurse staff. I just got 10 minutes ago a message from one of our staff members that he was also tested positive, and he's now out of our team and to stay at home. So, and you are not only concerned about this, you're also concerned about what this does for the schedule that you have made. And furthermore, a lot of staff and nurses are tested, and this takes a lot of time. In my hospital, it can take sometimes more than 1 to 2 days. It's a long-standing pandemic, probably, and it's, of course, by definition, worldwide. We have unprecedented shortages for the Western ICU. So that means that we have a shortage of tests, we have a shortage of protection equipment for the employees, we have a shortage of equipment for the ICU, and there is also a shortage of drugs is imminent. For instance, for muscle relaxants and for propofol, as we were just being told. And so the most important thing, of course, for good contingency planning is that you are prepared. So we were very grateful with the letter of our Italian colleagues And you can work on that, and means if you have to work on the hardware, you just confiscate all the available devices. Ventilators that were in training places where nurses and doctors were trained were confiscated. For the research, ventilators planned to be used for animal studies, confiscated. And the same holds true for monitors, renal replacement therapy. And you also confiscate places in the hospital, like the post-anesthetic care unit. The infrastructure and logistics, you have to make other routings. If you change part, in fact, of your hospital by making more parts an ICU. And very important is, of course, the staff, nurses and physicians that require training. But not to forget other employees like the cleaning persons and the technicians. They need to be trained as well. And there are, with respect to the hardware, there are some pitfalls. The compatibility, are these hardware, these devices that we're going to use compatible with what we have? There is a need for disposables. If you have new hardware, do we also have the disposables? And then, of course, there's the lack of training and the familiarity with this. Some of this equipment is not really designed for the ICU or not designed for virus safety. And there may be other pitfalls that I do not mention. There are some other pitfalls, is that in terms of changing logistics, we just heard how quickly it went in Italy to change the bureaucracy, but this is not in every country the same, and we have to do with people who are used to standard bureaucratic procedures, and sometimes also with insufficient sense of urgency, and coordination may turn out to be very difficult. And not to forget, there is also a tension on solidarity. I will not say that there is no solidarity, but there is a tension on the solidarity. We have to train our nurses and physicians, and therefore you need to select different groups of expertise of nurses, and you have to decide which ones, and the same holds true of physicians. Which physicians are you going to ask, and in which group of expertise do you want to put them? And it's not only about teaching intensive care medicine or helping in the intensive care, it's also about supplying information and anticipate fear and anxiousness about the safety of everybody. And you have to organize fast-track courses. You have to anticipate, when you train all these people, that they have to work under new conditions and in new teams. And with different backgrounds they have, and they have a different mode of working. I can give you an example. There are specialties where people are used to work in quite a military mode with short sentences and quick orders, whereas other specialties have more of a long-standing discussion. And all of these people now have to work together. And they also have to fulfill for them unusual tasks, which will give them very easily a feeling of deficiency, and they will feel very uncertain about it. Now, the basic rules to implement this is, of course, that you want intensivists only to do what they know best, and other things that they know to do very well, but others can do that, you should have that be done by others. And the same holds true for the ICU nurses. Some other very important basic rule is to prevent exhaustion from the beginning. The temptation to exhaust people is very big, but you should really have a policy on that to prevent that. Furthermore, you have to accept that you are going to work according to different standards. And I compare that sometimes to wartime. So this is the very safe situation, as all of us and all the nurses, at least in the Netherlands, and in other countries as well, are used to. They work as one nurse for one or two patients, and this makes them feel very comfortable. But all of a sudden we have more beds that they have to take care of, and they have to be a little bit more on a distance, and they get some help from different groups that had these fast-track courses, and then it means that they have also a different role. and have to communicate with these auxiliary nurses for this specific part. And the same holds true, of course, for the intensivist. So in fact, this different way of working is a huge experiment, and it needs explanation and motivation, and people need to be taught, and people need to teach about their specific competencies. Very important in such situation is that people give compliments to each other and be very flexible and be willing to do uncommon tasks, especially below, between brackets, below your level of expertise and training. And I heard medical specialists say, well, you can ask me to do that, but, well, can't you ask someone from the research? And you explain that you want someone who is able to handle people who are completely have under muscle relaxants, and that you have to know about that, and that you cannot ask someone who works normally in the laboratory. So which kind of auxiliary troops do you look for the intensivist? Well, very close to us, of course, the anesthesiologist. And you must also realize that internists, pulmonologists are already very busy on the ward. Geriatricians and oncologists and pain doctors can be very good in family conversations, and so they should be asked for that. With respect to the fellows of the intensive care for auxiliary troops, are mostly found in anesthesia and surgery. And elective surgery is in general skipped, at least in the beginning. Some practical tips I have is to organize care for the healthcare workers. We will have a tremendous wave, epidemics of post-traumatic stress syndrome if we do not take care of this. So we involved very early psychologists to work on this and to work on the prevention of PTSS, to make buddies and have a check-in and a check-out, and trying to pamper the healthcare workers with food, fruit, and drinks. And as much as possible, organize practical issues for the healthcare workers. They have a lot of worries, so they shouldn't have worries about coming to the hospital by car, organizing the kindergarten, food and shopping. It should be arranged for them. But there were some things that were completely out of our hands and that were not according to our planning. We had a careful plan about a triage that we would do, as is our common practice, make a very careful triage of which patient should have benefit, could have benefit from intensive care treatment and which patient not. And what we see now is that we have a lot of patients coming intubated from other centers. So this is not optimal in terms of triage in the COVID-19 pandemics. Some other practical tips is make a task-directed teams like turning and proning teams, decubitus check teams, lines check, and create a COVID intubation team. What can easily be forgotten is the family, and therefore you have to organize very well family contact. Normally family contact is a very important part of our work, but intensivists can be used for specific tasks, and family contact can also be done by experienced communication physicians who can then schedule conversations with the family, and the intensivist can then do other things. And you can also create by iPad telecommunication from the intensive care to the family, also taking care of privacy. There is one forgotten issue, is that how do we organize the good care for the other patients who need ICU? There are many patients who have higher survival rates than our COVID-19 patients. And there are patients who are in a treatment plan with the chemoradiation surgery plan. And this is, of course, outside the topic of my talk, but it should be in the planning. And did we really think about spreading ICU resources? Because the main focus is now completely on COVID-19. So I have a final advice is take care of your own health and of your co-workers. And I give you a very warm thank you for listening to me.
Okay, thank you very much, Professor Gervais, for that really interesting discussion on contingency planning. We now move to the third speaker in the session. This is Dr. Carole Boulanger, and she will speak on ICU capacities and nurse work planning. Carole is a consultant advanced critical care practitioner and a nurse at the Royal Devon and Exeter NHS Foundation Trust in Exeter, in the UK. Alongside practicing as an advanced critical care practitioner in her ICU, she has active involvement in the development of the role of the advanced critical care practitioner. Currently co-chair of the Faculty of Intensive Care Medicine in the UK, ACCP Advisory Group, Carole was awarded Honorary Fellowship of the faculty in 2017. She is the elected chair of the National Association of Advanced Critical Care Practitioners and an active member and former chair of the ESICM Nursing and AHP Committee, which represents the interests of nurses and AHPs within ESICM. Carole Boulanger's talk will be a recorded talk because of difficulties with the web. But she will be available for questions at the end of the talk. Thank you, Carole.
Good afternoon. My name's Carole Boulanger. I'm going to be talking through some of the challenges and some potential solutions for increasing ICU nursing capacity and managing nursing workload during a COVID pandemic. To understand, it's important to be aware that we were starting from a position of a significant vacancy factor, almost 10% in the UK, and a situation where normal business is maintained using bank and agency nurses. Also important to note that it takes around 12 months to have the knowledge, skills and competencies to care for an ICU patient. That's inclusive of a 6-week supernumerary period. Retention of ICU staff has been a challenge that's well recognised, and some of the ethical issues around end-of-life decisions, irregular and long shift patterns, short staffing and increased patient ratios all lead to burnout. These are all situations that we're bringing trained ICU nurses into, and also those who've had no exposure potentially to ICU before. The challenge is to provide staff who are able to care for patients in weeks or days. However, it's really important not to have the expectation that incoming staff to support can or should have an accelerated or condensed training to the same level. The time it takes to train an ICU nurse has been established over many decades. We have days, or if lucky, a couple of weeks to teach the essentials, which will very much relate to task and keeping the patient safe as a baseline. Important for all that, additional staff coming in are significantly valued for their contribution and reassured of what is to be expected of them, and that is not to turn them into an ICU nurse. We've learned a great deal of lessons from Italy and Wuhan, and it's important to note all of these. It's important to be aware that 15% of healthcare workers have been infected and therefore considered high risk. Healthcare workers can and do die, and this raises the anxiety levels for all, and not least those who have no context or experience of an ICU patient. The staff at the bedside are a major asset who need to be equally cared for in this, and that's important all the way through. The impact of PPE is significant at all levels. It forms a significant barrier between the patient and the nurse, and also the nurse and his or her colleagues. The focus for now is on protecting the staff member from the patient, where the risks are significant. There are nursing considerations for existing ICU staff. It's important to focus on preparation while and if you can, and this is about preparation to work in a new way. ICU nurses will be supervisors of aspects of care for multiple patients rather than managing complete episodes of care. This is significantly different. There are increased pressures of teaching and training of staff in the pre-surge period, and the redeployed staff will be anxious and may be reluctant. We have to train existing ICU nurses to supervise aspects of care and move from caring for one patient potentially up to 4 or more with non-ICU trained support, a significant mind shift and significantly at odds with how we've been taught to nurse in the ICU setting. Teaching others about ICU nursing in short time, in limited sound bites, puts an additional pressure on the ICU workforce, already anxious about the impending or actual significant workload of COVID. Existing ICU nurses will have to supervise others who may be more senior in their own specialty, which requires careful handling. That said, this is offset probably by the anxiety of those new to ICU patients and practices, and improves the all-in-it-together mentality. Expanding the critical care nursing workforce should ideally happen in a phased response in line with expansion of beds. In the early phases, there are high numbers keen to learn and be side-skilled. This places additional pressure on ICU staff and also requires careful management. Also really important to consider the long haul and that additional staff will be required for weeks and months, not days. Building resilience into the staff numbers and skill mix are a significant priority. We need to prepare for a marathon and not a sprint. In terms of who can increase our nursing capacity, those with recent ICU experience are ideal, as only a refresher should be needed. Recent retirees also a useful resource, not only to care for the patients but also to use their experience to support the staff going forwards. There are some advantages to registered nurses, however, with no ICU skills, as they may feel happier with task and clear direction. The time for all the potential groups to be confident and comfortable will vary. How do we increase nursing capacity? There are various ways. Simulation training can be very valuable, obviously orientation to the area, video snapshots of key aspects of care and management, and additional educational resources such as clinical guidelines and educational packages should be easily available to all the multi-professionals who may be working in unfamiliar situations. It's really important to remember you're not trying to create ICU nurses, but those who can safely support aspects of care delivery. There are many flashcards available to assist non-ICU staff and remind them of the fundamentals, principally the issues that they may need to be concerned about. There are significant challenges in day-to-day care delivery. Most importantly is about managing expectations. We cannot deliver to the standard we are used to with increased numbers such as we are facing right now. It's about minimising risk and complications. And the care may not be perfect in the sense of a pre-pandemic ICU, but we need to do the best we can for as many as we can. Delivering care in PPE is a significant challenge. It's hot, it's uncomfortable, and has significant impact on us physiologically, and that slows us down and increases workload, and everything takes longer. Staff will tire more easily, and it's really important to make sure that there are more breaks for hydration and food. Documentation is potentially a challenge. It's about adhering to key principles and ensuring that anyone could safely take over the patient's care without a detailed handover. Documentation for the key elements only and some lean charting. It's about having consistency across patients, so when non-ICU staff are returning on shift, there is some familiarity in the documentation that is required. What is absolutely key is making sure that there is a key plan for every patient with very clear goals and parameters at ward round, escalation points, at what point do they need to be concerned, how do they raise those concerns and to whom. Shift management. Teams on each shift may have only just met with a wide variety of knowledge, skills and competencies and, importantly, confidence. We need to find a rapid method to generate a team culture, spirit, and of course identity. We are in it together. Check in and check out as recommended by psychologists as a good way of ensuring the people you are working with are okay, asking how everyone is, making sure introductions are completed, and listening to be aware of someone who may be struggling Daily or shift-related buddy systems ensure that everyone has someone they can turn to on a shift, whose responsibility is to look out for them and vice versa. What is really important is making sure that there are significant breaks from PPE as part of the key focus for organising the shift. Everybody has seen the photographs of the Italian and Chinese nurses with pressure ulcers on their face from the PPE. It's a significant issue that we can address by making sure that we rotate people in and out of PPE as much as we can. The staff room should be a safe place psychologically, but we need to be monitoring for signs of people finding the whole situation too distressing. The priorities are significantly altered here as the staff become parallel to the patient. Equipment and environment. The logistics of providing ICU care and non-ICU environment are well recognised. So the importance of safety checks and buddy systems and standardisation of equipment. Simple things like sealing doors, strict entry and exit criteria, and establishing a process for calling for help, especially in side rooms with no eye contact where people may feel significantly isolated. Walkie-talkies have been effective in this regard. There are significant challenges for the staff, both those supervising and those working on the shift, managing a roster and a team that will likely change daily, minimising risk by clear goals for the day, parameters and escalation points. There will be those who feel the concerns around their accountability by working in these times. Sickness management, there will be a significant amount of sickness and those who will need to self-isolate, and how we manage the guilt those individuals feel when they're off work. Also, there'll be anxieties around coming to work for many. Working in forms of PPE are not new. However, the risk to the patient is not from the staff member, it's from the patient to the staff. Knowing you can risk taking a potentially life-threatening disease home to loved ones is not to be taken lightly. The ICU nurse usually builds strong relationships with patients and their families. We're not able to do this with, in most hospitals, a visitor's ban for COVID-19 patients. There are also significant concerns over the assumptions around non-ICU staff will cope with high mortality in addition to ICU patient care. Some of these individuals may not have seen death on any scale, never mind this. Managing end of life is a key challenge as this may well be the first face-to-face contact with families, when we're used to building a therapeutic relationship with our patients from admission. It's also a challenge in supporting those less familiar with end-of-life care and making sure that those families, even at the end-of-life process, still maintain their distance, with PPE being a significant intrusion. So there are some key principles. Divert as senior and ICU nurse as possible to managing the end-of-life process. Prepare for the new team to need to debrief, and there are some challenges around providing this space. Psychological support cannot be emphasised highly enough. The impact of the team working approach and caring for increased volumes of sick patients, many of whom will die, must not be underestimated. Early psychological support should be put in place, and reinforcement of it's okay not to be okay, and a range of methods of support so that people can access what feels most appropriate to them. Check in and check out is a useful way of making sure that people are okay before they go home, plus welfare calls when people have had a bad day or are sick. It's really hard when staff are uncomfortable or upset and you can't give someone a hug. We've lost that compassionate touch. We need to find ways of vocalising methods to communicate and reach people and provide them with support. Building in resilience in challenging times. Resilience is not innate. It's what we do makes a difference. So one area of staff well-being which has been examined in much more detail is resilience, both in studies and feedback from Wuhan. The key point here is that the responsibility does lie with the ICU. It's not just up to the individual registered nurse to develop resilience. It's everybody's business. There are various ICU-related strategies that can help. Communication methods during isolation inside rooms, managing patient and family distress, monitoring workload, telephone support often on duty, effective leadership. Expect frustrations and work out ways to express that. Communication, encourage talking, lots of talking. And don't shut down humour. It's for many people the way they cope. Good end-of-life care and support for new to ICU staff before and after C19 and accept that this may be prolonged. There are personal strategies around eating well, about mindfulness, about social support, good advice to people around limiting social media to those that are supportive and avoiding overload. The little things matter. Food, hydration, hand, face care, somewhere to shower and change pre-home, someone checking in when you're off sick, insisting on days off, acknowledging it's tough and will continue to be so for a protracted period, saying thank you, not such a little thing. Post-pandemic, we need to be planning in ongoing supports and accept that the effects may be long-lasting, and reinforcements of some of the successes, which may be supporting a dignified death. Time to reflect and grieve as a different team, much larger and more diverse than we were before. Acceptance that we may well have a new normal in ICU care. So some key take-home messages. Prepare, prepare, prepare. Expect frequent changes to your plans. Caring for the staff will translate into caring for the patients. Don't underestimate the physical, psychological and emotional impact on the team, which may be long-lasting. Remember, we're not trying to shortcut training to an ICU nurse, just provide safe aspects of care. We need to plan for a marathon and not a sprint, and look after each other as well as we look after our patients.
Okay. Thank you very much. Dr. Boulanger, for your So I'm now going to welcome back all three speakers, and we're going to start with some questions.
There is a huge echo.
Yes, there is.
Someone switch off their sound. Okay.
Is it better? Okay.
Yeah.
So I will start with some questions for Dr. Durd. So the first question is that there has been a lot of variation in containment strategies across countries in Europe. And how has this affected the spread? And you know, is this causing a problem in terms of our response to COVID?
So that's a really tough question to answer, because it's very hard to say how things would have developed if we would have made other decisions. So the problem for governments is, in retrospect, they're always proven wrong. So if in truth an epidemic is huge and they implement measures fast, then as a result of that, the epidemic will be less large, right? So in retrospect, everybody will say, wow, these measures were quite heavy and the epidemic was not that big. It also works the other way around. If in truth there's a relatively mild epidemic and a government would say, you know, okay, we're going to instigate some measures, but it doesn't need to be very, very strict. And then, you know, there still is something of a pandemic. Then in retrospect, everybody will say, you know, there was still an epidemic or a pandemic. Why weren't you stricter? So it's very hard to assess, or even now, or also in a couple of months, whether we made the right decisions. I do agree with how Mike Ryan says it. I mean, you have to do something fast. You can't, sit back and relax. But which measures are exactly appropriate at which point in the pandemic? That's really, really a tough call. And I think the people making those decisions, as long as they have the most updated information and they base themselves on true expertise, then that's, I think, the best we can do. And there's no better way to do it.
Okay, thank you. So some countries that would seem to be quite similar, such as we'll say Belgium and the Netherlands, have taken different strategies on some containment measures. What is the role for countries with similar configurations to group together and have common strategies?
So I think the devil is always in the details. So even though you may think that Belgium and the Netherlands look alike, the school systems are different. It's also a cultural thing, which is not very scientific maybe, but it is true. So I think so for instance, in the Netherlands, the approach that people most value is an approach where they are kind of allowed to have some form of autonomy. Autonomy is a very big thing. People don't want to be told something. So if you approach Dutch people and you say, okay, do this, do it all, and do it now, it'll probably fail. If you explain to them how it works and you ask them to be collaborative and you give them a little bit of autonomy, but you explain very well what they have to do, that may work better. So I think it's a very difficult field because it involves social sciences, it involves risk communication, it involves modeling. It's very, very difficult, but there are probably a lot of differences between Belgium and the Netherlands that can explain the different decisions that were made.
Okay, thank you. So do you see, or what do you see as the role of policing and enforcement in regard to social distancing measures?
That probably also differs from country to country. I mean, we do see it even here. So if you look at the crime figures over the last couple of weeks, we can see that there are, for instance, less break-ins in houses, less car theft and stuff. How are you going to break into a house if everybody is working at home? But what we also see is an increase in kind of unrest. People living on top of each other in small spaces, sometimes without a garden, in this densely populated country. That's difficult. And I do think police and other law enforcing authorities have to be prepared for that, and they are. So yeah, they play a role, but exactly what they have to do and how they prepare, first of all, I'm not an expert on that, and secondly, again, I think it differs a lot between countries.
Okay, thank you. So the last question for you then is in regard to curve flattening. So somebody has asked if we are successful in curve flattening, this makes the pandemic duration longer. And how long do we think it will take with curve flattening measures?
It's difficult to keep repeating the same unsure story, but that depends, I think. So what we know is that this is a long disease. So people on average are in the ICU for longer than a week. So that means that, as long as the flow of patients coming in is bigger than the flow of patients going out, because they all stay for a very long time, then your need for capacity will still increase. And it's very hard to make predictions, especially about the future. I don't know who said that, but it's true. And it also depends on where in the curve you are with your country, and also how much of the top of the curve you manage to take off. But it's very true that if you flatten the curve, you will suffer for longer. But that's definitely worth it if it keeps your healthcare system up and running.
Yes. Thank you very much. Questions now from the audience in regard for Professor Gearbes. In contingency planning, a lot of effort and emphasis has been put on ventilators. What are the other key items we should be focusing on when we're upscaling our ICU capacity?
Well, the most important thing is, of course, about the employees, the healthcare workers. We see this also in the Netherlands, that politicians think that if they buy 1,000 ventilators, that the problem is solved, which is not the case. So it's good to point at the fact that it is not solved by buying a lot of ventilators, which is, by the way, quite difficult at this moment because everybody had the same idea to buy extra ventilators. So yeah, we should also acknowledge the fact that there are limitations to our resources. And that's especially why I mentioned that we should have a policy, a helicopter view about what we do with other patients that need intensive care and other patients that have higher rates of survival, higher chances to survive. And it's my personal feeling that we jump very much on everything on COVID, which is of course an horrible disease. But if you look at the survival rate of the patients that went to the intensive care, and you take into account the amount of money that we spend for those patients, and at the same time, patients with much lower risks for mortality that we refuse, I think this really needs to be thought over, because this will probably not be for only a few days or perhaps a couple of weeks. This will be for much longer. And I think that we also, as intensivists, we should think about what about all the other patients? And we are all of a sudden faced with a limitation, a severe limitation of resources that we have.
Yes, thank you. So there is a balance to be struck between opening as many ICU level beds as possible and the quality of care that you can give to those patients. How are you balancing that in your intensive care unit?
Well, that is very difficult to say, because we are now at the start of this local epidemics and a huge amount of admission of patients, and it's something that you have to look at all the time. And there comes it's very clear that the level of care is downgraded. I practiced intensive care for a very long time with nurses on a standard of one nurse for one patient or two patients. And we did not see decubitus in the face when these patients were in prone positioning. And I now see it. There is an indication of some decubitus. So the care is definitely at a lower level than it was before. And the question, of course, is whether it is still enough. And well, we do our utmost best to have it enough. And I think it's good enough at this moment. But well, there comes a point also when people get exhausted. And so I'm very curious about the Italian experiences after several weeks, how they cope with that. Because we will have also, you must also realize, if this will carry on for a long, long time, what will happen to all our people? And they have not had holidays, they do not have normal time to sleep and to recover. So this will have an enormous effect on the time that is in our near future. And I do not have the definite answer for that, and something that you have to see, and is very dependent on local factors, of course. But we need to think a little bit more about that than we perhaps do at this moment. And a lot of people probably do already, but it has to be more also in the discussion about how are we going to guarantee sufficient and good quality of intensive care medicine and medicine in general for our population.
So some people are considering reprocessing single-use devices due to supply chain interruptions. Do you have any experience of that?
Yes, because we have a shortage of face masks, and there has now been a procedure to reuse some of them. And what you see already is that you have some sort of downgrading of policies that are advised also for the protection of our people. And it was in the past very easy because there was no shortage of anything. So if you would ask what mask do you want for that, then you would just answer the very best. And well, perhaps the difference between the very best and the best is not so very big, but you would take the very best. And now people say, well, the best is also good enough. And we also say now, yeah, we are going to reuse it. And so you have to be very careful about that. And I think that it has been tested how you can reuse these face masks. And I think it's very well done and sure. So you are just changing a little bit your standards. And well, we should be all the time very careful about how much we will accept for what we thought 1 year ago was not the standard.
Thank you. Thank you very much. So questions now for Karl Boulanger. So Karl, there's a lot of concern about burnout in our ICU teams. What practical tips do you have to detect burnout in ICU nurses and doctors and other healthcare workers?
I think burnout was a significant concern even before C19. And now we've got a situation where we've got people working with teams that they don't normally work with. So significantly more of a risk, I think. Certainly our thoughts would be to have early psychological support and advice about strategies to put in place early on in the pandemic. We've been very lucky in the UK. We've had a few weeks where we've been able to use the data from Wuhan and from Italy to put in place some psychological support for our staff. But it's not straightforward and it's not easy, and it's one of the biggest concerns going forward with this, about building some resilience into the team. Things like checking in and checking out, and actually actively seeking out the welfare of the people that we're working with, and they may be people that we've never worked with before. It's a significant challenge, but it's around setting out a foundation of looking closely after each other, because without that we can't look after the patients.
Yes, thank you. So you mentioned telephone support as a mechanism. How would you do that, and who would do it?
Well, we've got quite a few staff at the moment who are at home self-isolating, who may have mild symptoms or have somebody in the household who has symptoms. These individuals are very frustrated. They want to be in work, they want to be helping, and they want to be supporting. And actually giving these people a group of people to phone and check in on, just to see how they're doing, seems to be proving to be quite a useful link, not only for the person who's feeling guilty for being at home and they can't be in work, but also for those people who are unwell or who can raise concern that they've had a bad day or are finding things difficult. It means that there's always somebody to buddy up with.
Okay, thank you. And the last question is a similar question to what I asked Prof. Gerbes, but I'd like your perspective from the nursing side, which is how we balance staffing as many beds as possible with giving high quality care. So how can we do that when we're having people, nurses especially, working outside of their area of expertise?
I think sadly it means going back to task-based nursing, which many years ago was what used to happen. There would be rounds for turning patients, rounds for mouth care, eye care, and so on. And I think as ICU nurses, it's about us supervising and supporting people in managing those individual aspects of care rather than episodes of care. So it's a completely different mind shift from the way that we're used to nursing. But also it's accepting that things will not be the perfect that we want it to be. And it's about doing the very best we can for as many as we can. And that is a challenge because there will be more pressure ulcers potentially. There potentially may be more adverse events around access, around drug administration and so on. And that's going to be very difficult. And I think that's one of the difficulties of being an ICU nurse in this setting is that you want to do the very best and you're used to doing the very best for one or two patients. Being able to do that in a supervisory capacity is very difficult. That said, the people who are coming in to support us from theatre, recovery and healthcare workers of all ranges, their interest is in delivering high quality care too. And it might be simple things that we can teach them to deliver to that individual patient, but that doesn't mean that they're not important. It's just about making sure that we are not trying to generate a whole raft of ITU nurses in short order, because that isn't the case. It's about teaching those elements of care that can be delivered safely by others and supporting them to do that. But it's not easy.
Yes, thank you. So I want to just finish by thanking our three speakers for three excellent talks. Dr. Derde, Professor Gerbes, and Dr. Boulanger. Thank you very much for these talks.
So welcome back, and after a very informative session, it's now time to get some other world updates about the pandemic. So we're going to start with Spain, and it's a pleasure to introduce our next speaker is Professor Ricard Ferrer. Professor Ricard Ferrer is the head of the Department of Intensive Care in Vall-d'Hebron University Hospital in Barcelona and head of the SODIR Group, Vall-d'Hebron Institute of Research. He's current Vice President of the Spanish Society of Critical Care Medicine and a member of the Joint European Society of Intensive Care Medicine, Society of Critical Care Medicine Surviving Sepsis Campaign Steering Committee. Within ESIC, Ricard is the chair of the Systematic Inflammation and Sepsis section and director of the Sepsis and Severe Infection Masterclass. Ricard, it's great to see you. How are you, Ricard?
Fine, and you? Good afternoon to everybody.
Yeah, well, it's tough here, but I know it's tough for you guys in Spain as well. So we are well. We're keeping the morale up, but of course it's tough. We're still hoping we are reaching the peak now. So we look forward to hear what you have to say about Spain now. So please start.
Okay. So this is the current situation in Spain. We have more than 64,000 cases. That means 127 cases per 100,000 inhabitants, and very close to 5,000 deaths. So in this graph, you can see the case variation day by day. This is starting day one when the country has the first day with 150 cases. And you can see here Spain in red. This is logarithmic scale. You can see here Spain in red, which is higher than Italy and France. So in few days, we are going to have a similar situation that you had, that you are having in Italy, in fact. So these are the cases in the ICU in whole Spain, starting 4 March, and how this is growing very fast, and there is not a plateau by now, so it's still increasing. In this graph, you have the situation in Madrid. 1/3 of the cases are in Madrid, and here in yellow, these are the cases in Catalonia, again close to 1/3. So there are problems in many communities, but I have to say that Madrid first, Catalonia a little bit later in time, are concentrating each 1/3 of the cases, and the rest are spread around the country, with some other areas with a lot of cases in the ICU. And here you have on day 13 March, the declaration of a state of alarm, so confination. But look that this was done when we had close to 150 patients already in the ICUs. So we can discuss maybe later, and this is maybe too late when we have such amount of patients in the ICU. So all the contingency plans are already developed. So we have in many ICUs 300% ICU bed that we had at the beginning of the pandemics. For doing that, of course, we have to use many other areas of the hospital outside of the ICU. And now we are starting the expansion of hospitals and ICU in convention center. This is how Madrid is doing that in their convention center in IFEMA. And this is how we are designing modular ICU, probably for expansion in Catalonia, with modules of 48 beds that can be replicated, in this case, maybe up to 2,000 beds, close to a hospital with an umbilical cord linked to a hospital. And those are the plans for the following weeks. So I have to say that the healthcare working are doing a tremendous work. We have new shifts, no holidays, new locations, but we have the support of lay people. So every afternoon we have people applauding us and giving us a lot of support, bringing food to the ICUs. So this is very helpful. But at the same time, the resources are scarce, and most of the new healthcare workers that are starting to work in the ICU are mostly inexperienced. Medical equipment is very scarce. We are using all the ventilators available. That means that we have in place in the ICU ventilators from research facilities, training facilities, a small clinic and small veterinary clinics also. And this is happening also for ventilators. Medication is lacking. Propofol is almost, there is no more propofol. And of course, some antiviral drugs are finished. We don't have clear guidelines. I think this is an international problem because we have to adapt to the new evidence, and this is changing every week or every day. And big problem we have now in Spain is that more than 6,500 healthcare workers have infection by COVID-19. This is much more than in Italy and much more than in China. And of course, this is limiting a lot of staff we have in the ICU, and we have to think about that. So in our local society, SEMICIO, which is the Spanish Society of Intensive Care, we have developed a contingency plan, which is going to be very helpful, and is being very helpful for some units which are not in the situation of Catalonia and Madrid. We have ethical recommendations for ICU admission and invasive mechanical ventilation, but of course, this is not an easy topic. And we are doing weekly teleconference with all heads of departments every Wednesday in the afternoon to share our experience. This is the situation in my unit. So these are the number of cases. We started 3rd of March, and these are the daily number of cases. Now we are intubating between 15 and 20 patients per day, and still growing. This is the number of cases in mechanical ventilation in my department, taking into account that the number of patients that are discharged or are dying is very small at this stage. So we are close to 150 today patients in this extended ICU. So this is the areas where we have extended the ICU. There are new spaces for this week, more than 100 places like this one. Look that we have make a fast installation of a new ICU with new tubes for oxygen, etc., built in just 2 days. But look also that the equipment we're going to use in this temporary ICU is, of course, not the best equipment, because we are using some transport ventilators and etc. So this is our experience. We know that the mortality below 70 years is very low by now. Also, the number of discharges are still very low, but mortality above 70 is high. It's more than 80%. And we are at this stage not admitting these patients anymore in our ICU because the lack of beds. So my key messages, my learning points are that please prepare national contingency plans. Hope the best, but think in the worst scenario. We need a strong health governance. So hospitals alone cannot manage that. We need governance that allocate resources and professionals where really is needed. If the spread is heterogeneous, we need to allocate resources and professionals really where it's needed. Some areas are still with resources, others are finished. We have to start the contention phase before having patients in the ICU. Later is too late, and we have to move to mitigation phase before expected. In fact, we are in a mitigation phase, selecting patients for ICU. Definition of case is very important. You have to recognize very early community transmission and then consider any pneumonia as a suspected cases. This is very important to protect healthcare professionals. Establish uniform criteria for all your area, same criteria for ICU, mechanical ventilation, and ECMO. And of course, if you need to expand your ICU, you have to work in multidisciplinary teams, sometimes including professionals without any experience in intensive care, but they need the leadership of intensivists and anesthetists and work together sometimes with traumatologists and many other specialists without little experience in intensive care, but they need the leadership of intensivists and anesthetists for this situation. So for protecting healthcare workers, I have to say that training is very important. So provide training to the new professionals, especially in PPEs and in high-risk procedures, CPR, intubation, etc. Identify daily the main roles for emergency situation, again, CPR and intubation. Rational use of PPEs is very important because your stocks are going to be reduced very fast, faster than you expect. And try to have a rational use from the beginning is very important. Establish rest time frequently for your healthcare worker. Find convenient areas for that close to your ICU. Establish well-defined coercition zone, especially if you are working in open space areas where it's difficult to have single boxes, but it's better for work, it's much more efficient in open areas, but establish well coercition zones. And of course, prevent moral distress, facilitate access to psychological support, and facilitate fair patient allocation to support your decision-making of your staff. So thank you for attention, and I will wait for the question and answer time later.
Thank you, Ricard. We can actually take some questions now. I have to say, while I was looking at your presentation, I could feel the same feeling and same thoughts that you guys had, because it's very similar to the situation that we had here in terms of increased capacity. First of all, I would like to ask you a detail. I saw that in some areas you've increased your capacity by 300%. Just a detail, because it's very difficult to count what is an ICU bed. Are you talking just about invasive mechanical ventilation, or are you talking also about non-invasive mechanical ventilation and CPAP?
90% of the patients are in invasive mechanical ventilation. The rest 10% are patients who are close to mechanical ventilation, mainly in high flow nasal cannula, and the rest are patients just extubated. So 90% of those patients are in invasive mechanical ventilation. So pneumologists are doing the rest outside of the ICU, and of course with scarce possibilities.
So if you're adding those patients with CPAP or NIV, in some places you're talking about 400 or 500% of the previous capacity of respiratory support, probably.
Right.
Yeah, that's our experience here too. So I was going to ask you, why do you think the situation is so bad in Spain? We clearly had a very bad situation in Lombardy and in Italy, but in Lombardy we were particularly affected. Do you have an explanation for it?
Yes, I have some explanations. First one is that community transmission was very high before containment. So the decision of containment was taken too late. So at this moment, the decision was taken 2 weeks ago. So still we are facing patients who got infected before contention. So we cannot stop the tsunami now. They keep coming to the hospital. Our intubation rate today, yesterday, and day before was 1 patient per hour in my hospital, and those patients were infected before contention. Second one is because we don't have rapid diagnostic tests, so we were not able to split population in patients in people infected and not infected, and this is a very, very, very important topic. So and this is important when we are coming back to the real world. So when doors will be open again, some people, if we don't have rapid diagnostic tests, some people with virus are going to spread the infection again, and we are going to have new cases in the ICU again. So I think that
I suspect for that phase, everyone is looking also the availability of antibody testing to see if there is being some immune response and some memory of immune response in the population. But I was speaking with China the other day, and I don't think they were ready to have it ready spread to the community yet. We are certainly working on it in Italy at the moment, but I don't think we will still have the capacity ready immediately to do that. I wonder how you are doing that in Spain, and if you are planning to work on antibody testing to see whether you could restart at some point the country, because that's certainly one of the thinking that we are doing here in Italy at the moment.
This is a very important topic for healthcare workers. So if I know that some of my staff already have antibodies, they will work much more safe and they will feel much more safe. Of course, they are going to use protections, but if they have immune protection, they will work much more safe. So I think this is very relevant, especially for healthcare workers.
I agree. And one other question, Ricard. I remember you and I, the last time that we saw each other, we were in a conference in America, and we were talking about how to prepare, and everyone was monitoring the situation from China. I suspect that neither of us would have ever imagined to be in this situation 6 weeks after, with basically increasing 5 times the capacity of organ support in our units. If you have to go back in time, what would you do differently, maybe the beginning?
So in the ICUs, we are receiving, as I said, we are receiving something that is 2 weeks old. And I think it's important for other countries to start the contention phase before. And another important topic is that we must learn how we can prevent patient worsening before. So what interventions are useful in the community? Maybe hydroxychloroquine, maybe azithromycin, maybe anti-inflammatory drugs, but we have to give something to patients in the community with a positive test that prevent worsening 1 week later when patients have pneumonia. I think this is very important, because in the ICU, we are just receiving the effects of these interventions. I mean, you can have contingency plans, but what contingency plan can you have for a 400 increase of your ICU capability? I mean, this is impossible. The only thing is try to stop this tsunami before. Contention before you have cases in the ICU, and try to develop strategies to prevent worsening for patients with mild symptoms.
Yeah, I think you're right, and that's why we were trying to work on the recommendations on the WHO, because I agree, I don't think there is any healthcare system in the world that can work with a reserve capacity of ICU of 4 floors that is not utilized normally, and just to carry on. And especially, this comes to my next question. Everyone talks about technology, ventilators, and I suspect if you know it, you can plan for having 4 times ventilators in your storage, and it's a bit of extra cost, but what is very difficult to have is human resources. And I find that in my team, probably the most precious resource that I have in this moment, on top of my doctors, is of course my ICU nurses. And where do you find this workforce, and how do you do it? Carol Boulanger already touched on this before, but I was going to ask you, how do you plan to staff these big facilities that you're doing? We're thinking about similar contingency plans, and we're developing some in Italy, but certainly our biggest struggle now is we don't have enough people in our own hospitals. How do we staff these new places, or these modular ICU units that you have to do? And I know that in the UK, they're thinking about similar plans in the Excel Center, for instance.
So the situation locally is that we are using junior staff that now are going to be senior staff, move to this big facility, and they are going to have the leadership of other staff without experience in intensive care, but he's going to be the leader. So senior staff is managing things. Junior staff is leading bigger teams with another specialist. Also for nurses, so trained nurses are going to be the leaders of unexperienced nurses in intensive care. In each of these facilities, we are open, but we are trying to avoid small ICUs. Sometimes you have to go for 8 beds, maybe in an hemodialysis ward. I prefer to use 40 beds in a big open space. It's not easy to find this in the hospital, and work with these mixed teams, giving some leadership to junior intensivists or anesthetists, and they are going to be the leader of bigger teams. But I think the solution is not in the hospital. This is what we can do at hospital level. The solution is in regional or national or international governance. We need people from other countries, because the areas, the worst areas now are in Lombardy, some areas in Spain, but we need governments. We need that some extra manpower come from other countries, give you some relax to us for 1 week, 2 weeks, and we will keep working. But if we have some people coming for 2 weeks, people from China, people from the rest of Europe, from the north of Europe, that they have a better situation, will be very helpful. But this is governance. This is governance outside of the hospital, and this is very important. But I think we are lacking that.
I think you're right. I think we've been very close as a community of scientists and doctors to share information as much as possible. Bill Gates was giving a speech 5 years ago showing that the possible problem could be a pandemic. And if we are on that, and one of the things that he was suggesting is that probably we should think about, an healthcare army. And I suspect this is what we are lacking at this time in Europe, and probably it's something that we have to think in the future, coming away from this pandemic. How do we support each other for the next one? Because I suspect you're right. Maybe the resources are there, especially if the peak of the outbreak is not always at the same time. So anyway, Ricard, thank you so much, and good luck with the outbreak. I'm sure it will get better for you guys as well. Thank you for everything that you're doing and for all the information that you're sharing with us.
Big hug to you, Mauricio, and big hug to everybody.
Okay, so we move on with our next update, and our next update is this time from Norway. So it's a pleasure to introduce our next speaker. It's again an old friend of mine, of ESIC. It's Professor Hans Flateng. Hans Flateng is a professor and senior consultant at the Haukeland University Hospital in Bergen in Norway. He was medical director of the General ICU from 1994 and 2014, and professor of intensive care medicine since 2004. A member of ESICM since 1996, Hans was the chair of the Division of Professional Development from 2009 to 2012, a past chair of the Society Health Service Research and Outcomes section, and principal investigator of the very old intensive care patient VIP network for the study of this patient. So Hans, welcome. How are you, Hans?
I'm fine. And you, Maurizio, seems to do well, at least as a leader here.
Well, we are doing okay. We hope clearly that the numbers will start to decrease, and we really hope that, but we are holding it there. So Hans, please give us an update on Norway.
I will, and thanks to the Society for hosting such an important event and inviting us in the North to contribute as well. So I'm glad to share some of the experiences from Norway. As you can see here, our number of tested positives is not very high compared to what we've recently heard. We have 3,800, close to 900 tested positive, and we have no more than 302 in hospital today. In the ICU, we have had 128, and 88 is still in ICUs all over Norway. But beware, we are only 5 million people in this country. We have had so far few deaths, only 5 in the ICU. We have had more deaths that have been in old nursery homes, where the mean age is 84. Since we are 5 million people, we have a rather high case per million inhabitants, and we are ranked number 15. And as we recently heard, Italy has 1,400 and Spain close to the same. Within Norway, as you can see to the right here, there is a north-south difference. And in particular, the region around Oslo is the most heavy hit at the moment, with at least some intensive care in some hospitals having a high burden. In the rest of Norway, and in particular the northern part of Norway, the disease burden is rather low at the moment. We started early with general population measures and contingent, finding and tracking important cases, which we have a lot because it's popular to have ski holidays in the Alps, and we have thousands of them coming home, bringing the disease. And people have, for 14 days, for 3 weeks now, had been advised to stay at home, avoid close contact. School and kindergarten closed already March 12th. Restaurants, shops, not allowed with gatherings outside, more than 5 people. And no concerts, of course, theaters, cinemas, etc. And we are even not allowed to go to our vacation home, which is a problem for many Norwegians. This is the development of the total cases in Norway, and we can see here it's a steep increase in the total cases, and also a steep increase in death, but the absolute number, as I said, is rather low, and only 5 of these are in the ICU. We have had some time now, at least 14 days, maybe 3 weeks, to do intensive care preparation. One problem is that our reserve is very low. We have a low number of ICU beds, approximately 5 per 100,000 inhabitants. And we have a lot of intermediate beds, including the most post-operative beds, approximately twice that number. So our immediate action that has been taken to increase ICU capacity and to convert intermediate beds to temporary ICU beds, as we have heard from other countries and hospitals. This managed to increase it to at least 3 times baseline, and taking some other areas as well. We, in some hospitals, may have a 400% increase in ICU beds. That's including the intermediate beds we upgrade. And we try as much as possible to plan areas with cohort isolation, because we know that this will be a less stress than single room isolations, less stress for personal employment. Further increase is planned, but we are not certain about where. It's not very easy for us to build a new hospital, but we will probably try to do it if we have to find other places. One very nice instrument is the Norwegian ICU registry that has been prepared to be a pandemic registry before this pandemic. So we could start having a registry from day one, and we have a day-to-day track of the pandemic, which is very useful because we can very soon use our own data to put into calculators about how the pandemic will be in Norway. So this is a registry started in '98, cover most of Norwegian ICUs, and we have already a corps of registrars throughout the country. So this add-on solution has been very helpful for us already now. And some of the data I will show you comes from this Norwegian ICU registry. Here we can see a day-to-day tracking of what happens from the first patient was entered into our ICU, and this is for the whole country, on March 14th. And yesterday was, of course, the 27th. And this is the number of patients in hospital. And a very interesting figure is the increase in the ratio of ICU patients to hospitalized patients in Norway. It started out by just about 10% and has steadily increased and seems now to flatten out around between 25 and 30%. That means that at least one of 4 patients entering the hospital will eventually end up in the ICU. And this gives us a number to prepare from. And as we've heard, they often get sick while they are in the hospital and then come to the ICU. So just a few patients are entered directly from the emergency room to the ICU. We also have a slightly different age population that I've seen from elsewhere. Very few patients are above 70, only 25%. Most of them are young, middle-aged, and mostly male. We have 3 or 4 patients are male. So here are the bulk of the patients in this age group between 40 and 70. Rather few young people and no children as yet. We have some problems that we will anticipate, and as we've heard, lack of skilled nurses and physicians is a mainstay, and I do think that this will, if the pandemic continues in Norway, be our major problem to have. So we have tried to prepare ourselves. We do crash courses, include medical students, which we have a lot of, to work in the ICU under leadership of ICU physicians, ICU nurses. And of course, we have lack of equipment. Since we have so low number of beds from the beginning, only 5 per 100,000, which is a staffed bed, our surplus of ventilators is not very large. So we have also been looking and hunting high and low to get ventilators, which also will pose a problem. But we try to be creative and use transport ventilators. And we have been successful using non-invasive ventilators for patients prior to coming to the ICU. And we have had several patients on the with NIV and not necessary, and it was not necessary to intubate them. And I think that because we do it a lot, so we have a high quality of that care in Norway. We also have a decreased number of hospital beds per population, as in many other European countries. So that means less beds available for pandemic patients. And we have to really get rid of other patients in order to prepare for pandemic patients. And as is usual, sorry to say, non-updated plans for pandemic handling in many hospitals has been the reality here. And also lack of proper storage of vital equipment and vital drugs at national and regional level is a problem, as we share with the rest of Europe. So this is our initial experiences from a part of Europe where we are not that hard hit. And our numbers seem to flatten out, so it seems that our contingency plan for the population may work, at least temporarily. So thank you for listening.
Thank you, Hans. That was very informative. I was actually looking at your data for the mean age in ICU, which is actually roughly 4 years younger, maybe 5 years younger of our age in Italy. And I do wonder, you still have an old population in Norway. I wonder why you see less patients, less old patients becoming sick. Do you think maybe it has to do with the social structure of our countries? I'm just asking because I don't know. But for instance, one of the things that was mentioned for Spain and for Italy, we still have a lot of old people living with our families. So it becomes very easy to pass probably the virus even from asymptomatic people to the older, more frail people. I just wonder whether you have any data on that or if you have any gut feelings about it.
Yes, you're right, probably, because we have a lot of our elderly population in nursing homes and facilities for elderly people. Rather few live at home with their children and grandchildren, which is usual in the more southern part of Europe. So they are in a way quarantined before we go into this pandemic. And that may be one reason that we don't have this high number of elderly people. We don't have an age limit for entering patients in the ICU, and we're happy to take them, but they should not be very frail. We put more emphasis on frailty than on age alone.
Mm-hmm. And one other question, did you organize yourself also as a network in Norway, and do you work also with the other Scandinavian countries to have some form of coordination in case you run out of capacity, because also you don't have a lot of beds per population?
No, that's right. But they are in probably the same position, both Finland, Sweden, Denmark, and Norway. The problem now is that we are not allowed to travel between the countries. We have banned travel between across the border. That could, of course, be solved if we had an army of healthcare personnel. And that is a very good idea that you suggested, Maurizio. I support it wholeheartedly, because of course we could go south and help if we arrange it and if our governments allows us to do that. But
I do remember
we have just a network over.
I would say I was remember receiving a lot of emails from doctors from northern countries at the beginning offering to come and help. We didn't have the structure to do it, no. But we would definitely seen that you guys wanted to help. One very last question, because for instance, at the moment we don't have medical students helping with this. And it strikes me during this pandemic, which is about mechanical support, how similar it is to the beginning of our specialty in Copenhagen with medical students ventilating patients with tracheostomies manually. And I do wonder, do you think we should have medical students in the sense that if we don't have them, we are preventing them to have such an important experience during their training years that probably they will not get, hopefully they will not get again for some time?
Yeah, funny you should mention that, because yesterday I wrote a short note to New York Times about this, because they plan to share respirators, ventilators, to divide them with Y pieces and let one ventilator ventilate for patients, which is nonsense. If anyone knows anything about pulmonary physiology and individual need of patients, you will immediately see that this will fail. And then I just reminded them that in 1952, we used thousands of medical students and nurse students to manually ventilate them. And these bags we have for tens of thousands all over the hospital. And of course, in a period of stress, this is probably better than death.
Okay, Hans, that was very useful. Thank you so much and everything that you're doing, and good luck with your preparation in Scandinavia. So thank you, Hans.
With your work also, Maurizio.
Thank you. So it's time to move to the next update. So it's a great pleasure to introduce Professor Louis Kaplan, who is going to talk about an update from the US. Hi, Lou. Let me just introduce Lou. Lou is Professor Kaplan, sorry, we're friends, so it's easy to say Lou, but Professor Kaplan is a professor of surgery at the Perelman School of Medicine, University of Pennsylvania, Philadelphia, and Veterans Administration Medical Center, America's largest integrated healthcare system serving 9 million enrolled veterans each year. He's the current president of the Society of Critical Care Medicine and co-chair of the joint Society of Critical Care Medicine, European Society of Intensive Care Medicine Surviving Sepsis campaign. Lou, please give us an update about the US. We're all looking forward to hearing this because we know the numbers are becoming very high.
Thank you, Maurizio. Indeed, these are my disclosures, the most important of which is that I can name Maurizio, Joseph, and Maurizio as my friends. That is a very important thing, and this webinar has allowed me to see people that I have missed. The US has undergone an evolution. We began learning at a distance. We learned from China and Italy and the European countries in turn. And as we learned, we had escalating concern. This very rapidly led, as you have identified, Maurizio, looking at numbers, we moved to crisis footing. And then we began to adapt. And it is the process of adaptation that I want to explore with you rather than the individual numbers, since they don't tell the whole story. We have very asymmetric penetrance of COVID. Seattle, Washington, Chicago, Illinois, New York City, New York in particular, but also New Orleans and Louisiana are very differently hit with patients with this disease than any other place that we have, including where I work in Philadelphia. Commonly, when facilities need to adapt, they have the infrastructure for the facility, the clinicians, and administration all in one place. This pandemic has brought others into play, joining dietary, EMS, the pre-hospital care providers, but also in the VA, that's environmental management services, the people who clean the facility, and security, including law enforcement, all in the same place at the same time. Solutions for immediate problems that reflect your facility's unique infrastructure and resource allocation now occur all together. This has not happened before. This adaptation of cross-service and cross-silo approaches has been particularly helpful. Health systems, and these have now been drawn together, disparate facilities into one system that often use a hub and spoke approach, are sharing. They're sharing patients, they're sharing clinicians, even across state lines, they're sharing supplies, and this provides both direct care, bringing a doctor or a nurse or an advanced practice provider to another site, but also we've leveraged telemedicine in a very substantial way. And in a very unprecedented way, the collaboration between VA medical centers and their academic affiliates, like what I have in Philadelphia, have viewed themselves as one system, where they were often viewed as separate. This is absolutely important because of the resources that are also asymmetrically distributed between hospitals in the same region. Individual states have adapted. Residents have been instructed to shelter in place. Essential travel is the rule at this point. Businesses have closed, and only those that are engaged in life-sustaining elements can continue. The government is enforcing that, but also has opened portals that were very difficult to previously access to request federal aid. This is singularly important, and we'll talk about how that plays out in just a moment. When you look across the US, we do not have uniformity. What you see here is a map with the darker red as places that have absolutely statewide, across the board, stay-at-home orders. In the lighter salmon color, there are different areas that have had this requested and then enforced, and in the yellow color are states where this does not exist at all. There is opportunity here. This should, in fact, be uniform. We need mitigation. The government has done things that it has not previously done before. Our government is often in the news, And I won't speak for the government, but I will tell you that from the White House to the U.S. Surgeon General to the Federal Emergency Management Agency, where I spent an entire day on Wednesday, an opportunity that never would have occurred otherwise, I now have insight into how all of those agencies and arms work with the FDA, the Food and Drug Administration, and the Centers for Disease Control. The recognition that typical standards of care and standard care may rapidly devolve to crisis standards, which is a standard, but a very different one, has permeated the way that these agencies are working together. This is also mostly unprecedented. It is curious and important to note that when large portions of the country have been told to shelter in place, the agencies upon which we rely to provide aid are the ones that must continue to work and are often put in close proximity with one another in order to get the work done. This is something for which we do not yet have a solution. What have they enabled? Emergency use authorization pathways, taking devices that were labeled for use in one way and identifying that it's okay to use it differently. We can stand up new beds and use them as ICUs. There is a licensing pathway for ICU beds. Those have been relaxed. Even our critical access hospital can use new areas and designate them as beds to take care of patients as there is an influx. We have opened our secure stockpile. 4,000 ventilators went a day or so ago to New York City to help offset their shortage of ventilators. Device manufacturer augmentation has been put into place. One of our automotive manufacturers will now be making ventilators. All of the companies that make PPE, those have also been directed to increase the rate at which they make them and then ship them. We are reliant upon our truckers to get things from one place to another. And the need to support them is one of the things that has arisen from this particular crisis. But all of you, like you are participating in this webinar, are probably unsurprised, let me go back one, by professional society collaboration. It's important. We are doing things as societies that we had not done before and without restriction. Resources are being shared. Many of those are free. What else is free that we've leveraged are private citizens. People have dropped off food. They've dropped off PPE that they had at home. Industry partners, non-pharma, have dropped off N95 masks and gloves and all of the things that you would want for personal protection, including what comes from retail businesses that would sell these things. They have simply opened their stores, opened their warehouses, even to the point where at Penn we received 43,000 individual pieces of PPE in the last few days. Unprecedented generosity and humanity. And so in conclusion, this truly is global. It has broken down silos, leveraged public and private partnerships, and has driven people to innovate, even in figuring out how to potentially safely, despite the Professor Fladen's comments, ventilate 2 people on 1 ventilator. So with that, I will thank you.
Lou, thank you. That was, as usual, very, very sharp, very informative. So thank you for that. Lou, I remember with Joseph Keseshoglu and Heatherly Bailey just a few months ago, we were working together on a piece that you authored as the first author, which was Imaging. And it was a collaboration between societies, and we were thinking where we were going. That focused so much on data science and how we can collaborate on data and data sharing and so on. I don't think any of us imagined to have anything like this in February and March this year. I'm asking you, are you using data science to map where's going to be the next epicenter, whether there's going to be any epicenter to see where's going to be the next hotspot? I know that now New York and California, if I'm not wrong, they seem to be particularly affected. Are you confident that you're mitigating or containing the infection somewhere else, or are you using all this prediction model to see where to focus next?
It's an important question, Maurizio. I do not have confidence that we know where the next hotspot will be, and I don't yet have confidence that we can identify whether our mitigation procedures and processes are being effective. We're hoping they are. One of the things that was discussed with the president and the vice president, as well as leaders of other key agencies, was exactly what you've identified, is leveraging the power of the national laboratories that have vast computing capability to feed information into them to not only visualize where things are occurring, but also map the rate at which they change to help prediction and the appropriate distribution of the resources that the Office of our Assistant Secretary for Preparedness and Response has as part of a national healthcare disaster plan. I will take the liberty of going back to a question you asked, Ricard, which was, what would you have done 6 weeks prior? It would have been this. It would have been to have created a national dashboard, updated every day with existing resources, your flex beds, what you have, what you need, and then use all of that in an integrated way across the federal agencies and our pharma and industry partners to determine where we needed to move things, where we needed to shore up institutions or systems that did not quite have enough for what they might need, and prepare in that sort of way. So yes, I would have loved to have had the foresight to imagine all of that.
Can you remind us how many positive cases you have roughly today, and also what about azithromycin and hydroxychloroquine? I know there is a lot of news and rumor coming from news on the US. I wonder, as a scientific society or as a clinical community, what's the view on that?
So the numbers keep changing, but we're up over 100,000. There is reservation about hydroxychloroquine. Certainly people have tried to use a related compound that you can get in pet stores for dealing with fish that results in vast human harm. So we strongly discourage that. Azithromycin, we don't know. We'd like to keep track of how that works and whether it works in people. It depends whether you're deploying it in a preemptive fashion to prevent secondary bacterial infection or a presumptive empiric fashion, thinking that in our high-risk patients with multiple comorbidities, they may already have co-infection. It is striking from the early data how often there is more than one virus in the same patient, both influenza A or B and COVID-19.
And I think you're right. And your answer, because we say we follow very carefully some great podcast on John with Dr. Fauci, which is being illuminating the evidence and so on. This paper also about the edge of trying new treatments in pandemics. We have to learn from the previous epidemic West Africa with Ebola. And the end trying drugs without and research ended up the pandemic without having any guidance for it. So probably the to be high before we have treatment in a strong and bad position. It was just a comment like the to comment.
You're right. We rate things we from those we should do in the context of trial so that we know what we're doing. Carefully design of the results we know, not just think, well, that was a lovely that use in your facility. We should be able to trust and face the results that we share that are multiple institutions and understand how to expect if we apply that in patients, and more importantly, to know should not apply that therapy so that we do adhere to our principle of doing no harm.
You are such an eloquent speaker. I'm going to a difficult question now. Coming back to what you're presenting, and coming back, for instance, to evaluation that we have technology and how to use it. You and I, we have something, and I know they're both thinking very about lowering standards as long as you're saving and life. And there's a standard actually we have to compromise or not. We are not yet. We really don't want to go there. Clearly, banking, for instance, using non-invasive on page. We don't do it without and we should use it without thinking. But do you think that would be something we would consider in an extreme situation? Or would you say, if it's the stage, I'd rather use the opportunity to save the tech alive? Because that's the that we have now. That's what we're actually doing way to make this possible. While again, this thousand, I really want to go there. We should effort to enough ventilators. After 6 weeks in this, I'll not be proud about having any more in the next weeks. So I just wonder what you think.
I have several thoughts that have led down the pathway. If there is a clinically proven reliable method for use, you should use all of those. The question is, what do you do? When those are exhausted, there are no more of those having to be. And have someone that is potentially salvageable if only you could ventilate. In that crisis standard mode, the other alternative is simply to provide palliative care. We should prevent well. If you think that the person could survive, should mark down a pathway of unproven, feasible approaches. I think the answer to that is yes. One do that for me.
I'm with you. I should try to use technology to it, but in a way for research. I always have contribution like the US. It's amazing work for amazing people, and you will do so.
Thank you.
Good afternoon, ladies and gentlemen. We are beginning to a new session right now, and I would like to announce Professor Alain Combs. He's a professor of intensive care medicine at the University of Paris, Pierre Marie Curie, and senior intensivist at the Department of Medical Resuscitation, Institute of Cardiology, Pitié-Salpêtrière Hospital, Paris. His main research interests are the care of the critically ill cardiac patients, mechanical circulatory assistance, and extracorporeal membrane oxygenation and rescue therapies for severe ARDS, including ECMO, pulmonary infections in mechanically ventilated ICU patients. He will now be speaking about the use of ECMO. Yes, no, and when.
First of all, this is my disclosure slide. Well, first let's discuss the rationale of using high-flow VV ECMO in patients with severe ARDS, and it's mostly to replace pulmonary function in patients dying from refractory hypoxemia or for whom the mechanical ventilation becomes dangerous. We have data showing that it may, of course, provide oxygenation and decarboxylation, but it may also minimize lung stress and strain in these patients and may be able to decrease ventilator-associated lung injury in the most severe forms of ARDS. And over the last 20 years, there's been a lot of data showing that if you would like to go for ECMO, ECMO should be applied very early in the course of the disease. These are data here from our group showing that mortality increases by 7% per additional day of mechanical ventilation awaiting ECMO. And on that Kaplan-Meier curves, it was obvious that those patients who received ECMO in the first 2 to 3 days following intubation had much better outcomes than those who got the machine after more than 10 days of mechanical ventilation, and probably beyond the fact that ECMO provide oxygenation and decarboxylation, also ECMO may provide much gentle, much safer mechanical ventilation and lower driving pressure, for example, in these patients. So what we can derive from the EOLIA trial, once again, you remember the EOLIA trial was published almost 2 years ago now. And overall, the EOLIA trial showed that the mortality of ECMO patient was 35 and was 46 for control patients. The difference was not statistically significant. There was a trend, but overall it was not significant. We then reanalyzed the data using another stats model, using Bayesian model analysis, and with that type of analysis was possible to show that the probability of ECMO saving lives in these most severe forms of ARDS was probably between 90 and 99%. In EOLIA, there was also patients crossing over from the control group to ECMO, and those who crossed over had a very high mortality. On average, they crossed over 1 week after the inclusion in the trial, and the mortality was almost twice as high as the mortality of the ECMO group. We also reanalyzed the subgroups. Of course, you should be very, very careful in this type of analysis, but we were surprised to see that those who benefited the most were patients who had the highest PF. This is here the median PF in EOLIA was 66, and mortality was almost halved in the group who had the PF above the median. So together with this data, we also showed that there was less mortality. Actually, there was a trend for patients with low lactate and those who have the lowest SOFA score, also suggesting that patients with only lung failure probably derive the most benefit from the machine. Last point about EOLIA, and it's a very important point here when discussing indications in the COVID-19 patients. The mean duration of ECMO in EOLIA was 2 weeks, and it's even longer if you do not carefully select the patients. So now let's have a look at the data from other viral infections. Of course, we have data from the H1N1, was 11 years ago now, also very severe ARDS. Also, the disease was completely different for sure. These are data here from the ANZICs in Australia and New Zealand with very severe ARDS, and they reported mortality of only 25% for those patients who got ECMO. Similar data from the UK also showing good outcome after transferring patients to an ECMO facility, and similar data also from the Riva network in France in a group of patients also who did all receive ECMO in that study, also suggesting after case control analysis the benefit for ECMO. More recently, we had the corona, the MERS-CoV associated ARDS also in the Middle East. And there's two small studies, this one, which is just 2 cases reported by a group in the north of France. And in that study, the 2 patients actually received ECMO. 1 patient died and the other survived after the very long stay in the hospital. And this is the latest about MERS-CoV. This is a study which is coming from Saudi Arabia in the Middle East. In that study, they did a case control. Case patients received ECMO with very strict initiation criteria, PF below 100, or a Murray between 3 and 4, or a CO2 retention on MV despite a high P-plat. And patients who did receive mechanical ventilation for more than 7 days were contraindicated. Also those who had CNS hemorrhage or a very severe disease. They did the case control by matching the cases to a control group, patients who met criteria before the introduction of the ECMO program in Saudi at that time. The matching was satisfactory, as you can see here on the most important prognostic factor. And these are the main results. The mortality was quite high, but it was significantly less in patients who got ECMO. Actually was 100 in the control group. And the ICU length of stay was longer for ECMO, but it's obvious because there were some survivors and maybe ECMO permitted to buy some times. This is the Kaplan-Meier curve here showing that those patients who did receive ECMO had a better outcome. And once again, it was significant. This is a small study before and after, but it might be also discussed because MERS is a very similar disease. It's actually the same family of viruses as compared to COVID. And then have a look now at the data, the very few data we have for COVID-19 patients. This is the Lancet study gathering 199 patients published a couple of days ago. And in that study, there were 3 patients who did receive ECMO of the 191 and all died. The 3 of them died. There was no reporting on the specific characteristics of these patients. And this is another one here, even more recent in the Lancet Respiratory, a larger study here of 710, of whom 52 acute and critical ill patients were included. And in that study, there were 6 patients who did receive ECMO, and there was only 1 survivor. Once again, no data on the clinical characteristics of those patients who did receive ECMO. So there is an ongoing controversy, and this letter was published 10 days ago now, also on the potential aggravation of the patients with ECMO by this physician, elaborating on the potential impact of ECMO on lymphocytes and also on an increase in IL-6 concentration. This is highly controversial, and there is no data supporting this assertion. And actually, in our experience, we did not observe this kind of problem here in La Pitié. So now, how can we plan if we should do ECMO for these patients? This is another recent paper in the Lancet Respiratory in which we elaborated on what should be the organization for the personnel, for the equipment. Equipment actually may be a major issue here because of shortage of devices and shortage also of ECMO circuits in the coming weeks. also elaborating on what should be the organization of the facility of the systems. It's actually a very big challenge to the system, the units, and the network of hospital to organize this activity. What may be the indications for now, I do believe we should stick with the Eolia entry criteria, and it's mostly hypoxemia. In our experience, most of these patients, some of them will develop refractory hypoxemia and they may die from refractory hypoxemia. And it's probably those who might have the most frequent indication. There might be also some indication for those who develop stiff lungs, but it's not the actual presentation in most of these patients initially. Contraindication, very tough question here. Age for sure, what is the age limit? Probably over 65, 70, maybe less, actually, in the coming days and weeks. For sure, severe comorbidities, severe immunocompromised status as well. Patients who have cardiac arrest probably should be excluded, except if it's witnessed with immediate CPR. Duration of MV, another very difficult question here. It may depend also on the age and comorbidities. And the last point is very important. Multiple organ failure might be also a contraindication, except maybe isolated AKI, which is also another feature very frequently observed in these patients. So to end up this talk, a few report of our experience here in Paris. We did our first case close to 1 month ago now. It was massive PE. After 6 days of mechanical ventilation, was a patient who was treated in a remote center outside Paris, and he was rescued by the mobile rescue team after cardiac arrest, and the patient died of multiple organ failure little time after his arrival here in La Pitié. As of yesterday, we have implanted 45 patients here in La Pitié and another 25 cases in other Paris hospitals. And last night and today, we did actually more patients. And this is the update of the Euro ELSO survey, weekly survey. Overall, yesterday evening, there was 154 patients on ECMO in Europe, 70 in France, 27 in Italy, 16 in the UK, 10 in Germany, 12 in Spain, etc. So what is the conclusion? This is here a big question mark. What should we do? What we have observed so far is most patients have been stabilized by ECMO. This is a very, very severe lung disease, frequently associated with kidney injury. But not all patients die on ECMO. Actually, we have won 3 patients so far. So this will be possible. But most patients, we may require weeks of support. It's clearly too early here to draw any conclusions. We need time. We definitely need time to evaluate the results of ECMO in patients with COVID-19 infection. Thank you so much.
Thank you very much. I'm sorry, I forgot to put my microphone on. Thank you very much, Alain, for this presentation. We have a lot of questions coming, but if I look at the nature of the questions, actually we can derive 2 questions out of it. One of them indicates that the use of ECMO, or actually not the use of it, but the necessity of using it, was quite low in China and also in Italy, because most of the patients are very ill, but they are not very complex to keep a PaO2 at a certain level. Can you comment on that?
It's true for most patients initially in the first 1 or 2 days, but we had a very massive shock wave here in Paris. It began just 1 week ago, and we had a lot of calls for referrals for ECMO in patients who did develop refractory hypoxemia, despite prone positioning, despite NO, and despite all the classical techniques which are usually deployed for these very severe ARDS patients. This is why we decided to go for ECMO in these patients. We did not apply ECMO early for patients who have the PF ratio above 80 in these patients.
Okay, maybe the second question is at least as important as the first one, maybe even more, because if we hear all the experiences of our colleagues from Europe and Asia, this is a huge burden on healthcare. We all have limited capacities of beds, limited capacities of mechanical ventilators, especially as said before, limited capacities on nursing and medical personnel. And we know also that if you start with ECMO, you will use a considerable amount of your personnel for the ECMO patient. So it brings some ethical questions. I mean, I can't say it is unethical to use ECMO, that should not be true, but I think we should be extremely selective to divert our manpower to the right place, because we may be losing a couple of patients while saving one. What do you think about that?
I completely agree. This activity should be performed only if you have enough beds to care for other patients. For now, in the Greater Paris, this is still possible. We may reach the limit in the coming days or weeks, I don't know. But for now, we have been able to care for these patients. So, and we need to evaluate also the results of the ECMO in these patients. So there is no loss of chance for now in our area. We discuss every other day the indications. We may become even more restrictive in the coming days. We do it day by day, actually, right now, day by day.
Okay. Alain, thank you very much for your presentation. And now I would like to actually move to the next speaker. And I would like to introduce Professor Massimo Antonelli. He will shortly make a presentation on basic non-invasive ventilation. Massimo Antonelli is Professor of Intensive Care and Anesthesiology at the Università Cattolica del Sacro Cuore, Rome, Italy since 1991, and Director of the Department of Anesthesiology and Intensive Care and Emergency Medicine, Postoperative ICU and Neurosurgical ICU of the Fondazione Policlinico Universitario Gemelli, Rome. Massimo is also the former editor-in-chief of Intensive Care Medicine from 2007 to 2013, past president of the Italian Society of Anesthesiology and Intensive Care Medicine, CRT, and he served as a president of the European Society of Intensive Care Medicine from 2016 to 18. His scientific fields of interest and research include non-invasive ventilation, mechanical ventilation, ARDS, shock, sepsis, and infection.
Thank you, Joseph. I will try to show you in a very few minutes what has been done and what can we do with our situation. The numbers are well known. This is the context, and I do not want to add anything. And the surge is extremely tragic and dangerous everywhere. This is the report of our Istituto Superiore di Sanità, where the critical patients represent something like 25% of the patient, which means that most of them can be admitted to the ICU. The real problem is a problem of capacity. The rapid surge with the exponential increase of the cases created a very hard impact on the sustainability of the healthcare system. And we try to face this surge building up temporary hospitals wherever in the country, especially in the north, expanding the original capability of 5,300 ICU beds that were available. And in the region of Lombardy, this was almost doubled. But the real problem is represented by the fact that we may be obliged to ventilate patients non-invasively fundamentally for three different reasons. We do have a limited ICU bed capacity. We do have a lack of resources, the ventilators, and then we have in comparison with the big surge of patients, a nurse and doctor shortage. If you look at the data that is going to be published into the JAMA very soon, you can see that non-invasive ventilation and CPAP in the north region, in the Lombardy, within and outside the ICU, represented something like 10% of the entire population that is here, more than 1,000 patients. And looking at also to minor report in terms of sample size in China, you may say that within a number of 201 patients, 30% of them had indeed received indeed non-invasive ventilation. However, if you look at the indication and the clinical practice guidelines coming from the ERS and ATS on non-invasive ventilation for acute respiratory failure, there is no recommendation. But in the rationale of not giving any recommendation, there is some indications such as that you can try a trial of non-invasive ventilation to patients with hypoxemia, but you need an experienced clinical team. And under the surge of COVID-19, this is a problem because often we do not have an experienced clinical team. And we can try to select the patients carefully, but unfortunately, there is no time and the number of patients that we have to take care of is very huge. But we need to reassess day by day. And very recently, just a few days ago into the JAMA has been published the management of critical ill adult patients with COVID coming from an expansion of the Surviving Sepsis campaign fully dedicated to this subject. And there, the use of high-flow nasal cannula as well as the use of non-invasive ventilation is suggested as a weak recommendation with very low quality of evidence. It is really important to remember, however, that even in definition allocated the non-invasive ventilation within the range of 200 and 300 PF value for ARDS patients. And under this context, at least a trial may be attempted. I want to focus your attention on a device, an interface that is playing more and more a determinant role in assisting these patients, at least in Europe, and something is happening also in US, which is the helmet. And the helmet showed since the first attempt proposing the technique not only as a CPAP form, but also as a non-invasive pressure support ventilation, a good outcome in comparison to the facial mask. One thing that you have to keep in mind, especially when you use the helmet as an interface, is that you may have rebreathing if you do not take into consideration the two variables, physiological variables that condition the rebreathing. The first is the production of CO2, and the second is the flow that passes through. And in this case, if you look at the graph, provided the fact that you can deliver at least 30 liters per minute to these patients, and this is one of the COVID patients inside a pressure negative room, just using the cellular phone in order to communicate. But under these circumstances, the rebreathing is totally negligible. It's interesting to see that the helmet can be used through a Venturi system to allow an adequate flow rate, a PEEP valve, or a free flow system with a rotameters for oxygen and air, or other Venturi system. One thing that you can keep in mind that often these patients may just sneezing or just coughing may produce a multi-phase turbulent gas cloud, as you can see from this very recent publication in the JAMA. When you are in a contained environment, the reduction of this risk of disseminating into the environment may offer an additional advantage. Of course, one important thing that you have to place here, an HEPA filter. This is just a HME, which is before the PEEP valve. But if you want to apply it as a pressure support form, you can use also the masks as well as the helmet and you have to titrate your ventilator in case of pressure support, starting with a pressure support something between 10 and 15 with a PEEP 5 or 10. This is something that can be chosen in order to avoid air leaks and droplet dissemination, whilst this containment by using the helmet is much less, and FiO2 allowing a 92% of saturation. You have to consider, however, that this kind of setup may induce some dyssynchronies, but these synchronies allow a good time for assisting the diaphragm and avoiding any real detrimental effect. Also because the patient is already immersed into an environment. And by adopting the helmet in comparison to the face mask, under this condition, the work of breathing is reduced. In the 2016, the group of John Kress published this paper where randomly compare face mask and helmet, obtaining a very good results in comparison to the face mask when the helmet has been used as an interface to deliver non-invasive ventilation. One thing that may be very important, when you use an helmet, may easily have higher level of PEEP in comparison to the face mask, and allow then a better recruitment of the lung, that in these patients may be an important issue, especially in the COVID patient, as you know. Recently, we could the inspirator effort is dramatically reduced, having a reduction of the dynamic transpulmonary driving pressure as well as the pressure time product. Then also an efficient way to reduce the work of breathing. But it is obvious that also when you use this technique or this mode of ventilation, you may get some failures. And there are some indicators that can help us when to start on predict a failure and consequently an intubation. And for instance, the tidal volume that can act as a surrogate of the transpulmonary pressure. The higher the volume it is, the higher is the failure rate. However, also another indication can be taken into consideration. If after few hours or just 1 hour, the PF of your patient, of your COVID patient doesn't go up, please reassess and consider carefully the possibility of an intubation. But as a matter of fact, all these approach can be attempted also outside the ICU, having in mind that when we are looking at these patients, the failure rate may be up to 60%. But remember that in the condition of a shortage, unavoidably, you need to make a choice and try to assist the patient in the best way you can. The Chinese has proposed another score, which is the assessment of air rate, acidosis, consciousness, oxygenation, and respiratory failure, in order to predict the failure in hypoxemic patients. And the capability of a prediction, it is indeed shown and reached a good performance. I want to conclude just giving some final practical suggestion. As soon as you want to choose this kind of interface, you have to pressurize the helmet before placement. Never use the pressure support without PEEP if the pressure support is the modality. Certainly easier to use as a CPAP system using a high flow rate. Under pressure support, never use a pressure support below 10 centimeters of water, because part of the flow that is generated is necessary to distend the helmet and assures a continuous flow of the gases, preventing the breathing. If this is present, if you can use the fastest pressurization ramp. And as soon as you see the ventilator dysynchrony, don't worry that much. You are in conditions where you cannot be very sophisticated in analyzing the eventual dysynchronies. But things that differ from other patients with the endotracheal intubation, with the helmet, any inspiratory respiratory effort takes place in a high volume pressure reservoir, which is similar to the free CPAP. So you can make an attempt, and this can also help you to treat patients in difficult conditions within and outside the ICU. Thank you for your attention.
Thank you very much, Massimo, for this interesting presentation. You have told us various aspects of non-invasive ventilation, but the question at the end of the day is always on high-flow nasal cannula, the use of it, because the fear is that due to the 60 to 80 liter per minute flows, the spreading of the virus. On the other hand, we also know and also saw the last week that some patients with COVID, with coronavirus, profit enormously, and you can also prevent intubation and ventilation if it's the right indication. What is your policy on that? Because we have a very different literature. Some people say this is not very important. You can use it under precaution, of course, big precaution, and some people say you should not use it. How is your politics? In your hospital, policies in your hospital?
Yeah, as you said, it's quite controversial. I would say that in my hospital, we do use it preferentially under condition where a negative pressure is present, and knowing that putting the patients in a cohort setup as we do, probably this minimize the problem of just contaminating so much the environment and just giving or transmit to other patients who are in good condition the virus. It is obvious that under this condition, when the high flow oxygen therapy is used, the patient, the staff must be protected with the personal protective devices, including a FFP2 or at least or P3 when they are close to the patients. Because as I shown in my presentation, has been clearly demonstrated that when a patient sneezes or just have such a high flow, you may have a turbulent gas cloud dispersing around. So be careful, you can use it, but escalate rapidly to non-invasive ventilation or CPAP. This is what we do. And we try to use the high flow oxygen therapy in a very emergent situation at the beginning of the story.
Yeah, thank you. Just a comment. Actually, in principle, we also know that, maybe your expert opinion on that soon, we know that with our high flow nasal cannula, we create 60-70 liters per minute flow. But if the patient starts to cough, that would be something like 400 milliliters, liters, sorry. Actually, one part, some people say, so the part, high flow does not make the situation worse. It's actually the sneezing and coughing of the patient. On the other hand, some others indicate that high flow can also enlarge the distance of the spread of the virus. Okay, I just ask your opinion on that, but at the end of the day, again, the precautions that you have indicated are the ones that we should be sticking to.
Yeah, that's for sure. But for these reasons, at least in my hospital, we try to give the possibility of using the helmet as a CPAP form. Yeah. Also because there is a containment, and the patient, just if sneezing or coughing, is within a contained environment, and having an HEPA filter before the PEEP valve, you may reduce the most the potential contamination, the external potential contamination, without compromising that much the patient inside the helmet. However, we also have to admit that we try to help our patient with what we have in the moment they are sick, and in reason of considering the various possibilities we have. When we have a shortage of resources, we try to use a sort of escalating approach, starting with the normal Venturi mask or of reservoir mask, going to the high flow, escalating to the CPAP or the pressure support in a non-invasive form, then intubated the patient, putting him prone, and.
Okay. Okay, thank you very much for your participation and for your very nice lecture. And I think it's time to move for the next session.
Thank you very much indeed. Good luck.
So welcome back, everyone, and we have another important session on updates from other countries, and we are going to talk about Latin America and also low and middle income countries. And I was actually thinking myself during the last few weeks that I would have never really wanted to live in this pandemic, but what made me realize is how difficult it is to work in resource limited settings. It's the first time in my life that I have this problem, looking at resources in terms of human resources, technology, and so on. So I think we have a lot to learn from how other countries that sometimes are used more than us to prepare for these problems. So it's a great pleasure to introduce the first speaker, Professor Luciano Azevedo from Brazil, who is going to talk about Latin America. Hi, Luciano.
Mauricio, Professor, how are you?
I'm very good, and you?
Fine.
Good. So just before you start, I would like to introduce you, and Professor Azevedo is the head of the ICU and Professor of Critical Care and Emergency Medicine at the University of Sao Paulo in Brazil, and coordinator of the Intensive Care Research Program at the Syro-Lebanese Institute for Education and Research, also in Sao Paulo. He is the current president of the Latin American Sepsis Institute and the president of the São Paulo State Society of Critical Care. In addition, he is a member of the executive committee of the Brazilian Research and Intensive Care Network. And I have to say, he's also a great intensivist and has been leading some very important trials with BRICNet and in Latin America in general. So I look forward to receiving an update from you, Luciano.
Thank you, Mauricio. First, I'd like to thank the European Society of Intensive Care Medicine for inviting us to participate in this marathon. It's very important for us to have our voices heard in such a catastrophic scenario like this one. And I'd like also to thank my fellow colleagues from the Latin American Intensive Care Network, the LIVEN, for providing me with data and also on discussion on the issues regarding how the countries in Latin America and mostly in South America are dealing with the pandemics. So I was supposed to discuss the issues of COVID-19 and updates of COVID-19 in Latin America, but we'll focus more in Brazil, since you already had some discussion from the Pan American Intensive Care Societies. Just for a brief summary, Latin America is comprised by 20 countries with a population of 640 million people. And Brazil, of course, is the largest country in Latin America, not only for territory, but also from people. Brazil has 1/3 of the population of the Latin American. And it's a region with a big inequalities, a very problematic issues regarding income distribution, regarding poverty, as we will see later. So this is data from March 26 on the most larger countries in Latin America or in South America. As you can see, Brazil is leading the number of cases in South America with almost 3,000 cases and 77 deaths, followed by Ecuador, Chile, and Argentina. So these are the countries with the largest number of cases, but I would like to say that this is mostly underrepresentative of the scenario in Latin America, because as we will see later in my presentation, we have a lot of patients that are not tested for COVID-19. We have a lack of supplies for PCR reactions, for PCR tests. So we are only testing now, for instance, in Brazil, the more severe cases, the patients admitted to the hospitals, and also the cases, the suspicion of cases in healthcare workers. So we are really not, this is very underestimation of data in our countries in South America or in Latin America. This is data from Brazil as of March 27th from the Ministry of Health. As you can see here, there is the exponential peak of cases in Brazil in the last few days. The first case in Brazil was just 1 month ago, the first diagnosed case, a patient that came from Italy. There was in Milan, Mauricio, and it came from Italy for a business trip. And this was the first case in Brazil, and now we have more than 3,000 cases in our country, and with 92 deaths. Besides this, what makes me think that we are underrepresentative in Brazil is also the data from the Fundação Instituto Oswaldo Cruz, the Fiocruz in our country, that has evaluated the number of admissions at the hospitals with patients with for patients with similar flu-like symptoms, and this has increased 10 times in February and March as compared to the previous year. So we believe that a large number of cases in Brazil is not reported, is not diagnosed. So we are probably much more larger number of cases than it's depicted here in this presentation. So what are the problems of Latin America, the characteristics of Latin America and also Brazil that may contribute to the probably larger dissemination of this pandemic? We have 48% of Brazilian population that lives without proper sanitation in their home. We have 25% of population that is below poverty line in Brazil, and almost 30% in other comprising Latin American countries. We have a large number of people living in major cities, but they live in shanty towns with usually two rooms for 8 or 10 people. So it's very difficult to have proper social isolation or proper isolation of the patients affected by the disease in this kind of cities. And the poor control of chronic disease, because the population doesn't have access to medication, doesn't have the money to buy medication. So we believe that in Brazil or in Latin America, the dissemination of the number of severe cases is going to be higher than in other countries of the world. And we have also a lot of endemic viral disease, for instance, and not only viral, but malaria, yellow fever. And we are in the middle of an epidemic or an outbreak of dengue fever, with more than 100,000 cases of dengue in Brazil and Latin America in the previous year. So these all are situations that can constrain or make difficult for the healthcare system to fight another pandemic or another disease with major complications for the country, like COVID-19. So this is a common scenario in Brazil. The social inequalities in our countries are very important. We have rich people living together with people from the low income levels of the society, and this kind of characteristic may facilitate the spread of COVID-19 in Brazil. So this may be a major issue for the control of the pandemic in our country, or also in Latin America as well. Also, we have difficulties in the scenario of intensive care access in Brazil. We have a national public healthcare system that has 7 ICU beds for 100,000 population, and this comprises 3/4 of Brazilian population that they have only use of the national public healthcare system. And on the other hand, we have a private healthcare system that comprises 25 beds for 100,000 population, and that takes care of only 1/4 of the Brazilian citizens. So the people that have access to private healthcare system has much more access to the intensive care units than the people that has only access to the public healthcare systems in Brazil. Even though this is not a very bad number, we have other countries that have, of course, lower numbers than Brazil. We also have a lack of adequate triage for the patients that come to the intensive care units. For instance, we don't have a very good discrimination for patients that will benefit most of the intensive care unit treatment, and others that, for instance, they are more fragile or more old, or that have chronic disease very not compensated, that could benefit less from the intensive care. So this would be important in the scenario of a pandemics like COVID-19 in Brazil as well. So what are the major issues for COVID treatment in Latin America and also in Brazil? We have very few certified labs to do the PCR reaction. So, for instance, in the north part of the country, more than 10 states in Brazil have had only one certified lab, which was certified by the government, to do the PCR reaction. So this will delay a very slow lab response for test results, and other countries in Latin American colleagues from Mexico and Argentina had the same problem with the test results. And also, since we cannot test everybody, we are only testing selected population, like as I mentioned before, only the most severe ill patients, and also the patients that had the healthcare workers that had symptoms of respiratory illness. We had also a reduced sensitivity of the polymerase chain reaction. So we are now trying to discuss what we do with patients that have the symptoms, that have the tomographic findings, but they do not have the positive test in the nasal swab. So this is another major issue for us in these countries. The lack, of course, of adequate personal protective equipment, the lack of beds, and the lack of ventilators. And also, we are just starting the pandemic in Brazil, but also in Latin America, but we already have the lack of healthcare workers due to isolation, either for contact of the other people that already has the disease, or also for the positive disease in the PCR test. But we do not only have bad news in Brazil and in Latin America. This is the scheme for the trials that we are just starting in Brazil, is as an alliance of the 3 major private hospitals in our country, and also the Brazilian Research in Intensive Care Network. We are just starting, we are just able to randomize the first patient on COVID-19 for hydroxychloroquine, azithromycin, and also for dexamethasone for the most severe cases. So we'll try to have an answer or have a contribution to the medical literature on the treatment of these patients on the next 2 to 3 months, as if we can finish the research in this period. So to conclude, COVID-19 in Brazil is in the exponential growth phase. Some of the characteristics of our healthcare system may make difficult the disease control in Brazil. We believe that, unfortunately, the virus dissemination may be higher in Brazil due to the problems of income, and also due to the populational issues. The inequalities in income may spread the epidemics faster and harder in Brazil. And also, since we are a few weeks ahead of other countries, for instance, like African countries and other Asian countries that were not in the first phase, like China, perhaps the evolution of disease in Brazil may be useful to understand the spread of COVID-19 in other similar income distribution countries. Thank you very much for listening to me. I would like to be, I'm able to reply to the questions. Thank you.
Thank you, Luciano, for a very informative talk. I was positively surprised to see that you have roughly 7.5 or 7.6 beds per 100,000 population of intensive care, I think, in the public system, which is not too far away from some of the standards in Europe. And then I think you have more in the private healthcare system. So what I was wondering is, you seem to start from a baseline that is okay. However, what we are seeing pretty much in every healthcare system is that you need to increase your capacity if the outbreak starts. And I was going to ask you, is that the strategy that you're doing at the moment? Are you already increasing capacity, and are you working with your government to try to slow down the virus transmission? Because there are some news reports that suggest that maybe you're not in a state of mitigation or suppression already in Brazil, but I would like to hear more from you about this.
Yes, we already did some adjustments with the government to increase the healthcare capacity. So, for instance, the elective surgeries were all finished in Brazil for the last 1 or 2 weeks. The government of the states are building hospitals, just like campaign hospitals or for army hospitals to adapt. And then this is another contribution. What we're trying to do in Brazil, we are not in lockdown so far. We are in quarantine, so only the essential services are allowed. But the quarantine is not very well. The people are not really adequate to the quarantines. A lot of people are still going to work, and people are still trying to go to the beaches. So we are trying to cope with the situation as better as possible. But so far, we are not in lockdown, such as Italy or other countries have. We just, last night, we just closed the airspace for foreigners. Only Brazilians can return to Brazil in our planes. So far, we are trying to do, we are very concerned, Mauricio, regarding our economy. We are concerned that if we do a lockdown of 1 month or 2 or 3 months, our economy is going to crash. We have a lot of Brazilian citizens that live with not formal jobs. They live in informal ways, so they need government support in this kind of scenario. So the government only has released a law saying that they will support these people that has, for instance, informal, not formal jobs during this month or these 2 months of the epidemics, the big problem of epidemics in Brazil.
You've been very, very clear. I would like to go back to one interesting slide that you show. We don't have to show it again, but just to see if I understood it correctly. You were saying that in parallel to the cases that you're able to trace, you are seeing a disproportional number of cases that could be related to flu-like symptoms, even without positive tests. Am I right? And this would not be consistent with the seasonal aspects of Brazil, because now you are in a good season in Brazil. Am I right?
Yeah, absolutely. This just came from the media, from the lay media 2 or 3 days ago. The researchers were just assessing the data from hospital admissions in February and March due to flu-like symptoms. They already had seen an increase, a very tight increase in January, which is not common, of course, in Brazil as well. But in February and in March, they have seen a very huge peak of increase in the number of hospital admissions due to pneumonia and due to other flu-like symptoms, and they are attributing this to the COVID-19. What happens is that, sorry.
I was saying this is very interesting because indeed there is a lot of hope that COVID-19 could behave as a seasonal flu, but actually there is no evidence of it at the moment. And I think the strategy of hoping that it could be very dangerous. So, but I guess you're aware of it and you're making your preparations.
Yeah, absolutely. Yeah.
And one other last thing, I know that you are part of a group of intensivists of Latin America called Living that you are representing also today. Is there any other message from other Latin American countries? Are they preparing in the way that you are preparing in Brazil? And the data that you see in terms of spread of flu-like disease that is not traceable to positive tests, is it similar in other countries as well?
Yes, they have. The issues we have in Living are similar in all the countries. We only have the number of patients in the number of cases and the number of deaths. We mostly in most Living countries we do not know the severity of these cases. We do not know how many patients are in the intensive care unit. We do not know how many patients are ventilated. We do not know how many patients are healthcare workers. So we are just flying like a blind flight. We just know that the Ministry of Health in most Living countries just provides the number of cases and the number of deaths. So we do not know about the severity. My personal feeling is that as the pandemics evolves, what we see in the number of cases are only the severe cases, and also, of course, the deaths are related to this, because in most Living countries, in most Latin American countries, the healthcare systems are not testing for mild and asymptomatic patients. They are only, if you have mild symptoms, go home, stay 14 days in isolation, and you are supposed to have COVID-19. And if you get worse, return to the hospital. So this is what's happening. We do not have tests for everybody.
And I suspect that's what we are seeing, and we're wondering if part of the large number of cases that we see in some countries, but with different case fatality rates, could be also attributed clearly to the number of tests that are made. What, of course, you cannot control is the number of patients that go to the hospital and die in the hospital. I'm sure that comparing those mortality in comparison to previous trends in previous year in every country will give a better picture of this pandemic when this is finished.
Okay,
Luciano, thank you so much for your contribution again, and it's a pleasure to introduce our next speaker, who is going to talk about low and middle income countries, Professor Mervyn Mayer. Hi, Mervyn.
Hi, thanks very much, Maurizio. It is an honor and privilege to join you this evening.
It's great that you are here with us. So Professor Mayer is a principal specialist at the Charlotte Maseke Johannesburg Academic Hospital, University of Witwatersrand, Johannesburg, South Africa. He is the immediate past president of the Critical Care Society of Southern Africa and the current chair of the Global Intensive Care Working Group of the European Society of Intensive Care Medicine. On behalf of the ESIC Fund, Alive, Mervyn is actively coordinating, addressing and delivering sepsis education in developing countries, including Uganda, Pakistan, the Caribbean, and later this year, Mongolia. And I would like really to thank you about all the work that you are doing and coordinating for our society with the Alive Fund and all the sepsis program that you're doing worldwide. I know that we're going to talk about a little bit about this later. So now please start with your update.
Thank you very much, Maurizio. And once again, a huge thank you for the opportunity to share some thoughts on low middle income class countries, and a huge token of gratitude to all the wonderful healthcare workers around the globe who are doing a magnificent job to try and deal with this colossal issue. So I think before we get into the low middle income class issues, it's very relevant to understand the background of low middle income class countries or resource limited settings. And the first entity to understand is if we have a look at the entire world's population, 87% of the world's population in fact reside in resource-limited settings or low-middle income class countries. If we look at sepsis, based on the most updated study, a lovely study, The Global Burden of Disease, published just a few weeks ago in The Lancet, 85% of all sepsis occurs in low-middle income class countries. And it's very, very important to understand that the population profile is vastly different to that we experience in high-income class countries. We see different diseases. So in many regions, there are high incidences and prevalences of HIV, concomitant tuberculosis, and as a consequence of that, chronic lung disease. In Africa, hypertension is almost endemic in adult patients, and we see a lot of hypertensive heart disease and chronic kidney disease. Additionally, things like diabetes are becoming explosive issues within many low-middle income class countries, and hepatitis B is endemic in many of these countries. As a consequence, we see chronic liver disease over and above the malnutrition aspects that are well known in large regions like Africa. What's also particularly different is the age spectrum. And in fact, in countries like my own and in Africa in general, and in many low middle income class countries, in fact, there's a much younger population. Luciano alluded to some of the infrastructural problems in Brazil. When we look generally in low middle income class countries, in fact, in many areas, they're absolutely rudimentary with very fragile healthcare systems. Human resources in many areas exceptionally limited. So the WHO often recommend for adequate care, you need one doctor for every 1,000 citizens. In my own country, in South Africa, we have one doctor for over 15,000 citizens. In my neighbors next door in Malawi, one doctor in some areas for more than 50,000 citizens. Having intensive care specialists is rarely something that is not freely available. In a country like South Africa, with a better infrastructure, perhaps with respect to various other low middle income class countries, we only have about 70 trained intensivists. And in terms of those practicing, perhaps half. Elsewhere in regions, bar Brazil, where there are a large number of intensivists, limited numbers of intensivists. Logistics are very relevant to understand. Things that are often taken for granted in high income class countries, like the provision of safe water supplies, often not available. Electricity, oxygen, road transportation. Often the roads are non-existent and you don't have vehicles to transport someone. So if someone had presented to a basic clinic and required higher infrastructural care in a higher tiered hospital, it may not be feasible. And there are ongoing conflicts in many of the regions. If we look just at the financial differences in terms of healthcare expenditure per capita per annum, there's a 20-fold difference between high-income countries and low-middle-income class countries. And let alone what that means if there's a huge burden of this particular disease, because it will decimate economies. So having said that, I think a very pertinent commentary was one that was published a couple of years ago in The Lancet by members of the Global Intensive Care Working Group of the European Society of Intensive Care Medicine. And in fact, it was entitled Critical Illness in Developing Countries, Dying in the Dark. And I'd like you just to focus on that for a moment, because I think it's a profound heading and often encapsulates what many individuals and healthcare systems have to deal with in resource-limited settings. So let's have a look at the current situation. And as Luciana had alluded to, we've had the benefit of time to learn from China, from Europe, from North America, in terms of adequate preparation, albeit with marked resource limitation. The numbers are escalating. In Africa, in South and Southeast Asia, and West Asia, countries like Iran, and in other low middle income class countries in Eastern Europe, for example, Romania and Russia. In my own country, the numbers are escalating quite dramatically to the point that a state of disaster has been declared, and we're currently in a lockdown. And if we had to extrapolate numbers just in my own country based purely on calculation, the population of 60 million people, if the community is affected to the degree of 60%, it means 36 million people will be affected. If just 20% develop symptoms that require some form of clinic or hospital care, we're looking at around about 7 million. And if 10% become critically ill, 700,000, it would decimate a healthcare system. It is just not feasible or possible. And so I want to focus quite significantly on Africa, which in fact is the second biggest continent globally and the second most populous. In fact, 1.3 billion people live in Africa, which is a greater number than all high-income class countries put together. So if you look at this particular map, you will see that Spain, France, Germany, Italy, Switzerland, the Netherlands, Belgium, and Portugal fit into one small segment of North Africa. The United States would fit in, so would Eastern Europe, India, the whole of China, Japan, and the UK. And so just to put that into perspective, the potential for a massive explosive problem is certainly there, just in terms of population. There are differences. We have a younger population in Africa. In fact, average age is 19 years. So what are some of the key learning points that we've in fact been exposed to as this particular pandemic is in its infancy? And the one issue is preparation, which is absolutely paramount. And from our perspective, it has to be done with simplicity. And that means simple and pragmatic guidelines and interventions, adherence to all the basic principles. Sanitation, which in many instances is extremely difficult, bearing in mind that safe water supplies are not necessarily always readily available. The social distancing, which we've tried, that's why we're in lockdown in South Africa, because many individuals are living in tiny dwellings, in shacks, 4, 5, 10 people in a single room. Transportation is not readily available. So in my country, every single day, 16 million people travel in minibus taxis that are designed to carry 10 people, but there might be 20 or 25 people within a taxi. All of that, in fact, has now been stopped to try and limit and flatten the curve. Communication is exceptionally important, not just to get out a single message, because there are multiple languages and people need to understand those issues. Not everyone is literate as well, and so messages have to be passed on in an appropriate fashion. But it is still feasible to try and introduce impeccable infection prevention control and ongoing and continuous education. Organizational skills are paramount as well. We've in fact freed up as many beds as feasible, stopped all urgent and elective surgery, and you've got to involve all the players. And I was listening earlier on to the American presentation. It is no different to what we are trying to in fact do here. And all the players mean the medical individuals and across the specialties, relevant nursing staff, and other entities that are often forgotten outside of the allies, the cleaners, security, and so on. And we've also looked at the issue of utilizing auxiliaries. We have what are called clinical associates, and Maurizio, you alluded earlier on to medical students. We're looking at that as well. Additionally, decisions that are decisive need to be taken. And we also have to address the fear and panic that currently is embroiled throughout the continent. We're all learning as we go along, and we need to recognize that and be flexible. And another very important issue where there's limited staff, and in any setting, is staff support. What about the ICU situation? Well, there's absolutely limited capacity. In fact, Brazil are better off than most resource-limited settings with 7 beds per 100,000. In many African scenarios, that bed number is under 1 per 100,000. In fact, until recently, and it has improved, a place like Uganda had 1 bed per million adult individuals. And so there's a reality. In my own country, they're under 2 beds. And so real capacity problems. And as a consequence of that, admission is going to have to be based on the merits of any patient and unit capacity. And that means, very importantly, triage and ethics. And in fact, we've already put in place ethics teams that will make decisions as to who comes to a critical care setup and who doesn't. And some years ago, we put into place an entity called the ARDS, which is a very useful way of trying to address many ethical issues on firm ground. It in fact evaluates 5 and possibly 6 R's. Is there rationale? Is it reasonable? Is it realistic? Is it responsible? And if you have a yes to all of them, then it's the right decision. If they're no's, then the decision is made. If there's some yeses, some no's, then you employ the 6R, which is you go back, reevaluate, reassess, and reconsider. We put together intubation teams, both to improve expertise as well as to limit spread, potential infection of broad spectrum individuals who are utilizing intubation. And in fact, because we cannot employ and invoke large critical care capacity with ventilation, we've initiated polymask wards, and very successfully. And we've got a lot of experience treating patients with pneumocystis and a much younger population who tolerate the hypoxemia somewhat better. And in many instances where we would ordinarily have employed intubation and ventilation, we're getting away with polymasks. We're trying to standardize protocols and keep them simple so that there's a uniform invocation of them. And then this is done hand in hand with attention to detail, using impeccable clinical acumen, something that's been forgotten around the globe. Clinical medicine still has a major role in these issues. You can, in fact, often invoke many excellent measures just by using excellent clinical skills. What about frontline workers and protection? Well, because of the potential for burnout, ongoing encouragement and support, the employment of auxiliaries, and as I mentioned, we do have these clinical associates. They undergo a 3-year course, something between a nurse and a doctor, and in fact, they do excellent work. And then again, a major emphasis on exemplary infection prevention control measures, including innovation. So if you look at the right top hand portion here, we're using construction hats with the visor, which can be cleansed over and above normal PPE. Videos so that we can disseminate issues. And in much of the resource limited world, many individuals in fact have mobile or cell phones, and so these can be disseminated. And similarly amongst the medical fraternities, telemedicine we're looking at as well to try and guide people who may not be in skilled areas. And we've invoked train-the-trainer sessions for PPE specifically. And then it was fascinating listening earlier on to the potential spread of the virus within the air. And in fact, extrapolating from our experience with tuberculosis, opening windows often addresses that. So it is virtually non-feasible to have negative pressure rooms or fancy devices that extract the virus from the environment. And in fact, you will achieve as good a number of air exchanges with open windows as often the very best devices out there. And that number is around about 12 air exchanges per hour. And obviously the exemplary measures also extrapolate to laboratory individuals where those are in fact available, transportation and ward layouts. A lot of thought needs to go into this. If you look at the middle picture in this particular slide, you'll see another innovation that we've looked at is just creating a perspex box so that people who are intubating are protected. And on the left-hand side, you'll see the employment of these auxiliaries who are doing a fabulous job in preventing burnout and adding to the workforce. And on the right, a patient we just admitted who required ventilation, in fact, was referred to us with the appropriate transportation. So if we have to conclude, this is a massive challenge that we are potentially facing in resource-limited settings. Our patient profiles are entirely different, and so is the healthcare infrastructure. But it is feasible to offer good quality care with basic sound principles of practice. And that often just means simple interventions together with some of the creative and innovative issues that are currently being rolled out. But we do need a collective effort, we need committed collaborations, and we need cohesion, together with inspired leadership. And even in the face of adversity, we've got to strive for excellence. And so a wonderful African word and South African word that is extended beyond the shores of the continent as well is Ubuntu. And Ubuntu is a word that means that we must always remember that we need to go through these things with compassion and with a degree of cognizance of humanity. And as always, I think it's very important that we not lose sight of the fact that we're in a major catastrophe, but there's always potentially light. And I had the privilege of growing up in a country where I had exposure to Nelson Mandela, who when history is written almost certainly will go down as the greatest statesman ever. And he taught us a lot about how one can deal with very difficult issues, taking out his own personal experience. And I want to share this quotation for everyone who's listening. What counts in life is not the mere fact that we have lived. It is what difference we have made to the lives of others that will determine the significance of the life we lead. And I think if we can all make that difference, there is hope. And if there's hope, there's light. And that means we can move forward. So I want to finish this, as I often do, on a harmonious fashion. And I'd ask you please just to listen to the words.
There comes a time when we heed a certain call, when the world must come together as one. There are people dying. Oh, when it's time to lend a hand to life, the greatest gift of all.
Let's move forward together in unison. Gracious and humble thanks for this opportunity to share a few thoughts about low middle income class countries and resource limited settings. Thank you very much.
Thank you, Mervyn. You cannot see it on camera, but you gave me goosebumps with your talk. And I have to say, for as much as I hope that we can help low and middle income countries, I think there is so much to learn from your creativity and from the way that you've been able calmly to deal with the situation as if it is a normal thing, because actually you are faced with this on your daily basis. So we are actually learning so much from you now. But now I would like to go back to how we can help with COVID-19 in Africa. I don't think, correct me if I'm wrong, that bringing ventilators there from Europe is going to be something that is going to make a huge difference there, considering the lack of resources that are there. I suspect maybe we can work on that too. But if I understand correctly what you're saying, it's about trying to do simple things correctly, basic things in the right way, and again, trying to slow down virus transmissions. How can we help you to do that?
Well, thank you very much, Maurizio, for those kind words. And I think the sentiments you've expressed are exactly that. And, you know, I think these issues go beyond just resource limited settings. If you do the simple things well in any setting, you're likely at least to have a favorable outcome in many scenarios. If we take the equivalent, it's like building a skyrise building with many stories. It is not good to start with the penthouse at the top and build downwards. You've got to have a solid foundation. So principles and basics, I think, are really relevant. In fact, simplicity is the ultimate sophistication. And that's what we need to do. So for the vast bulk of people in continents like Africa, it's going to be about containment. And we've learned wonderful lessons, I think, from the Chinese. If we had a look, and I was looking at some statistics earlier on today, where in Shanghai, based on the projected estimate and numbers, they thought that they may be dealing just in Shanghai with 1 million people by March 1. And in fact, that wasn't the case because of very stringent containment. And certainly in the South African setting, our authorities have engaged. And in fact, we told them 5 weeks ago to lock down already, and it took several weeks to do that. But we're in total lockdown at the present moment in order to try and contain. The numbers are escalating significantly, and like in Brazil, are almost certainly an underestimate because of the non-availability of widespread testing and also a lag in reported results. And so the numbers are almost certainly much, much higher. And the containment is very important to try and limit, where there are already major resource limitations, the numbers that healthcare systems may have to deal with. But we have thought beyond that. We already have engaged and looked at the issue of opening national exhibition centers. Schools are closed, so we can use those facilities. Major hospitals have been designated as hospitals to go to where there are better skilled individuals. We have closed down certain wards. All surgery that is non-urgent has been stopped. And we've in fact tried to create an organizational issue where many elements in fact are relatively free-flowing, and where we can introduce very simple measures that can make a difference. The introduction of the polymask wards, I think, is something that I've not seen or read about previously. And because we have a younger population, they often tolerate the hypoxemia remarkably well. And ordinarily,
Mervyn, I don't think many people know what a polymask ward is. You were explaining this to me before. Can you elaborate that?
Yes, it's just a rebreathing mask. It's a rebreather, which can provide between 60 and 100% oxygen on a face mask. So as one would grade up from conventional Venturi masks, a rebreathing polymask can provide a significant amount of oxygen. And it's always interesting because very often we found, for example, in our pneumocystis patients, based on our large experience with HIV, the patients will come in with severe respiratory distress, breathing at 40, 50 per minute, marked hypoxemia, oxygen saturations of 70 or 80%. And then, in fact, they tolerate these so-called rebreathing masks whilst we judiciously, clinically tide them over. And we often avoid ventilation in that setting. Those patients, when you try and ventilate them, you can never achieve those minute ventilations and volumes, and it becomes exceedingly difficult. But we don't have the resources to even offer that on a wide scale. So we introduced this, and certainly as the numbers are emerging, I can tell you that it appears to be successful. But you know, as this unfolds and unravels, we may be able to share some further information on that. We are also looking at very, very simple for a very limited number of ethically acceptable patients to ventilate, looking at very, very basic, simple ventilation, and that is currently being planned and looked at the present moment, but it'll be on a limited scale. But for the rest of significant resource limited settings, it's not even an option. In fact, many of our neighboring countries and elsewhere in Africa have already made the decision that ventilation won't happen. And you know, that is a very real issue, because we also have a massive burden of disease outside of COVID. So, for example, which is often confusing issues amongst the entities, tuberculosis. And tuberculosis, for example,
That Mervyn goes back to what I was going to ask you, is that you're right. We do have to remember COVID-19 is making competition for resources even more difficult. And of course, in low middle income countries, this is going to be even more important. What can a program like the Alive Fund educational course that you've been leading around the world, what can it offer, and could it be something that as a society we could support, maybe to help with this and with other infections in low middle income countries?
Oh, thank you, Maurizio. I think it's a wonderful question. This particular course has been designed to deal with exactly those issues. It's about conferring very basic, important, practical principles that in fact impact dramatically on outcome, together with basic clinical bedside teaching in a course that's absolutely unique. And it's been run now and rolled out in Uganda, as you mentioned earlier, in Pakistan, which was amazing, and now in the Caribbean. And there's absolutely no question of doubt that this has a major role. In fact, taking away any personal interest in it, and I must say I'm enthused every single day that I think of it, particularly in the context of what's unraveling around the world now. If we can get the core principles right, you're going to salvage, you're going to offer excellent care to the vast bulk of individuals. And it's about mastering basic principles in any context. And if we are able to do that on a broader scale, including for what we are talking about now, I have no question of doubt that we will make that difference that I was alluding to earlier on. And in fact, if we took it a step further, I'm not sure that something like this shouldn't be rolled out very broadly and then provided as some degree of certification so that it sets a basic benchmark for healthcare in general in resource-limited settings. And there's no doubt in my mind that populations will benefit from it. The course is designed in that sort of fashion that it will cover all the common diseases and sepsis in general that one encounters, both in adults and in pediatrics. And so I really commend ESICM for initiating this particular venture. I think it's a unique project, and I think it's a brilliant project.
Okay, so before I would like to thank Luciano and Mervyn. You can see that there is a slide, everyone. That's our live fund. Please donate. We are going to use that money to support education on everything that Mervyn has explained in low and middle income countries. And we think that if you donate money for this, we can make more difference by delivering more courses around the world. So you will find these links on our website. You will find it on social media. Please spread the word. We do want to help. We are learning a lot from low and middle income countries, but we also want to help you. So thank you, Luciano. Thank you, Mervyn.
Thank you very, very much. It's been a real honor to be with you.
Thank you, Mauricio. Thank you, Mervyn. Bye-bye.
Bye.
So welcome back, everyone. And I think we're starting what is for me probably one of the most important sessions to learn and to share with everyone. I can tell you personally and also from my team, the biggest challenge during this outbreak has been how to deal with families. We know that in order to maintain containment and to avoid the spread of the virus, we had to restrict visiting times, visiting hours. So I really look forward to this session. It's a great pleasure to have two great speakers. One is our president, Joseph Keseshoglu, but before him, I would like to introduce the first speaker, who is Professor Eli Azoulay. Eli is also a friend, and Professor Azoulay. Hi, Eli, how are you?
I'm very well, thank you. I'm very happy to be with you.
We are very happy that you're here. I know that you're also very busy in Paris, but we are very happy that you can make it for the time to be with us. So just let me introduce you to the others, Eli. I know everyone knows you, but let me go ahead. Eli Azoulay is a professor of medicine, a specialty pulmonary medicine and critical care director of the medical ICU of the Saint-Louis Teaching Hospital in Paris. He is the director of the research group of the management of acute respiratory failure and outcomes in critically ill immunocompromised patients, and the director of the French Familia Study Group, a multi-center collaborative multidisciplinary group funded by the Ministry of Health and the French Society for Critical Care, aimed at improving effectiveness of communication with family members of ICU patients. Eli is past chair of the ESICM ethics section and former editor-in-chief of the Society Journal Intensive Care Medicine. So welcome, Eli. And it's a pleasure also to introduce our president again. I'm sure everyone knows him, but it's a pleasure to introduce again Joseph Keseshoglu, who is also going to speak about this subject. Hi, Joseph. Joseph Keseshoglu is a professor of intensive care medicine at the Department of Intensive Care Medicine, University Medical Center in Utrecht in the Netherlands, and the current president of our society. Professor Keseshoglu was a chairman also of the ethics section of the European Society of Intensive Care Medicine, and after finishing his term, he became the elected chair of the Division of Scientific Affairs. He's authored around 130 published or in press peer-reviewed papers, and his main interests are ethics and the intensive care environment. So we are going to have time to ask questions and to hear about this challenge, both with Eli Azoulay and Joseph Keseshoglu. But before that, Professor Azoulay is going to give a short introduction. So Eli, please.
Thank you. I'm again very happy to be with you and to share this ESICM marathon webinar. So how can we improve communication with family members during the COVID-19 pandemic? Well, you know very well, and after this marathon, what are the figures at a global level? And we know that the barriers for optimal communication are, above all, isolation and containment. For obvious reasons, we know that the ability of COVID-19 to spread has an R0 of 2.5, making that the problem is really how we can stop the disease, and containment has been suggested not only by the evidence that there are clusters of people who are contaminated by being approximative to each other. So this is why we recommend people to stay at home. But also, we know that the psychological impact of quarantine makes that family members that are far from the patients are also experiencing many different symptoms: stress, confusion, anger, and many issues with communication gaps. So we understand that containment is mandatory, but it limits family visits in the ICU and our ability to help them to provide empathy, optimal communication and decision-making. And this is also a problem for the patients. This paper published in Critical Care shows that delirium is increased in critically ill patients who are subjected to isolation. The second point stands on the acute respiratory failure itself. And we know that family members of our ARDS survivors or patients with ARDS who died in the ICU not only have more post-ICU burden, the prevalence is higher, but also it's sustained over time, making that these family members are burdened by the ICU long time after patient discharge. Very few papers that I'm going to report, just this one to show that family members are as sick as patients following ICU discharge, showing very clearly that the burden is on both subjects. When we are going to focus on family members of patients who died in the ICU, you can see that when patients are perceived as not breathing peacefully with acute respiratory failure, family members 3 months and 1 year after the loss will have increased symptoms of post-traumatic stress disorders. You can see here that when the patient is not seen as breathing peacefully, not only increases PTSD, but also complicated grief. And this is a study that has been recently published by an Italian group in Minerva and Minerva Anesthesiologica last year. But these patients are the sickest ARDS patients receiving VV ECMO. And you can see here that not only the levels of anxiety and depression are the same, but also post-traumatic stress disorder is much higher in family members. Look at the IESR, it's 21 in patients, but 34 in family members, showing that 2/3 of them have severe PTSD-related symptoms. And my last point is related to the media. The family members that are of our patients in the ICU not only cannot attend the ICU, but also are subjected to very high pressure on the media. We know that the media is also shaping the fears, but also is providing an overwhelming amount of information, making that people are on the edge and are very, very burdened by this amount of information. So to summarize, and I have 2 slides, acute respiratory failure and ARDS that are characterizing the COVID-19 pandemics put family members at a very high level of emotional burden. Isolation and containment worsen these symptoms. and the social climate may be clouded by the overwhelming information from the media. So what we are suggesting for family members is based on this 5S strategy. One is to stimulate family visits. We know that many hospitals prohibit family visits, but we are encouraging critical care teams to open the ICUs, of course with limits and of course with effective PPE for family members, that this is what we do, and we are making that at least one person can enter in the ICU every day to see the patient. Two is that we are providing family members with a standardized written information. Three, we set up routine telephone calls with the relatives. It's the medical students who are doing that once a day, but the nurses and the doctors also respond to family requests over the phone. We also solicit family members' creativity. We use FaceTime, WhatsApp, video, so that they can see the patient in the room. They can also have a virtual ICU visit. They are completing diaries that are remote. We are also using text messages to keep them informed and media groups. And of course, unfortunately, when we are in patients who are about to die, we are opening the ICU and preparing the family members to say goodbye. Thank you very much, and I will be very happy to share the discussion with Professor Kesesioglu and Professor Cecconi.
Thank you, Eli, and thank you, Joseph. So I think we have a lot of questions that come here. I would like to start to ask you again. I mean, Eli, you mentioned a little bit, but I'm not sure it's the same policy everywhere. So I would like to hear both from you and from Joseph. Clearly, we work for the last 10 years, 15, 20 years to try to open intensive care to relatives as much as possible. This is now a drama for us, for our patients, for our families. I think no one was prepared to this level of isolation for this virus. What do you do either in your country or in your unit? Do you still allow relatives to come and visit, or do you restrict everything? Because, for instance, in my country, we are now restricting all the visits to the ICUs. Maybe, Joseph, do you want to start?
Sure. First of all, I would like to give one or two sentences from my background that my main struggle had been before 2010 to change the visiting hours from, let's say, 3 to 6 in the afternoon to 24/7. And it worked. And I must say the last 10 years, from 2010 to 2020, we had 24/7 visiting hours. And this was creating a huge happiness by the family, but also by the patients. They appreciated that very much. I mean, even though the family is not staying there 24/7, that they can come anytime they want was a big gain of quality and also service for the patient and the family. So it's for me very painful with the start of this pandemic to be obliged to do some changes. And when I say some changes, we have twofold changes actually, because from 10 days ago, we have opened a second ICU unit in the post-operative care unit of our operation rooms. So my ICU, the classical ICU, is consisting of private rooms, which means that the doors can be shut. Some of them are having negative air facility, some of them are not. But can comply the hospital's one family per patient per day rule, and they can come and visit the patients, although we discourage them to go into the room, but they can communicate from outside. If the patient is alive, they can give messages. If not, they can watch their patients and they will get information. Unfortunately, the cohort at the recovery room, at the OR, is not designed to be an ICU. The beds are too close to each other, and we need the numbers. And we are forming there up to 25 extra beds. As of now, that is 12, but we are increasing it every day gradually. And I think on Monday or Tuesday, we will reach to 25 beds there, making a total of 61 beds from our normal 24. But then we realized that we really cannot allow the family to go in there because if they go in there, very much prone to aerogenic distribution of the virus. As we also told them, our nurses and our medical personnel are specially trained to protect themselves. Whether the protection is 100%, that can be discussed, but they are really trained for that. And it is very difficult to protect the family. So we have two procedures. Actually, when they are in our recovery area, or the patient is in our recovery area, the family will be called at least once a day during a certain hour by the nurse, by the physician, to give information to the family members. This will also be done in our classical intensive care unit, even though the family can visit, because normally we had a very liberal call from the families. But this time, every time the family calls, the nurse has to get out of the room. It means that all the clothing would be changed and the mask should be taken out and the hands should be sterilized. So we also apply there a certain hour that we call them and they don't call us. And of course, as Eli said, we unfortunately have some patients who eventually die, and we cannot, I think, morally allow them not seeing their patients. And we are doing some exceptions for these people under very strict conditions. What Eli said is also true for us. We are using iPads. Actually, we are starting to use iPads. It's very we have just bought the iPads. As of now, it should be active, but I'm not very sure. But that's one of the methods. We are having phones to communicate with the room inside and outside. And we are usually taking pictures and sending to the family. And that is how it is at this moment. But I think we will use more electronic equipment to keep the family in contact with their patient.
Okay, thank you, Joseph. Eli, do you want to comment?
I think that we are in line. We are making our best. Of course, with the pandemics, we have open ICUs outside the walls, so we are not always in the same ICU conditions. I would say that the most important thing is to develop a strategy. I think that doctors and nurses must understand that a normal relationship with the patient and the family members is also helping the decision making, is also giving a sense to what we do on a daily basis. So for the nurses and the doctors to have a strategy to communicate with family members at a very critical time like this one is important. So they are very enthusiastic about that, and I think it's effective. Of course, as we are opening ICUs outside the ICU walls, we are not always in the best conditions, but making our best and showing to the family member that they are important to us and that we are developing something for them is something that I find very important.
So it's such a challenging moment, I find, for all the way that we interact with our patients and with each other. I mean, we all have our heroes in this pandemic, and I'm sure that you agree that our teams, my team for me is my team of heroes, you know, everything that they're doing.
I agree. Our nurses are wonderful. I think that we are discovering.
Really, but what I was trying to say is I do find it's a lot of enthusiasm now when they can save one patient. When you extubate this patient, you know, with their mask, they cannot smile to them. They smile with their eyes, you know, they hold their hands. All the communication has completely changed. And, you know, we are becoming very creative. We do some drawings to try to explain them what's happening. It's really amazing. Yeah. And that's, I think that's the nice part of it. Unfortunately, of course, we also deal with a very sick group of patients, and we have a lot of patients, especially when they are older than 70. that they do die, and they die with this sense of not being close to the family. And I saw that's clearly that's difficult already for the family, but I see a lot of difficulty for my team, and I do wonder, do you have any strategies to cope a bit with that? You can see that they feel like they've been deprived from their way to communicate. You know, you're not smiling, you're not showing some empathy with your face easily with people from far away. Everything now is with a phone or with an iPad. It's not the same thing. How do you tackle these things? And so the support, not just for the families, but from how our team is feeling on the shop floor. Again, maybe Joseph before, and then Amy.
Yeah, that's a very good point, because we have at this moment the advantage of being right in the middle of the center of the problems for something like 10 days. I mean, we were preparing much longer than that, but we have gone from 1 patient to 33 in 10 days of time. So what happens is that in the past, with normal situation, the nurses and the physicians were building up a relationship with the family and also with the patient. We had the policy that if the patient was staying longer than 4 or 5 days, there would be only one physician as much as possible selected for that patient and speaking with the family, and if the patient is awake, also with the patient, in order to avoid giving different information. So that was a building up relation and having the talks with them. Now this is gone completely. It is something that you don't see each other too much. You are talking on the phone usually. And it may even be that if you don't have time when somebody is dying, you will have to tell the family that the patient is dead on the phone. And that has a huge impact on the medical and nursing personnel. Just picking up the phone, how am I going to give this news? Just like that. I'm sure we are not yet aware of the situation, and I'm sure in the coming week or maybe a bit longer, we will start to realize this more and more. But we have been very quick in searching for psychological help to the medical and nursing personnel. Every day there is a certain time frame that they are in the ICU, not on the floor, but somewhere in a room that you can talk with them if you think that it is necessary. As of now, it is very lowly used. I mean, people don't use it very often, but they are there, and I'm sure in the coming days they will be very much looked for just to talk and try to get some help.
And I think, Joseph, sorry, before Eli can comment on this, but I think you're absolutely right. I mean, we call this the COVID marathon, but I think this is going to be a marathon. It's not a 100-meter sprint. And at the beginning, you have all the adrenaline and all the energy for the new challenge. And after a few weeks, the work is tougher, is more patience, but also you start to get a little bit tired mentally and physically. We're all working very long hours and in a very difficult conditions. So I think you're right. We need to try to support our teams in this, thinking that this is going to be a long marathon. Eli, please.
I absolutely agree, and I think that this is a very important point, and making our teams aware that we are paying attention to how they do and on their mental care is also important. I think that there are two things that we could comment on. One is, I think that the proximity between family members and healthcare workers is also based on the fact that we are all involved in the pandemic. We are all contained. We are all in quarantine, and our kids are not going to school, and we are sharing actually the same strain, the same social strain. So this makes us all together in the same boat. The second thing is what you both said on what is going to be the long-term outcome of this pandemic, not only at a patient level, of course, this is our main issue, but also at a family level and at a healthcare professional level. And we know that this is something on which we will need to pay attention, to give not only to our teams the credit of all what they do, but also understand with them how important was their actions, everything, the small things and the big things that they did, and how it impacts actually on their healthcare. And I think that this is something that we will need to measure and something that we need to follow and to debrief in the close future.
I have a very important question that is coming from the internet, which actually we've experienced also personally, and I don't know if for you guys is the same. Not with people within our team, but clearly with 11% or 8%, this is the range of healthcare workers being, you know, all the percentage of all the positive cases. It's very common now also to see healthcare workers. And so how do you find it for your team if it happened, or how can they prepare? It happened definitely already in my team, to look after doctors, to look after nurses that become sick from the disease. Of course, it's very easy to say they're just another patient, but we all know that it is really not just that. And I was wondering whether you have any experience of it, or how we can be ready to emotionally and mentally, you know, look after very sick, critically ill doctors and nurses into our units. Joseph?
Yeah, I don't have that experience, although we have a number of people from our team, nurses and physicians, who have become positive and who have become sick, but they were not bad enough, luckily, to come to the ICU. It is a difficult question because I have been facing the last 40 years that I'm doing this job, I have been facing with the admission of colleagues. And you see at a certain moment, it is difficult, but we are also trained as really professionals. And if you know that, whether the person is your colleague or somebody else, and if it's colleague, of course, it's much more difficult, but you are still the only hope. I mean, not you as a person, but as a team. So I think the professionality will prevail in that case. But of course, I don't have the experience to tell you what will happen if that's one person versus what will happen if it is 10 or 15 people, you know, and I hope we don't go that far. The fear is there, of course, among the medical and nursing personnel, because that can happen to you moments, that can happen to your family, to your children. And the fear is there, but I must say the first 10 days that we are experiencing this, the spirits are high. We get always from people to come to offer more help, people also outside the department. I have nurses who want to come back, even they are retired recently, they come back also. We recruit from other people. So the fear is there, but it's not keeping them out of the ICU. It is really keeping them within the ICU. I hope we can maintain this also on a longer period, which we are going to face.
Okay, Ellie?
Well, I think that this is a very tricky and stressful issue. Unfortunately, we also have numerous healthcare providers that have been contaminated, and we have both doctors and nurses who have a severe COVID pneumonia in the ICU. I must say that everyone is aware that this is something that can happen, and despite we have, I would say, optimal PPE interaction, and the things are well, people kept it very professional, and we provided exactly the same care without thinking too much that this is something that can happen. But every day when we go to the hospital now, we know that this can happen. And I think that we debrief this a lot with the teams. We have a daily debrief with the team during the daytime and a daily during the nighttime. We have a 12 hours switch. So we are spending time to debrief on these issues with the nurses. But I must say that this is a very tricky issue and something that is stressful for everyone.
And that's why I think I agree with you. That's exactly how I feel and how we are approaching the situation. That's why I think it's also so important to show that the management, the ICU directors, all the leadership takes it so seriously to have all the training and all the personal protective equipment for our staff. It's very important to show that you care about that you care about proper training in donning, in doffing. And I think it's really, you know, something that can make a difference for how your team feels safe. Before we move to the next session, I would like to give the word to the two of you, just a couple of minutes each. If there is any message that you would like to give as a take-home message for how to deal with families and emotions during this time, during this pandemic. I don't know who wants to start. Maybe you, Joseph?
Well, I can, but your question is, of course, not a very easy one. We just take the world as it is, and we take the world as it comes. The important thing is to keep very good contact with the family, whether it is on the phone or whether it is face-to-face, if it's possible. And also, we have to maybe make special teams, as we were talking with each other today, just not to let the physician who is really deeply busy with the treatment of the patient also save time to talk to the patient family, because I mean, if you are talking to family, you are not talking about a 5-minute phone call. They will want to know everything, and they will have a lot of questions. They will be worried. They will be anxious. We need also maybe to specialize in our daily work. We have a lot of colleagues working in other wards who do not have as much as work now to do because of the daily work being reduced, and all the work is concentrated on COVID-19 patients. We have to reorganize our work. But in order not to be frustrated more and more during the pandemic, we have to realize in our minds, we have to make a change of mindset that we are not in normal times, and the expectations should be actually different. The quality that we gave to our patients, we will certainly want to keep it as high as possible, but we should also try to expect that it can be lower, and we should also communicate this with the family, that we are really facing an extraordinary situation. I have personnel to run 24 beds. I am now having, at the end of next week or beginning of next week, 61 beds. All the anesthesia nurses are recruited. All the nurses from the departments, operation room nurses, they are recruited. We are working on students. So we have to agree and accept at a certain moment that this is an unbelievably extraordinary situation. And if we concentrate, I was also telling this actually during the ECMO talk, if we concentrate on the great aim, we will lose a lot of patients. So we will have to reduce from each patient in order to be able to help the bigger masses. And that will not be a very easy job.
Thank you so much, Joseph. I think there was very wise words. Eli?
Well, I would like to emphasize that despite the fact that we are undergoing a very unique situation, we must consider that family members following a patient discharge will be almost as sick as the patients. We are dealing with very vulnerable family members. And when we call them back 3 months, 6 months, and a year after ICU discharge, and what we can notice is that very simple and small things that caregivers that healthcare providers are doing in the ICU can translate into impressive benefits for the family members. So I would, above all, thank very much all the nurses and all the teams for what they are doing for family members. But I also want to emphasize that all these small things actually also provide them a good care for family members after the ICU. So if we are able to reduce post-traumatic stress disorders, if we are able to reduce family members with anxiety and depression, not only they will be in a better shape to care for the patient who is surviving a very difficult condition, but also themselves, they will be in a better shape to face sometimes, unfortunately, a grief, and this grief can be less complicated when nurses and all the healthcare team has made very small things then translate into very significant benefits for the family members. So I would very much encourage the teams to not only do, but also show how much it is important. I think that we need to help each other to give small things to the family members, but most of all, telling them that we are in, as Joseph just said, in a very specific, special, and unique situation, and that we are still making our best to address their specific needs.
Well, I have to say, I was not expecting anything else, anything less from two previous chairs of the ethics section and knowing you personally. But I would like to thank you because you've been able to be very clear, very transparent, very honest on your answers. I am sure that everyone that is watching is taking home some very reassuring messages and some very important messages. So it has been very nice. Thank you.
Thank you. One more new session, ladies and gentlemen. This time I would like to invite Professor Howard Buchner. Professor Howard Buchner was appointed as the 16th editor-in-chief of JAMA and the JAMA network in 2011. Prior to coming to JAMA, he was a professor of pediatrics and public health at Boston University School of Medicine and editor-in-chief of Disease in Childhood. He is a member of the National Academy of Medicine and an honorary fellow of the Royal College of Pediatrics and Child Health. Since his arrival at JAMA, Howard has focused on publishing important and novel research articles, and JAMA now reaches over 1.5 million physicians each week worldwide, and views increased from 10 million in 2011 to 34 million in 2019. Howard, please, the floor is yours.
Thank you, Joseph. And I want to thank ESICM for the privilege of speaking today. I'm hoping my slides will advance. Let's see. Is there a problem with the connection, or are my slides on? Great, I can't see them. Okay. So I really represent quite a group of journals, both JAMA and the JAMA Network journals, but I also want to speak to the issue of all journals. Firstly, all journals have been committed to making their content free. I think that's really important, and that's been true through virtually every epidemic that's occurred over the last few years. The second is we're processing manuscripts in a matter of days. It does depend on the manuscript. So, for example, the article that we published yesterday, Treatment of 5 Critically Ill Patients with COVID-19 with Convalescent Plasma, because of the importance of that article, it took us a greater amount of time to make sure that we got it right. So we were comfortable holding up that manuscript for 3 or 4 days rather than 2 or 3 days to ensure that the content was valid. Many of the manuscripts early on in the pandemic have been translated into China. We have a dedicated landing site, as do most of the major publications. We provide links to WHO for all of our content, which is free. And then, of course, we've tried to really expand the way we distribute content differently than has been in the past. So now we use social media and the electronic table of contents, well over 1.5 million followers. And the print has changed over the last few years. And so now we use live stream events. I'll return to that, podcasts, infographics, crowdsourcing. This past week, we received 100 submissions a day. We received 500 submissions this week. It's difficult for us, but we will manage. It's critically important that high quality content be reviewed quickly and distributed. We publish both research, opinion, and reviews, and our content to date has had more than 10 million views. This is an example of some of the content that we've published. Obviously, the one on the upper left, characteristics and important lessons from the coronavirus disease 2019, the report from the Chinese Center for Disease Control and Prevention, has had over 1.2 million views. The manuscript on the bottom is by Tony Fauci, who's the National Institute of Allergy and Infectious Disease Director, has become the spokesperson for the healthcare group in the United States. That's entitled Coronavirus Infections More Than Just a Common Cold. That was published on January 23rd, 2020. And that clearly was prescient. And then you can see the article on the far right, case fatality rate and characteristics of patients dying in relationship to COVID-19 in Italy. Clearly, over the last week or two, the submissions of manuscripts have really changed in some regards following the worldwide pandemic. Whereas in the first month or 6 weeks, it was dominated with manuscripts from China. This past week, manuscripts from France, Iran, Pakistan, and Italy have all dominated submissions. I'll move to the next slide. I have 3 heroes, and I really want to be clear about why these people are so incredibly important to this pandemic. In the United States, without doubt, Tony Fauci, who has lived through every epidemic and pandemic over the last 40 years, has been the voice of reason in the United States. It has been difficult in the United States, in part because much of the leadership understands the reality and facts very differently than other people. And I think Dr. Fauci single-handedly has tried to insist that evidence and data make a huge difference in the future of how the United States and other countries around the world will deal with this pandemic. It's hard for me to understand why Mauricio's live stream event that we did with him almost 2 weeks ago, I believe, catapulted the world to understand what was coming. I think there was an appreciation from China about the potential catastrophe that the world faced. But I think Mauricio single-handedly, in the 35-minute live stream event that we had, crystallized to the world what the struggles were going to be. I just can't emphasize that enough. He spearheaded just an enormous amount of change both in the United States and around the world. That live stream event has been viewed by more than 1 million people around the world on Facebook and YouTube. And I think it also emphasizes the way in which the world has changed. And then all of you, healthcare workers around the world, physicians and nurses, are clearly my heroes. And very quickly, I just want to go through some of the public health and scientific observations that have come across my desk and what I've read that we've published, have not published, or has been published in other journals. I think the world will look back and there will be no questions that China's quarantine worked. I think when it initially debuted, there was a great deal of concern about whether, one, it would work, and then secondly, what did it mean to the population in China? But I think the sparing of the major metropolitan population areas in China have clearly signaled that it has worked. Taiwan, Hong Kong, Singapore, and Korea have had tremendous success, but I'm not sure they're representative for the rest of the world. They are three very small populations with very sophisticated health information technology, but a great deal of credit needs to go to Taiwan, Hong Kong, Singapore, and Korea. China gave the world 3 or 4 weeks, and most countries, including the United States, squandered that time. And I hope we learn from this pandemic and that never happens again. Without doubt, the time squandered in the US and the inability to mount rapid testing, I mean in terms of hours and not days, has led to organization and logistical nightmares in the United States and I believe around the world. And it has also led to additional appropriate but misuse of PPE, in part because hospital systems in the United States, and I expect elsewhere, simply do not know how to triage patients. Without doubt, the single most important immediate healthcare event is that healthcare workers must be protected. Most places have sorted out ways to increase ICU beds and obtain more ventilators if necessary. But without healthcare workers, increasing the bed count will be unimportant. The US is managing. Unequivocally, New York has become overwhelmed, but the other cities in the United States are managing quite well, in part because the number of cases that have led to ICU admissions has been reasonable. And so places like Boston or Seattle are doing well. You'll hear from Derek. Places like Pittsburgh simply don't have much disease. And then some of my scientific observations. There's a great deal of tension over unapproved therapies in the intensive care units. People have written about that in our journal. I understand why it's occurring. Derek will have a piece that comes out on Tuesday and Wednesday and tries to frame why there's tension between the academic research community and clinicians who are trying to save lives. The ACE-ARB question remains unsettled. There's different elements of that question. First, do people on ACE and ARBs, are they more likely to have disease? And then if they acquire disease or become infected, does it influence the course of their disease? It's still unclear why children seem to be, although they may be vectors, they do not seem to be substantially impacted. Route of spread is clearly respiratory, but whether or not the virus lives on inanimate objects and can be transmitted that way is unclear. We just published the first reports of vertical transmission. We were very careful in the choice of words that were used. Again, I already mentioned the passive protection, time-honored, 100+ years. At least a small case series that we published seems to suggest that it has worked on numerous clinical outcomes, although with a case series of 5 and no controls, not much more can be said. It's very unclear what September will bring. Will it be more like influenza or more like other pandemics? About 20 to 30% of patients around the world generally need to be hospitalized, and about 1/3 need ICU beds. The case fatality rate remains variable. I think at best it's 0.5%. To 0.1%. Germany remains quite low, but it tends to rise over time and it's clearly over 5% in many countries with very sophisticated healthcare systems, clearly related to the age of population, comorbidities, likely coding differences, questions about the number of ICU beds, and clearly related to preparedness. And then the last is, over the last week, JOM has been asked to evaluate different predictive models. I am concerned about these models. They vary by factors of 100 or 1,000. Major decisions are being made based upon these models. Some of them are static and not dynamic. And I think we need to be much more careful in the decisions that we make based upon these prediction models. Some of them are very simplistic and are, I think, not representative of high quality data. I'll stop there and I'll turn it over to Derek.
I think maybe we can take a couple of questions, Howard, before we turn it over to Derek.
Vary by factors of 100.
And one of the questions is the challenge of constantly changing information. If we look at earlier publications, actually China was reporting 5% ICU admission. Later it has become 10% in Italy. In my country, it's even higher. And also, of course, it also depends on how many people are you testing or not. But how is a journal like JAMA, but also other journals, are coping with this sort of changing information, because you publish them after each other? Could you just elaborate on that?
Sure. I think most of the journals, Joseph, have taken two tasks. So, for example, we're publishing a major report from Italy early next week. It's a large case series. For that article, it was reviewed internally. It's a case series. We knew what data should be in a case series. We went back and forth a few times with the authors, but that did not go out for external review. That's in contrast to any article that we think is going to have a major therapeutic or have major therapeutic implications. So, for example, the article on vertical transmission, which we know is going to be create a great deal of anxiety, that went through external peer review twice because we were so concerned with the message. The article on convalescent plasma underwent external peer review with all 4 peer reviewers recommending publication despite the caveats. I think the point you make, though, is critical for those that are developing models and relying on models. Models need to be constantly updated with the most relevant data. So, for example, the R0, if you're doing social distancing correctly, the R0 changes. In a country like the United States, where a state like Colorado is younger and healthier, the implications of the pandemic are going to be very different than many of the southern states where individuals are far more ill. So the preparations have to be very, very different. So I think the journals are comfortable with publishing data that changes as long as they date those publications. I think the greater issue is for the models that people are developing. They have to be dynamic and not static.
Okay, just an extension to this talk. There are also quite a lot of treatment options currently being suggested in these publications and used, but they are usually not based on randomized controlled trials, which is of course very unrealistic to think that you can do it just like that in a couple of days. Organize a treatment, but aren't we sometimes giving the wrong message to the people? If I see that in one country ICUs can use certain medications or not according to the evidence is interpreted, and sometimes in one hospital some departments are starting with a medicine and the others are stopping. Because nothing is yet properly shown to have any effect. How is JAMA's position in these things? I mean, is it the same answer that you gave to my first question, or do you have another magic response to that?
Well, this is without doubt the most complicated clinical and scientific issue that are occurring simultaneously. You have very ill patients with ARDS. You know the standard treatment, ESICM, SCM have put out wonderful guidelines that were just updated. And so I think that approach is standard. It's modified, but the role of antivirals, the role of steroids, some of the other drugs, chloroquine has been mentioned, remain hotly debated. The greatest concern is if all of those drugs are used, will you then not be able at the end of this pandemic understand what worked and what didn't work?
Yeah.
And I think that's a huge issue for the critical care community. Andrew Khalil wrote something for us, a few days ago, just raising enormous concern about using everything in every patient. And then at the end, like occurred with Ebola, not knowing what worked and didn't work. On the other hand, you have patients who are dying. I fully recognize that. And you have individuals' obligations to those patients. What Andrew raises is, though, it's possible that some of those treatments that may not work may also do harm. And so I think that's the tension that every clinical intensivist, or if the patient isn't in the intensive care unit, has to balance. I would hope there would be room for high quality clinical trials. There was one obviously published in NEJM that showed no difference. We're reviewing another. Part of the struggle in both of them, both of these studies, they're really not major outcomes, they're wellness outcomes, they're not mortality outcomes. And in addition, in both of those two studies, many other treatments were used. So it really doesn't have true control groups. There's just tension, and I think it's a real struggle for the research community and the clinical community.
Okay, just a last question. I mean, if we look now, it took a crisis to trigger open access for the journals, including JAMA, but also the other journals have done that. What would be the ideal world? Is it not good to have open access also in the future? What do you think about that?
That's a longer conversation. I would say the resources that we've needed to put into our effort to publish these articles quickly, to create podcasts, to create live stream events, that requires resources. And it's very unclear to me how we generate those resources in the traditional or the simple open access model. It's simply unclear. I think there are times when undoubtedly, as we are with this pandemic, all articles and publications should be immediately free. But this has come at huge intellectual and financial cost for us, which we have the resources to do it. But scientific publication is very different than it was in the past. So every high quality journal needs to develop a digital strategy, a social media strategy, and begin to present content in new and creative ways. And there's legitimate expenses related to that evolution of communication.
Okay, Howard, thank you very much. It was very nice to host you here on the webinar, and I think we can go on with Derek now. And let me... I'm having... Okay. I would like now to invite the next speaker, Professor Derek Angus, and he's a distinguished professor and Mitchell P. Fink Endowed Chair, Critical Care Medicine at the University of Pittsburgh School of Medicine. He is also the physician director of the UPMC ICU Service Center, responsible for critical care services across the 40-plus hospital system. Professor Angus's research interests include translational, clinical, and health services research in the field of sepsis, pneumonia, and multi-system organ failure, as well as optimal critical care delivery. He is also critical care editor for JAMA. Derek, please.
Joseph, thank you very much. First of all, I'll just check that you can hear me.
Yes, can hear you good.
So, first of all, thank you, Joseph, to you and to ESICM for putting on this incredible webinar that's been running all day. And I think, like Howard, I would echo the sentiments from our position in the US and at JAMA about everything that has been happening in Europe, and how just as China gave the rest of the world a little bit of a lead time, so things have been unfolding in Europe a little bit ahead of the US. And while now it's true that we're really seeing an explosion of cases, in particular in New York, I think that if the United States does come out of this with some sort of sparing of cities and other places, it's in part because we got a little bit more on board with initiatives such as social distancing, in part because we saw what we were going through. And we saw what you were going through, not only because of what came through in the newspapers, but also because somehow miraculously you were finding time to write papers and send them to us in the midst of all that you were doing as you were caring for patients. And that in a way segues to what I want to talk about, which is this issue of, while we're doing everything we can, how can we also try to learn as fast as possible? Howard alluded to the fact that I have a viewpoint that's coming out in a couple of days, which is listed here at the bottom of the slide, optimizing the trade-off between learning and doing in a pandemic. And this viewpoint is my reflection on this tension between learning and doing. One can see that really these are two compelling priorities. We totally want to take care of the patient. It's right in front of us that we have a patient who's acutely ill, yet we also want to learn something. As you just pointed out, Joseph, in your question to Howard, we want to try to work out whether we can test the drug. And the whole world saw this play out during the White House press conference just a few days ago, where you could see President Trump and Tony Fauci both struggling with whether it would be useful to simply put hydroxychloroquine into the arms of clinicians to prescribe to patients because there was a hunch that it could work, or whether we still need to take the time to do randomized clinical trials. And the struggle there was because it was really being framed as a binary choice. What do we do first? Do we try to learn first, or do we try to do first? And of course, both of these choices are framed under huge uncertainty. Now, the interesting thing about this is it might even feel like a familiar problem, because this is actually something that's been written about for decades, and it's actually one of nature's oldest problems. It's even the same problem that a tree root system faces when roots are searching to stay in one part of the soil and draw water from the narrow or the shallow part of the soil, or spend energy trying to grow deeper, which is costly to get to draw deeper from more moisture in deeper soil. This is something that was written about 20 odd years ago by the famous psychologist James March in what is to this day, I think, the most cited paper ever in organization science: Exploration and Exploitation in Organizations. And of course, to do something is to exploit existing knowledge or beliefs. We have a hunch that giving hydroxychloroquine might work, so why don't we just try it? And the problem is, while that could be helpful in the short run, it could be ruinous in the long run because we're not learning. Alternatively, someone might say, let's learn something, we need to explore. And that is risky in the short run, but essential in the long run. And of course, the issue is, in any situation where there's uncertainty, the bad news is we have to do both. We have to do both simultaneously. It is a single intertwined endeavor. And so the trick is finding the right balance or trade-off where patients get the best possible outcomes, but where knowledge about new treatments gained and are gained and disseminated as fast as possible. And if you were wondering about whether these were two separate things, in the world of artificial intelligence, for example, it's one mathematical problem. It's not two separate endeavors. It's a central tenet of reinforcement learning and Markov decision processes, multi-arm bandits, and so forth. It's one mathematical problem. But in medicine, we have divided them. In medicine, we do the doing in this enterprise called clinical practice. And in learning is passed off to a separate thing called clinical research. Now, the reasons for that divide are things like the Belmont report, and I'm not saying that they weren't smart reasons, but the consequence is that we've created entirely separate organizations. We have hospitals for the doing, we have universities for the learning. We have separate cultures, separate people, even the funding. The National Health Service funds the care of patients, but then the MRC funds the research. The procedures are different, and then the goals of the people who do those things are separate. No one is actually charged with the joint goal of optimizing the trade-off. What is the most efficient way to simultaneously do and learn? Now, of course, one could sit back and say, well, wait a minute, that's always true. And I would say it is. This has been a problem sitting in the background for medicine for decades, but it comes into sharp focus during a pandemic. So how do we learn? Well, in the toolkit of learning, the randomized trial, as you alluded to, Joseph, that's the workhorse for learning. But you can immediately see that there are three major challenges when we try to roll this out in this COVID-19 pandemic. First of all, randomization is incredibly uncomfortable. The physician at the bedside feels 100% responsible for the patient in front of them and for the outcome of that patient, and they feel the consequences are immediate. On the other hand, when they hear about a trial, while they might theoretically understand that the trial is important, they're not clear about how it would help the patient if, for example, they were randomized to placebo. They don't feel as responsible for the research, and the long-term consequences of a trial that might get published years from now feel remote and abstract. The second big problem is that RCTs are cumbersome. They're slow to start. It takes a while to write them, to get them funded and so forth, and then they are intrusive to execute. In the midst of trying to take care of the patient, there's not time for someone to come in and do the consenting or draw the bloods or call down to the pharmacy to get a placebo and so forth. And then the third problem is, even if people were ready to randomize, and even if people were bringing trials to the bedside that were simple to do, what trials? There is no single voice from the clinical research enterprise. It is worldwide chaos. There is now a website for COVID-19 trials, and as of an hour ago, there were 351 registered trials. Which of the 351 trials should the patient be enrolled in? It is complete chaos. The pharmaceutical companies are standing on each other's heads to push their trials. The funding agencies are all trying to work out what their priorities are. It is a worldwide pandemic, but most funding agencies are funding regionally within their own region. What's the solution? Well, there's no easy solution. And I'm not saying that I know how to solve this all overnight. It would be best if we did actually have one large integrated organization that took responsibility for both pieces of the puzzle. But since we don't have that, we need the clinical research enterprise to engage in activities that leans in towards the realities of clinical care. Number one, make randomization more comfortable. Use, for example, study arms with multiple arms where only one is controlled, so a smaller proportion of patients are not getting some sort of active therapy that could help. Number two, try to use adaptations in the design so that as soon as you can learn about a poorly performing drug, you don't need to wait with people going into the bad arm for months or years. You drop the poorly performing arms as fast as possible. In that way, clinicians can feel like the answer is more immediate and more relevant to what they're trying to do with their patient. The second is make entry into clinical trials one-stop shopping. Simplify the interface between clinical practice and clinical research, such as using master protocols, standard enter criteria, essentially trying to combine these trials and study questions into one research program. And then the third is it's time for researchers to consider that well-developed sacred cows of research help get the perfect study done. But the perfect study that no one does is a terrible study. We cannot let perfection be the enemy of the good. So, for example, placebo is a principle of many RCTs, but it might be overrated in a pandemic. There might still be strategies to have rigor in the design without blinding. And sometimes placebo doesn't even blind anyway. And if you start having multiple arms, you can't have lots of placebos. It just becomes an incredible burden. But if people are locked into the idea that they do a placebo-controlled trial, they are not leaning in to the realities of the clinical care enterprise. So, for example, a trial I'm involved in is the REMAP-CAT trial. totally, I know this one well because I'm involved in it, but it's similar for some other designs that are being developed at the WHO and elsewhere. This particular design wants to randomize to numerous choices within antivirals, extended macrolides, corticosteroids, and different immunomodulators. And you can see in this schematic that there's actually several arms within several domains. It's all under this adaptive platform trial design. The patients are randomized simultaneously within all of these groups, such that it ends up being that there are 72 recipes, of which only one has no active ingredient. So in other words, over 98% of the patients in this trial are still getting active therapy. Primary outcome is ICU-free days, and it's capable of updating the randomization as soon as weekly and then sending back the new randomization so that you're dropping the poorly performed arms. What would I ask of the clinical practice enterprise? I would ask less. The clinical practice enterprise is already swamped. For places such as in the United States, where the whole healthcare system runs in the EHR, it could definitely think about helping to nest or embed research procedures inside the electronic health record so that, for example, clinical research coordinators don't need to also put on PPE to go into the room. Try to have as much be handled electronically as possible. I think everywhere physicians could ask themselves, do they really embrace how uncertain we are about individual therapies? So for example, if you did two hospitals and they both said, oh yeah, we have equipoise. In one hospital, it's because 50 of the doctors are sure that a drug works, and the other 50 say, oh no, that's a terrible drug. That in theory looks like they're in equipoise. At the other hospital, all 100 doctors have really thought about things and recognize, yeah, it's 50-50 that the drug works. You can imagine that doing a trial at the second hospital will be a lot easier. And then finally, physicians could definitely have a role to play in enrollment and informed consent, and that means trying to learn about the potential trials, reflect on uncertainty, and then try to communicate wisely to their patients. So in conclusion, this pandemic forces us to do two things simultaneously: do and learn. These activities are intertwined. We must learn while doing. And this trade-off is an old one that unfortunately requires an integrated effort. Unfortunately, in medicine, we've actually been separating practice from research, and that's coming back to burn us. The two enterprises must lean into each other using learning designs that accommodate doing at the same time. And I'll leave you with one thought. President Trump and Tony Fauci were wrestling with this tension between learning and doing around whether to give quinine-based malarial drugs to viral pneumonia. JAMA already published a paper on whether quinine-based drugs would help viral pneumonia, and the answer was they weren't sure. They published that paper in 1919. It is scary to think that 100 years later, we are still not able to learn, and we're still asking the same questions. Now is not the time to fight alone. We must find ways for clinicians and researchers to join together. Thanks.
Thank you very much, Derek. I think if I need to ask one question to you, it will be very close to what I have asked to Howard. If I look to our situation in my department, since the crisis has started, there is an inflation of requests for trials. And you look at them and you actually know that this trial will not achieve much because it's looking to such a small population which has a huge selection bias, and yet people do that. And you also mentioned about the remap cap, which is actually a very high tech, high class trial. And we usually don't have too much in between. And yet you mentioned also 351 trials either performed or on the way. Maybe on the way there are even more. How are we going to guarantee the quality? Because at the same time, we are throwing out messages. Maybe the messages we throw out, even with very high quality journals, are not the messages we would normally throw out if we had not been in the middle of the crisis. Can you comment on this?
Well, that's not a single question. That's a multi-part question. Let me tell you what we are trying to do at our institution, and we have the advantage that we are not yet drowning in cases, but we are very quickly trying to stand up the capacity to enroll in REMAP-CAP, because it is an adaptive platform trial and it's open label. And we're trying to nest it all inside our electronic healthcare system with open label randomization, and then bring other trials in on that same platform, so that the clinician just needs to go to a single place in the work record, and we will be doing the work behind the scenes of offering what drugs are available. We've already pulled many of these drugs off our formulary, where we've got a single committee trying to answer the phone and control the use of them, and we're going as fast as we can to flip into this learning platform. We hope to have that available by Friday, but that's hard. And we've had to create a committee just to wade through all the randomized trials that we're being asked to look at. I spoke to colleagues at Penn who are doing the same thing, and Tom Vanderpoel said they're doing the same thing in Amsterdam Medical Center. You can't have everyone pushing their own pet trial. You need to coordinate. As to the other piece, you're asking me the same question you asked Howard. Why would you publish an observational series when that would never have been published in the past? And the answer is, look at the timestamp. We're basically saying we're happy to share knowledge as best as we have it to help inform on what might even be worthwhile testing in a trial. But yes, I think we would say that just because JAMA said 5 patients got convalescent serum, that does not mean that everyone should get convalescent serum. It means that someone has at least tried to use convalescent serum in COVID-19, and it comes with an editorial that specifically says, okay, what are all the next steps? And the next steps did not begin with suddenly give everyone convalescent serum. I think, I can't speak for all of JAMA and the editors, but I think we would endorse that there has to be a move towards trying to learn as fast as possible. And we don't want to abandon randomized trials at all, because randomization is still so important for causal inference. The only time it won't be important is if we get some unbelievable hallelujah drug. You drop this into drug and it's like some laseroid thing that converts a near dead person into perfect health. If someone finds that, then that's great. But that's so unlikely, and it's an overused phrase, but hope is not a strategy. And we can't just be hoping someone will have a miraculous antidote. Almost certainly, these drugs will be making small gains, and that will only be detectable in a randomized trial.
Okay, thank you very much, Derek. Thank you for joining us. And now we will move on to the next session. Thank you.
Thanks, Joseph.
I would start, ladies and gentlemen, to our last session, beginning with our next three speakers but I will not do that because unfortunately Andy Rhodes will not be able to join us tonight due to obvious reasons, of course. And that's why we have two speakers. The next two speakers are some of the co-authors of the recently published joint SCCM-ESICM Surviving Sepsis Campaign Guidelines on the management of critically ill adults with coronavirus disease, COVID-19. They will be speaking more about the guideline recommendations and answering your questions. I will first introduce you Dr. Walid Al-Hassani. He is Associate Professor of Medicine and Health Research Methodology, Evidence and Impact at McMaster University, Hamilton, Canada. He is a consultant intensivist and gastroenterologist at St. Joseph's Healthcare Hospital, again in Hamilton, Canada. Dr. Al-Hassani has led several international clinical practice guidelines, including the Surviving Sepsis Campaign Guidelines, for which he was the methodological chair. Walid, the floor is yours.
Joseph, thank you so much for the kind introduction. It's a great pleasure to be here today. These are my disclosures. I am the chair of the guide group and a member of the grade working group. Before we start diving into the guidelines, I want to acknowledge my wonderful colleagues who did a phenomenal effort to make this guideline in a very short period of time. I also would like to thank my colleague, Dr. Kim Lewis, who is covering me now while I'm on call so I can be with you here. So before we start diving into the recommendations, I want to spend a few slides on the methodology behind the development of the guidelines. As we all know, the guidelines is as credible as its methodology. There are similar approaches to previous guidelines. However, we used rapid approaches in terms of conducting the systematic reviews. So we started by formulating the PICO questions. We had more than 50 questions that the panel had prioritized as important recommendations or questions for the management of COVID-19 patients in the critical care environment. We conducted the systematic review. So we had a systematic review team who searched the literature, identifying relevant evidence. The evidence could be either direct from COVID-19 literature. As you can imagine, there isn't much of high quality out there yet, just because of the recent onset of the disease. However, we also relied on indirect evidence from ARDS, other coronaviruses, and shock population. We did assess the quality of evidence and summarize it, and the idea was to generate evidence profiles. These evidence profiles were passed to the panel, and we discussed it back and forth until we generated the recommendation. So we used the grade approach. However, the guideline will be a living guideline. So if there is new evidence that gets published, these recommendations will be updated as needed, or even new recommendations will be formed as new evidence emerges. Also, I'd like to spend a few slides just talking about the recommendations and what are the implications of different recommendations. Obviously, if the desirable consequences outweighs the undesirable consequences, you will end up with the slam dunk, strong recommendation. Everybody should follow this recommendation. However, most of the time, the desirable consequences and the undesirable consequences, the distinction between both or the balance is not very clear. So in these scenarios, we issue a weak recommendation or a suggestion. And it's important to know that there are different implications, and that's crucial for the interpretation of the recommendation that we're going to talk about. So for patients, the most important key stakeholder, a strong recommendation means that almost everybody would want to use or follow the recommended course of action, and only the minority would not. As opposed to a weak recommendation where a majority of individuals would say, yeah, sure, thank you, we'll follow this. But there would be many who say, no, we don't want to follow this course of action. So a clear distinction between a strong and a weak recommendation. Similarly, for clinicians, a strong recommendations mean you must follow it, or unless there is a really good reason not to, as opposed to a weak recommendation where different choices could differ based on the context, the patient values or preferences, and other things like resources. For policymakers, the third key stakeholder, a strong recommendation most of the time could be implemented as a policy. However, a weak recommendation does not mandate a policy, and policies will differ likely between institutions. So it's important to know the differences between a strong and weak recommendation. Now, having this in mind, we did classify the guideline into several sections. The first one is on infection control. Due to time limitations, we will not be able to go through every single recommendation. So we picked probably the most important or the most controversial ones to discuss. So the infection control recommendation were based on the risk of the procedure, whether the procedure is aerosolizing or not, what kind of measures healthcare workers should take. There are excellent guidance in WHO and CDC, so we did not want to reinvent the wheel, and we focused on things like surgical masks versus respirator and whether we should be using negative pressure room. Other details can be found in WHO and CDC, and there is no reason for us to reinvent the wheel there. We did look at systematic reviews to summarize the aerosol generating procedures and what's out there, and the most recent systematic review, as you can imagine, have found that intubation, manipulation of the BiPAP mask, performing CPR, tracheostomy, all these procedures are high risk and associated with increased risk of disease transmission and aerosolization. We're trying to make the guideline as much as possible based on evidence, and also incorporating the expertise from colleagues who have dealt with COVID-19. The first recommendation is a strong recommendation. In situations when healthcare workers are performing aerosol generating procedures, we recommend using a fitted respirator mask that is known as N95 in North America, but elsewhere FFP2 or FFP3 or equivalent, as compared to surgical masks. So that's a best practice statement, and it means that almost everybody should follow this recommendation. However, if you look at situations where the patient is ventilated and people are providing usual care or performing a non-aerosolizing procedure, then we made a suggestion to use surgical or medical masks as opposed to respirator masks. And this was based on our summary of the literature. There isn't direct evidence from COVID-19, so we relied on previous viral infections and previous RCTs. And it seems that when you summarize all the trials together, there are, I think, 4 or 5 of them out there. It doesn't, the N95 mask does not seem to offer more benefit in terms of lab-confirmed influenza infection or respiratory infections or influenza-like illnesses. Having said that, the confidence interval is wide, so there is some uncertainty there. Therefore, we ended up with a conditional or a weak recommendation. The next important piece that I think we should discuss, I'm not going to go through the other infection control recommendations. People can refer to it, or we can talk about them in the discussion afterwards, but oxygen targets, and we try to incorporate the most recent evidence. We believe that oxygen targets has a U-shaped curve in which very low oxygen or very high oxygen levels could be harmful to patients. So we issued a strong recommendation based on recent systematic review and meta-analysis of literature suggesting that the higher the oxygen level, the more likely of harm, and oxygen saturation of 96% was the reasonable threshold there. We also issued a weak recommendation or a suggestion to initiate oxygen therapy for SATs that are less than 92%. But a strong recommendation when the oxygen saturation is less than 90%. Obviously, these recommendations do not apply to patients with chronic obstructive pulmonary disease or chronic hypoxia on home oxygen. So we're talking about the rest of the patients. Again, I'm not going to go through this in detail, but this is the meta-regression from the recent publication showing that the higher the separation in oxygen saturation between the intervention arms, there is a linear association with increased risk of death. Okay, now the more controversial areas is, okay, so if the patient is not tolerating oxygen by face mask, what should we be doing? Again, you will notice there is a lot of weak recommendations here because we really are not certain about the interventions here. Having said that, we issued a suggestion to use high flow nasal cannula over conventional oxygen therapy. We still don't know if high flow nasal cannula, generate aerosols and is bad for healthcare workers. More studies are needed, but we took that into consideration. But because the indirect evidence suggests that high flow nasal cannula may be beneficial in some patients with hypoxemia, we favored using that over just conventional oxygen therapy. Also, we favored using high flow nasal cannula over non-invasive ventilation because of the high failure rate in previous observational studies on viral pneumonias with non-invasive ventilation, also with a higher risk of aerosolization with non-invasive ventilation. However, and this might be one of the controversial recommendations, and the panel discussed this in details, we said in those situations, very specific situations where protection for healthcare workers is available and high flow nasal cannula has been in use or the patient doesn't tolerate it and there is no imminent need to intubate the patient at the moment, it seems reasonable to try non-invasive ventilation if the team feels comfortable. So we issued a week recommendation there with a caveat that absolutely you have to monitor the patient closely at short intervals. And we actually issued a best practice statement so that the only strong recommendation in this section was to monitor the patient and do not delay intubation. Helmet BiPAPs have been used frequently, especially in Europe. We don't have them, at least in Canada. We debated whether we should be issuing a recommendation given the lack of evidence on this area. We elected to not issue a recommendation for or against the use of helmet BiPAPs in patients with COVID-19. When it comes to endotracheal intubation, the team decides to intubate the patient. It has to be done by the most experienced person around, and this is to minimize the number of attempts, and also has to be done within the least number of people, so minimize the number of healthcare workers in the room. So that's a strong recommendation right there. We suggested using a videolaryngoscopy, because there is some evidence to suggest it increases the chances of success and failed intubation, but also theoretically it maximizes the distance between the operator and the patient and hopefully minimize exposure to aerosols. And this slide just summarizes what I have said. And again, you can see this in the Surviving Sepsis publication. I won't be able to go through it in detail. So the recommendations in green it corresponds to the strong recommendation. Yellow, which that means consider, it's a weak recommendation, so it's a suggestion for people. And red is don't do, and it's a highlight to alarm people to avoid delaying intubation or assess the patient. As you can see, multiple sites in this algorithm, we always make sure that clinicians assess the patient for the need of mechanical ventilation. So it's pretty obvious that, okay, you may not need to jump right away for intubation, but you have to be vigilant and observe the patient closely. For the management of ARDS, again, these recommendations only apply to patients with COVID-19 and acute respiratory distress syndrome. They don't apply to those with just pneumonia or just respiratory failure. And again, similar to other disease contexts with ARDS, we felt that we should still follow the protective lung ventilation, so low tidal volumes, and targeting plateau pressures less than 30. And we also made a weak recommendation to start higher PEEP strategy over lower PEEP strategy, obviously in those who are PEEP responders. And we also suggested using conservative fluid strategy and avoid flooding those patients with fluids. Prone ventilation, we also made a weak recommendation or a suggestion to prone patients with moderate to severe ARDS from COVID-19 for at least 12 hours, because we know less than 12 hours, it probably doesn't work. The other rescue therapy is neuromuscular blockade, and we issued a suggestion or a weak recommendation to use intermittent boluses of neuromuscular blockade as needed over using a continuous infusion. So in most situations, people would be able to get away with just using intermittent boluses, and this is based on the results of the recent ROSE trial. Having said that, we did issue a suggestion to use continuous infusion over boluses in certain scenarios. If there is persistent ventilator dysynchrony, despite multiple boluses, or if the patient requires deep ongoing sedation to facilitate ventilation, or they need proning, for example, or persistently high plateau pressures. In these situations, we felt it is not unreasonable to put the patient on a neuromuscular blockade infusion for up to 48 hours. I think I'll stop here. I'll hand over the slide to Dr. Laura Evans.
Yes, thank you very much, Walid. And the last speaker of the day is Dr. Laura Evans. She's Associate Professor at the Department of Medicine, Division of Pulmonary Critical Care and Sleep Medicine, and Director of Critical Care, Associate Medical Director at the University of Washington School of Medicine. A member of ESICM Council and Editorial Board of Critical Care Medicine, Laura is co-chair of the Surviving Sepsis Campaign International Guidelines for the Management of Severe Sepsis and Septic Shock, and member of the campaign's steering committee. Laura, we can't hear you very much.
That's because I forgot to unmute myself.
Okay, perfect.
Apologies for that. Thank you. I was thanking you, Joseph, for the introduction, and ESICM for hosting this wonderful webinar. And thanks to Walid for being a fantastic methodology chair. And I do want to recognize that we miss having Andy Rhodes here for this, but we'll do our best in his absence while he's busy taking care of patients in London. I'm going to pick up from Walid where he left off in the middle of the ARDS section, recommendations from this most recent guideline. And I'm going to take you through our recommendations around corticosteroids. And we broke the questions of corticosteroids down into two different components. One is about the use of corticosteroids in ARDS. And most of the evidence informing our suggestion around corticosteroids and the use of ARDS caused by COVID-19 comes from indirect evidence of steroid use in ARDS as a larger population. And here I show you a forest plot, which shows that there is a slight favor of corticosteroid use on mortality outcomes in ARDS. And that's informed by 7 clinical trials over a period of time from 2007 to 2020. Similarly, when you look at the same data about steroids and ARDS, again, this is indirect data. This is not COVID-19 related ARDS or even viral causes of ARDS, but ARDS taken as a whole. You can see that there's the signal that favors corticosteroids around duration of mechanical ventilation. However, when you get to looking at fewer number of studies, and these are all observational studies, not randomized controlled trials, of steroids for the treatment of ARDS caused by viral infections, you can see that point estimate of corticosteroids mortality spans 1, with the point estimate actually slightly favoring control. Again, these are all observational studies, not randomized controlled trials. There is one piece of direct evidence from COVID-19 pneumonia that was recently published in JAMA Internal Medicine just within the last couple of weeks, of a retrospective observational study of 201 patients with COVID-19 ARDS, and they received either methylprednisolone or no methylprednisolone, again, non-randomized. But you can see that there was a very significant survival benefit in the patients who received methylprednisolone. Again, this is not causally provative, but an association of improved mortality in those who got methylprednisolone. So when the panel put all of this information together, we came across with a suggestion or a weak recommendation to suggest the use of systemic corticosteroids over not using corticosteroids in adults with COVID-19 and ARDS. It's worth remarking, however, what you can read on the lower portion of the screen is that the majority of the panel supported this. However, this is informed by very low quality of evidence, and some experts on the panel preferred not to issue a recommendation until higher quality direct evidence would be available. The second part of the question was about steroid use in COVID-19 for patients with severe illness, but not with ARDS. So we broke that down into steroids with viral pneumonia. And you can see here in the forest plot, this is all available in the supplementary data from the guidelines themselves. We looked at studies from influenza, and we looked at studies caused by other severe coronaviruses such as SARS and MERS. And you can see down at the bottom of the slide, the figure on the slide, that the point estimate is not in favor of giving corticosteroids. So there was an association, the point estimate of increased mortality compared to control from corticosteroids for steroids for viral pneumonia. So the panel put that together to say for mechanically ventilated adults with COVID-19 and respiratory failure without ARDS, we suggest against the routine use of systemic corticosteroids. I'll summarize briefly some of the recommendations around ARDS that Walid started and I took over from with this. And so again, just to reiterate, we're recommending lung protective ventilation strategies with tidal volumes of 4 to 8 mils per kilo and a plateau pressure target of less than 30, looking for evidence of bacterial infection or complications of COVID-19 pneumonia, targeting oxygen saturations between 92 and 96%, considering using a conservative fluid strategy. So these are weak recommendations or suggestions, considering the use of empiric antimicrobials. And in mild disease, the role of systemic corticosteroids is uncertain. Once you move into the more moderate to severe patient population with ARDS, consideration or a weak recommendation around use of higher PEEP, the use of neuromuscular blocking agents as boluses to facilitate achieving our ventilation targets, consideration of the recruitment maneuvers if they are PEEP responsive, prone ventilation for 12 to 16 hours, consideration of neuromuscular blocking agent infusion for up to 24 hours if the patient is prone, has a high plateau pressure, or has ventilator dysynchrony. We recommend against the use of staircase recruitment maneuvers. And as we already just discussed, consideration of a short course of systemic corticosteroids in this population with ARDS. And then as rescue therapy, again, the use of a neuromuscular blocking agent infusion, prone ventilation, consideration of a trial of inhaled nitric oxide and or other pulmonary vasodilator therapy with stopping it for resource utilization if they're not responding to it, and consideration of referral or the use of VV ECMO when appropriate, and following our local criteria for the consideration of ECMO in this population. We already saw a little bit of this on the last slide in the summative figure. However, you can see here that the panel recommended for mechanically ventilated adults with COVID-19 and respiratory failure a suggestion, a weak recommendation to use empiric antimicrobials compared to not using them. But of course, if this is chosen to be used by the treating team, they should assess daily for de-escalation, reevaluation of the duration of therapy and spectrum and coverage based on what that particular patient's microbiology results are and how that patient is doing clinically. We did look at several possible recommendations around therapeutic options, and you'll see we lumped 3 of them together here, which are all suggestions against routine use. So we suggest against the routine use of intravenous immunoglobulins. We suggest against the routine use of convalescent plasma, and we suggest against the routine use of combination lopinavir and ritonavir. And again, I think as you've probably heard throughout the course of the webcast today and through your own reading of the literature, this is an actively developing area. And as Walid mentioned earlier in this session, the intention is that this will be a living guideline and that these recommendations will be updated as new evidence emerges. Similarly, the panel looked at recommendations around specific antiviral therapies, the use of hydroxychloroquine, and the use of immunomodulatory agents, particularly around the use of cytokine storm that may be observed in COVID-19 patients. And at this time, the panel concluded that there was insufficient evidence to support recommendations around the use of any of these agents. Again, that may change as the evidence base evolves. I'll conclude by briefly going through the hemodynamic support section. As Walid already mentioned, we will not be going through each and every recommendation from the guideline. There are about 50 total. But I think we pulled out some of the most pertinent ones, which is for the acute resuscitation of adults with COVID-19 and shock. We have a weak recommendation, a suggestion to use a conservative over a liberal fluid strategy for resuscitation. But you'll note when you look at the evidence table here, again, available in the supplementary appendix, that this is based on very low certainty of the evidence. This recommendation will probably look familiar to people from the Surviving Sepsis Campaign recommendations for adults with sepsis and septic shock, which is a strong recommendation for the use of crystalloids over colloids in the acute resuscitation of adults with COVID-19 and shock. And we offer a weak recommendation or suggestion for the resuscitation with COVID-19 and shock for the use of buffer to balanced crystalloids over unbalanced crystalloids. And for hospital mortality, we offer a high certainty of evidence and a low certainty of evidence for the outcome of acute kidney injury in that population. And again, coming back briefly to steroids and the use of steroids for the purpose of shock reversal, the panel issued a weak recommendation or suggestion to use low-dose corticosteroids compared to no corticosteroids therapy for refractory shock with the goal of shock reversal. And again, the wording in the remark will look familiar to you from the Surviving Sepsis Campaign sepsis and septic shock guidelines, that a typical dose is 200 milligrams per day, either given as an infusion or via intermittent doses. I think I'll stop there in the interest of time. The full document is available on both the ESICM and SCCM websites, but I do want to take this moment to really offer a special thank you to all the guidelines panelists who participated in this rapid fire process. Their time and effort was most appreciated, similarly to our methodologists who pulled and reviewed an enormous body of literature in a very short period of time, as well as to SCCM and ESICM for the support, and to the journals for getting this out so quickly. And I think most importantly is a big thank you and recognition to our colleagues all around the world who are actively caring for patients in this pandemic and moving as fast as this pandemic is. So I'll stop there and say thanks so much for having us.
Thank you very much, Laura. Just a little issue. I know that you both are very late. We were also late during our Congress. You are on duty. Can you take a question, or would you like to leave? That both will be okay for us.
I think I can stay for 1 or 2 questions.
Okay. Well, I have one question here, although I'm also one of the co-authors, but I think it's still good to take this question. And the question is, we are talking about a new disease, and was it not quite challenging to make recommendations on that with the available data?
No.
I mean, any one of you can answer to that.
Okay. I'll go ahead and take a stab at it, and Walid can add on to it. I think certainly it was a challenge. As Walid mentioned, I think in the beginning of his presentation, most of the recommendations that we made are based on indirect data. So it's based on, the panel's best interpretation of how data from other clinical syndromes and other diseases caused by other coronaviruses such as SARS and MERS, or even influenza, which is not a coronavirus, how that may apply to this population. So I think you'll see that uncertainty that is caused by the indirectness of the evidence base reflected in the recommendations, and that we have overwhelmingly have weak recommendations because we don't know a lot about this disease and how it will evolve. And I think that's one of the huge benefits of doing this living guideline model, is that as this evolves and as we learn more, and as all of our colleagues around the world are contributing to this evidence base, we will be able to offer stronger recommendations that are based more on this particular clinical disease. Walid, I don't know what you would add to that.
Yeah, I think for the very reason that this is a new disease, an overwhelming disease, clinicians need guidance. Guidance does not have to be based on high quality evidence. If the evidence quality is high and people know what to do, people could argue that guidance is less needed. It's the problem when there is a lot of gray areas and uncertainties. So we combined 2 things. We combined searching for the best available evidence, whether it's direct or indirect, but also we had expert panel from different disciplines who have actually seen and managed a large volume of patients. And we came up with the best recommendations that we think is reasonable for the time being. Having said that, the guideline, as we mentioned at the beginning, are living guidelines. So if new evidence comes out that says, hey, you guys got this recommendation, the wrong direction, you probably should change it, then we'll definitely update the recommendations. And as Laura mentioned, most of the recommendations here are suggestions, so weak recommendations, so they don't imply certainty at all.
Okay, thank you very much for your answer and participation, and have a nice day, all of you. I think it's still day over there, and we are coming to the end of our marathon. I think it was a little bit longer marathon that we actually anticipated. Maurizio, can I give you the word to wrap it up so that I can also conclude after that?
Yes, I think we did a marathon and a little bit, but I would like to say, seeing all the feedback that we got, all the questions, how really everyone prepared this, it's being really an incredible experience. For me, in the tragedy of this pandemic, having seen how the scientific community and the clinical community got together in this, it's really warming my heart. And I would like to say that from having the idea to doing this webinar, it took probably, Joseph, I suspect, 10, 12 days of people working around the clock, our office, our technical support from SIM, ESICM. I'm not going to mention individuals, but really everyone that has been working on this. Our speakers that are very busy on the front line, our teams that are covering for us today so that we can be here for 7 hours, actually for 8 hours. I would like to thank everyone and the community, and of course also our sponsors. Thank you.
Thank you, Maurizio. I think everybody who participated will agree that we have heard from all our speakers that COVID-19 is not ready to disappear right away, and we can expect many more weeks of disruption. However, we have been given clear indicators and solid judgment to be able to continue to face the virus. And as we speak, more and more research is being carried out, and more we share and listen to each other, more we learn. I would like to say that we have to be confident that we can and we will win this battle. I would like to thank all the presenters, moderators, and guests for giving so much of their time when their workloads are already very full, and for sharing their knowledge and experience with us. I wish to thank you, the audience, until the last minutes in big numbers for joining us today and for your many questions and comments. I hope that you have found this as a valuable use of your time and are ready to continue your work with extra confidence and assurance. Finally, I want to acknowledge the many companies who have supported today's webinar and who clearly want to help all those affected by the virus, and in particular assist with sharing of knowledge and education that we are putting in place for the benefit of our intensive care community. I would like to wish you all good evening, good morning, or good day wherever you are in the world. Thank you very much.